Good morning, everyone.
Hi, good day.
Good day. Welcome.
Yep.
Welcome.
Yeah,
Excellent.
it is way past 6 in the evening here.
Oh, really already. Very good. Very good. Excellent. And then let me just get so Dr. Perumal, can you hear me?
Yeah, I can hear you.
Oh, great. Excellent. Well, excellent. So, and Dr. Rajendran is here. The second presentation there.
I do see him as well, yeah.
You did see him, did you?
Yeah, I do see him. He's going under the name of Shiva Kumaran.
Okay. Is it SHI? Is it? Oh, okay.
Yeah,
Good. Excellent. I got it. Excellent.
Shiva Kumaran is
Thank you. Good.
Hi, sorry, I am Shivakumaran Rajendran. Can you hear me?
Yes, I can hear you clearly. Welcome, Shiva.
Thank you.
Excellent. So, Dr. Perumal, what I will do is you have got 15 minutes for both the presentation and the questions. And I will give you a gentle notice at about 12 minutes. Is that okay? Great. So, good morning. Welcome, everyone, to the World Neurosurgery Webinar Conference 2021. This is the second World Neurosurgery Webinar Conference. We had our first one last year. However, this is a continuation of the neurosurgery conference on the internet, which was actually started back in 2005. So we had anticipated in some way how things were, and so this is in fact our 11th conference. So I think we are going to have more of these, and I think we need to make the most of these opportunities. In terms of few housekeeping, I'm going to apart from the speaker, if everyone can please keep your microphone mute, that will make life easy for the speaker, without any interruptions, because any interruptions does make it difficult for a speaker to talk. And the second thing is I'm going to put a link to the form that you need to fill to get your certificates. This certificate is going to be, I'm going to send a certificate. You can put how many hours you have been and your name. So that way, I appreciate that that will be flexible for you, and hopefully that will acknowledge that you have been there and how many hours you have spent. In many centers nowadays, 1 hour spent is given 1 CME by your own department. And in terms of the questions, conferences are about questions, and speakers have put together their talks and they are eager for questions. So it doesn't matter what questions, small, big, large, fat, tall, it doesn't matter what questions. There's nothing called a wrong question. So please feel free to be part of this meeting. I really want you to feel that you are not spectators, the participants. You are just as if it were you are in a coffee room talking to the presenter. So please put your questions on the chat box. Time permitting, I will bring the mic to you. Otherwise, I will read the questions out. So without further ado, I shall invite Dr. Vinod Varaya Perumal from Malaysia to give his team's talk about ventricular subgaleal shunt for temporary CSF diversion in treating pediatric infective hydrocephalus, a single center experience and review. Dr. Perumal, welcome, and do you want to share your presentation? Thank you.
Hi, can
Hello.
you hear me, Dr. Naren?
I can hear you. Yeah.
Yeah. But I should be able to share my screen, right?
Yeah, you should be.
Yeah, but it's saying only the host can share the screen.
Okay.
Okay, then I can share it now.
That's great. Excellent. Thanks.
All right. Can you see my screen?
It's coming on. So fine.
All right. Sure.
Brilliant. Excellent. Well done.
All right. Okay.
Well done.
First of all, thank you, Dr. Naren, and as the host, and also to all the other moderators for giving me the privilege to be here today. So I would, without any further ado, to start. So it's to be part of a research surf. And my topic today actually relates to the theme of the conference itself. It's to improve outcomes, output, and cost. So I'm Dr. Vinod Varaya Perumal. I'm from the Department of Surgery of Sabah Women and Children Hospital in Malaysia. So my topic today will be ventricular subgaleal shunt, or commonly known as VSGS, for temporary CSF diversion in treating pediatric infective hydrocephalus. It's actually a single center experience and review of how we started using VSGS and how we came over the years in pediatric patients for infective hydrocephalus. So to begin with, hydrocephalus in our state, in Sabah, is actually often caused by central nervous system infections. Statistics still show that TB is actually a major disease in Asia, especially in our side of Asia, which is Southeast Asia. And in Malaysia, this is still active, mainly due to the presence of illegal immigrants who are not vaccinated. It's a part of our national vaccination program to get Malaysians vaccinated, but there are illegal immigrants influx actually causing a rise in this disease again. And our early treatment choices for infective hydrocephalus is mainly to be aimed at preserving the cerebral perfusion by reducing ICP, address the infection, and to prevent ischemia or any other secondary brain injuries. So the main objective that prompted us to do this research is to analyze the role of VSGS for stabilization of CSF dynamics, to what is the best method to address the infection, what needs to be done to wean off temporary CSF diversion, what needs to be done to prevent unnecessary repeated surgeries, and what needs to be done to prep the intracranial cavity for a permanent shunt once the infection settles. So as you can see, my main aim or idea here is actually to popularize VSGS as a temporary CSF diversion technique. So before I go further into this research, let me show you some of the literature reviews which actually prompted us or guided us towards, started to use VSGS for infective cases. So the main first argument is, what is the optimal age for VSGS if a child is actually too young to be suited to be performed on VSGS? So this study actually shows that repeated ventricular taps, or EVD, actually exposes the intraventricular environment to the exterior. And subsequently, those cases with weak immune system are subjected to further risk of infection. Rate of infections and their complications are also lower when a VSGS is done compared to other, temporary diversion methods. This is mainly because compared to EVD, which is considered an indwelling catheter, a VSGS is actually maintaining a closed system. So, and then next you see that VSGS is also, I can safely say that there's not much of prerequisites needed, which is in contrary to a VP shunt. You need to have a presence of a mature immune system. You need to have a good absorption capacity of the abdomen. You need a good thickness of the subcutaneous tissue. So all this means that if the baby is actually, premature or, being born with a low birth weight, we actually cannot perform a VP shunt, and you need to wait until the child, is fit for the surgery. So looking at the next question, which always arises during our practice, is that what is the safety of this VSGS to be done in the presence of a CNS infection? Because everyone is okay to do an EVD because they said it's draining out the infection. But if using a closed diversion system, is it okay in the presence of infection? So what we are going to see is that this literature here shows that actually they can prevent shunt-related infections. VSGS can be used as a shunt alternative, which actually renders the patients free of shunt, at least temporarily, even in the presence of infection. So they have done cases as well. And there's also one case report which actually used VSGS for temporary treatment in a case of multiple recurrent shunt infection. So they actually managed to get a period of shunt-free infection. And then they, install antibiotics and everything. And later, and 2 months later, they managed to put in a VP shunt. And in their follow-up, the child was well. Then the next question is, how long can it be kept inside to? Because everyone knows that, with EVD, the risk of infection increases, quite drastically after day 11. So, this requires the need for revision surgeries, repeated change of EVDs to right and left. So, but the papers which with VSGS actually shows that it actually can be done and can be kept inside to up to 2.5 months. These are cases, but I'm sure there are instances where it's been kept longer. So this period actually is sufficient to manage and resolve issues that would render even the need for a permanent shunt or a permanent CSF diversion in majority of the patients. So with all these questions in our head, we actually went forward to look into our practice, the research idea. So what we did was a retrospective analysis of all our pediatric meningitis patients complicated with hydrocephalus in whom we did VSGS. So based on our center's practice guideline, everyone who has a VSGS will be reviewed by day 60 of VSGS. The main reason for this review is to decide if we can wean off or shall we convert it to a permanent VP shunt. So this is mainly guided by 2 things. First is actually being a CT scan, and second is the ventricular subgaleal pouch. So if the CT scan shows resolution of hydrocephalus and the pouch is actually collapsed, for those patients, we wean off the VSGS. And the next is if the CT scan shows persistent hydrocephalus and it's a potent pouch, in those cases, we convert them to a ventricular peritoneal shunt. So as you can see, in cases that actually require shunt, we actually will do a transcutaneous aseptic puncture of the CSF pouch to obtain specimen. But if you're going to wean off the specimen, we actually do not take the CSF. And the next question is we can also ask is that, can this be actually left behind? Can you leave a VSGS behind and not remove it? By right, this is a temporary measure. It should be removed. But we have seen cases where patients, have lost to follow up. They have defaulted, they have been in them, some of them even up to a year before, we managed to trace them back. So all these patients also would have received a minimum of 6 weeks of respective intravenous antibiotics, antivirals or anti-TB medication prior to the VP shunt procedure itself. So looking at the surgical technique of a ventricular subgaleal shunt, it's a standard Cotches point incision, like how we would put an EVD, a frontal ventriculostomy. So from that vertical 3 centimeter infection, I'll reach the pericranium, burr hole is made, dura is exposed, irrigated is a standard method. But the most important step in this surgical procedure will be a subgaleal dissection. So we need to identify the loose areolar connective tissue layer. And then next is to make sure a blunt dissection is done. Usually you can achieve this by using a mesodermal scissors. So just put it in and open up, slowly to separate the layers. There shouldn't be any bleeding because this is an avascular plane. So usually to the right and to the left, towards the temporal and to the opposite side of the frontal, I'll go 5 cm each. And anteriorly, I'll try to keep it as minimal as possible because I do not want to extend beyond the hairline. This will be cosmetically disfiguring for the patient. But possibly I would achieve, 7 or 8 cm. The idea is to get at least about 10 centimeters by 10 centimeters size of a pouch. This is considered a very potent pouch. So our area of focus will be frontal, parietal, and temporal. That's where the pouch is going to be. So next step is about ventriculostomy. So the total size of the tube that I usually use is about 15 centimeters. 5 centimeters is usually proximal catheter into the ventricle from the burr hole. And usually 10 cm is what I keep into the pouch. So standard, Duranic and then cauterization of the arachnoid empire and then a ventriculostomy. So upon, into the ventricle, standard literature says put a suture tacking adjacent to the burr hole. This is to prevent the tube slippage. But over the years, I've modified it and I've added another suture tacking, because most of the time that we have observed, the failure of ventricular subgaleal shunt happens because the tube migrates and tucks itself at the edges of the pouch. So this causes abscess. So, and also by tacking the distal end of the catheter adjacent to the burr hole itself, because when the patient needs to be weaned off ventricular subgaleal shunt, we usually do it under local anesthesia. So by just opening the wound in a small incision, I can actually remove both the suture tacking and remove the pouch, and the patient would not be undergoing discomfort to be exploration of the wound to find the distal catheter. So once it's done, we advise patients or the parents to make sure the pressure is avoided over the operative pouch site. And also during the procedure, we must always ensure to leave some of the CSF behind into the pouch to make sure the pouch doesn't collapse or closes early. This maintains a pouch. So what we saw in a patient, we managed to gather about total of 17 patients. The mean age is about 47 months. Out of this, 9 had TB, meningitis, 7 with bacterial meningitis, and 1 had viral meningitis, influenza type A. And then the mean duration of the VSGS left in situ was about 63 days. Even though I told you that our practice is to review by day 60 and remove, but we actually lost some patients to follow up. That's why, there were a few cases, we had up to 85 and 90 days. So that makes the mean, to be higher than 60 days. So next is that 11 patients required conversion of ventricular subgaleal shunt to permanent shunt, while 4 we managed to wean off VSGS. So the maximum failure rate we actually saw in younger age group of patients with a mean age of 31 months. And if you're looking at number of surgeries, VSGS helped a lot with reducing number of surgeries. We have 14 patients which are requiring only 2 surgeries. One is the insertion of VSGS itself, and another is either removal or needing to remove and convert it to a permanent shunt. So as you can see, only 1 patient, out of this total 17, 3 of them had complications. Only these 3 complicated patients with complication actually required more than 2 surgeries. One with a subgaleal hematoma into the pouch, and another one due to the overproduction of CSF causing a persistent tense pouch with CSF leak. I would explain these cases in my next slide. Okay, these are the 3 cases with complications. You can see the first case with a 7-month-old baby girl. Actually, all the 3 cases are cases of bacterial meningitis. First surgery was ventricular subgaleal shunt, complicated with a tense pouch due to overproduction. So this one, we proceeded straight away with removal of VSGS because the pouch could not sustain the output, and patient had to undergo EVD insertion. But eventually, patient ended up getting a VP shunt after 6 weeks, infections resolved. But the only problem is that the total number of surgeries needed was 6, because here in our center practice, we revised the EVD at every day 10. So that's what made it to, the total number of 6 surgeries. So the next patient you can see is 42 months old baby boy. For this child actually came in with infected VP shunt. What we did is that we removed the VP shunt and we inserted VSGS. But this patient was complicated with a hematoma in the subgaleal pouch much later of surgery. It wasn't an immediate complication. So we suspected maybe the child had a fall, that patient developed hematoma. So for this patient, because tapping of the pouch showed that there was no infection or risk.
Dr.
Yes?
Permar, you have got 3 minutes.
Yeah, sure.
I questions.
Yeah.
Sure. Thanks.
Yeah, sure. So, and then next case shows that it's a case of TENS VSGS pouch with raised ICP features. In this case, we actually remove VSGS and EVD with a total of 5 surgeries. So among the non-complication patients, like I already said, 4 patients we managed to wean off. So maximum failure in younger patient, weaning process was very good in bacterial meningitis. Shunt dependency was almost 100% in TB meningitis group. Hospital stay dramatically reduced in VSGS and doubled in EVD, 17 versus 32. So discussion is that here we need to know is that patient with infected VP shunt will also safely manage with VSGS while facing the intracranial cavity for reinsertion of VP shunt. So the physiological mechanism is still not very well known. What's the absorption capacity? Observation shows failure in significant high output patients. And then there's no necessity as the indwelling catheter is not in presence here. So as the conclusion, I can say that VSGS can be safely used for temporary diversion in infective patients due to reduced number of surgeries, reduced hospital stay, relatively safe environment while treating the infection, and prep the intracranial cavity for VP shunt insertion. So the dilemma is, like I said, we need to understand the physical mechanism. All this is for future research space of what we can do to improve VSGS. Thank you.
Thank you very much, Dr. Permar. Fantastic talk, and I'm delighted that you have had good outcomes with the ventricular subgaleal shunts. Certainly it does make sense in patients with infection where you don't probably want to put some foreign body like a access device or anything like that. You have got a few questions. I'm just going to quickly ask them. If you can quickly reply, and if you have further answer that you can always type in. So the first question is from Dr. Ala Marji. Can I ask what tricks do you use to prevent leakage of CSF around the tube and not causing subdural hygroma? And another question along that line, from leakage of CSF from the wound. Thanks.
Okay. All right. So I would go with the first thing. This is to prevent hygroma. So we actually do not get this at the early period, because at the early period, the intracranial pressure is actually high. So there's very less risk of a retrograde flow. Actually, there's actually flow into the pouch more than into it. So as the CSF flow stabilizes over the period of course of our observation, which is up to 60 days, what I ensure to do is that I try to make the nick of the dura as small as possible, just to allow the insertion of the tube. So try not to open the dura very big, just to facilitate only the tube. So this ensures there's minimal retrograde flow. And as for CSF leak, actually, I think if it's leaking, then the VSGS has failed, because this shows a TENS pouch. So a TENS pouch shows that the capacity of the VSGS pouch to absorb the fluid is not in par with the CSF output. These cases, usually I will convert it back to a EVD. Okay,
excellent. In terms of the incision, Dr. El Gamal, his suggestion is to use a flap incision. Do you have any comments on that? Thanks.
We have actually done that. We actually initially at the beginning, right, because there was always the question of converting it to a shunt. So because in my center, we are not a big fan of frontal shunt. So that's the reason we just started doing linear incision, because we will, no matter what, later on convert it to a Keen's point shunt. Initially, we started doing that to convert to frontal shunt. So that's over the years, we have moved to Keen's shunt. That's why we just do linear incisions.
The other question is, if there's a leak, what do you do? Do you put sutures and then you convert into EVD, or how would you put a suture and see whether the leak stops? That's another question from Dr. Ala Marji. Thanks.
Yeah, like I said, most of the time I ensure the closure is done by myself. So it's a proper running continuous sutures, and I make sure I close it in layers. So to my belief, if it leaks, it means the pouch has failed. It means the tension within the pouch is high.
Sure.
So in that way, even putting extra switches is not going to help. Usually I just convert them to EVD.
Okay, excellent. And the other question is from Dr. Parawat, whether you tap the subgaleal pouch if it is tense, I presume. Do you have any comments on that?
Yes, tapping of the subgaleal pouch is usually just to buy time for a revision surgery, but not as the ultimate goal of treatment.
And do you ever convert, and you already mentioned you go for the Keen's point, have you ever converted the ventricular catheter into a VP shunt, Dr. Pravat asks?
Yes, you mean you're asking VSGS converted into a VP shunt?
Yeah.
Yeah, that's what I said. In cases where I need to convert, I just remove the whole VSGS and I insert a new shunt system by the hole.
Okay, so you take the old ventricular catheter out.
Yeah, because our catheters, EVD catheter size is different from what fits our shunt dome here. It's for VP shunt is a much finer catheter.
Excellent. The next question is, what if subgaleal shunt gets blocked? As it is possible with infection, what will be your next step? So let's say that the ventricles are going up, your pouch is not increasing in size. What would you do then? It's from Dr. Srinivasan.
Yeah, so like I said, we have seen few reasons for blockage here. Most of it is migration of the distal tube to go and tuck itself at the edges of the pouch. So it causes early fibrosis or sometimes blood clots at the edges of the pouch itself. But by the content of CSF itself, if it's very pernicious and all that, if it gets blocked, these cases, I will eventually convert to EVD because I don't see a benefit of diversion if the ventricle sizes are increasing. We are not addressing the problem. So I would convert it to EVD.
Thanks. Thank you. Professor Schroeder, you have comments? Thank you.
Yeah. Good morning, everybody. So thanks for the interesting talk. So in infectious hydrocephalus, we are always happy if all this infectious CSF is coming out. And our colleagues from Cairo made an investigation to compare an external drainage with conservative antibiotic treatment with a group of patients where they had even a lavage. That means you have one catheter for inflow and one for outflow. And they found it very good if you rinse the system. Sometimes we even use an endoscope to rinse if we have an infection with a lot of infectious material. So that's why I was surprised that you use it for infectious hydrocephalus. So it's used for hemorrhagic hydrocephalus. That is, of course, a good indication. But in infectious, I would also always be a little bit concerned that I keep all this infectious material in and I want to have it out. Can you comment on that?
Yes, actually, Dr. Henry, actually, I would like to start with VSGS was initially started to be popularized for IVH in newborns, especially germinal matrix IVH and all that. But actually, if you can see during a few of my slides there, I've quoted some of my references. Those were the studies actually guided us to actually to start using VSGS in cases of infection, because we have got quite a number of quite prominent studies, published in either Acta Neurochirurgica, Child's Nervous System, which actually showed very good results. Some of them up to 2.5 months, and the repeated CSF shows they actually managed to clear infections. They managed to get a shunt-free period and finally reinsert the shunt once the infection settled. So that's what guided us towards it. Prior to that, even we were very skeptical, because that's the same argument. Something that's wrong inside, you should get it out, but this is maintaining it within the cavity. But we were ourselves surprised after reading all that. It actually did work for us.
Excellent.
Okay. Thank you.
Thank you. Particularly with TB, meningitis, we put VP shunt even when it's active TB disease. So that's brilliant. Well done. Fantastic talk, Dr. Perumal. Thanks for all the questions. Please keep the questions up because conferences are about questions. So now I've got the pleasure of inviting Dr. Sivakumaran Rajendran from Malaysia as well to give a talk on rare disappearing cerebral infarcts. Dr. Perumal, you should be able to share your presentation. Sorry, Dr. Perumal, would you, that's brilliant. Dr. Perumal, you should now be able to share your presentation.
Good evening. Can everyone hear me and see me?
Yes. If you want to make it maximum, that's great. Maximize your presentation. If you want to keep it as it is, that's fine. I will warn you in 12 minutes. Thank you, Dr. Sivakumar. Sivakumaran, please. Thanks.
Good evening, everybody, and Sairam. I'm Sivkumaran Rajendran, a medical officer in a Department of Neurosurgery, Sabah Spine Center and Hospital Queen Elizabeth, Sabah, Malaysia. So today I will be talking about a case study where title is a rare disappearing cerebral infarcts. I'm the main author and I was guided by my surgeon, Mr. Vinod. So the introduction is the cases of cerebral infarcts are bread and butter in neurosciences. The vanishing infarct is not a new term and it's been well described previously. Despite this, it remains under-recognized, especially among the young clinician and residents. This misleading finding often causes doctors to settle for a normal report of the imaging, and little effort is put into decoding the myth behind this. This is related to fogging phenomenon, where appearance of cortex which regains a near normal density following the infarcts. Okay, in my center, the case is the description B. The patient is a 63-year-old lady with underlying uncontrolled hypertension and diabetes mellitus, and also atrial fibrillation. So when she presented to emergency department, her BP is 186/110 and atrial fibrillation, heart rate ranging 130 to 150. She presented with acute onset of dysphagia and right-sided hemiplegia. And the initial treatment for the stroke, as per the stroke protocol, she was started on antiplatelet and also the atrial fibrillation was controlled by digoxin. Clinically, her GCS was E4, V2, M5, and she appeared confused and has expressive dysphagia. The central nervous system examination shows an upper motor neuron lesion findings, where right-sided hemiplegia with hypertonia and hyperreflexia. Frontal reflex showed positive Babinski response on the right, and cranial nerve examination revealed upper motor neuron type facial nerve on the left with a weak gag reflex. Otherwise, there is no abnormalities in her laboratory results. CT brain was done for her on the day 1 of infarct. That shows a left acute MCA infarct. I will show the scan in the next slide. And day 2 shows established or evident of left acute MCA territory infarct. However, on day 14, the disappearance of the hypodensity area at the infarct region with near normal appearance of the cortex. The CT was actually repeated as a baseline to rule out any hemorrhagic transformation prior to commencement of warfarin for the prophylaxis of atrial fibrillation. So this is the scan of the patient, where this is the first day where patient presented to the emergency department. This we can see the a bit of acute infarct at the MCA territory region. In day 3, it shows the well-demarcated area of infarct. Otherwise, both the scans doesn't show any obvious midline shift or edema, pre-lesional edema. However, the scan repeated on day 14 shows the CT brain shows the brain matter looks nearly normal at the other side compared to the previous scans. But patient's clinical condition and neurological status remain the same without improvement at day 14, although the scan shows a near normal CT brain. I also like to, there's a lot of articles and then journals were talked about this case. I would like to share about another case where this one is published in the American Academy of Neurology in July 25th, 2000. This one is about a 64-year-old man developed with acute vertigo, nausea, and vomiting. And the first day of the CT shows a subacute infarct in the left pica region. However, after 10 days, the patient came with complaining of facial numbness, and repeated CT also shows there is no evidence of previous infarct. It shows a near normal CT brain. And a follow-up CT scan performed on the 4-month later shows encephalomycia changes in the left pica region territory. This is also another example for the fogging phenomenon. So the fogging phenomenon, it's actually a not rare phenomenon per se. The incidence of it, it's up to 54% in serial imaging of cerebral infarct patients. And the mean time of this occurrence is 2 to 3 weeks after an infarct. It may be overlooked if the scan is performed during this period. So the basic pathophysiology of the fogging phenomenon, usually the infarct will present with perilesional edema with mass effect and area of divide of blood supply, which causes the neuronal death. and the edema and the pressure of mass defect gradually will resolve. And this is followed by the lipid-laden macrophages, which are the local scavengers in the brain of the ischemic area. Subsequently, capillary proliferation soon follows, and reperfusion of the affected area occurs, which made it look like a near normal brain cells, brain tissue. And the fogging is unlikely in large vessel occlusion owing to a poor collateral formation. And the diagnosis, the imaging diagnosis for confirmation of this diagnosis is not routinely done due to the cost and patient factor, and also it is avoidable. And the first imaging is a contrast enhanced CT, where the enhancement of the infarcted area can be seen due to blood-brain barrier disruption during the subacute phase. We also can do a T2 weighted MRI, which can delineate the pathological infarct zone. However, we are not most of the time done due to the cost factors and the patient factor. And as a conclusion, the term of fogging phenomenon and vanishing infarct should therefore be popularized among clinicians to prevent confusion or misdiagnosis of cerebral infarct, especially in the subacute period. The presentation of patient early after the onset of the stroke and rapid initiation of antiplatelet therapy could have contributed to this reversal of radiological infarct. However, there is no proper studies or paper about it. And often CT is enough to diagnose a cerebral infarct, but fogging phenomenon often leads to misreporting of what is presumed to be normal scan. As mentioned before, in large vessel occlusion, a reversal of flow is less likely to occur. It should also be noted that the reversal radiological imaging does not necessarily relate to the reversal in neurological deficit, because by pathophysiology there is already a neuronal death which can be reversed. And take-home message from this case is stroke remains a clinical diagnosis, and then the MRI must be interpreted with the stroke onset timing in mind, as MRI may be negative in subacute phase, and repeated imaging may be necessary to locate infarct territory in order to guide secondary prevention therapy, like a symptomatic carotid stenosis or for the posterior circulation disease. Thank you.
Thank you very much, Dr. Sivakumaran. That's an excellent talk, and certainly I found it very helpful. I have not known of this until I saw your abstract, so it's very useful to have this. Questions to Dr. Sivakumaran? Dr. Sivakumaran, I think the important thing is that in UK we have got a neuroradiologist, and they have a sharp eye, and then we do get MRI scans, and so but I can see where the confusions can come, and another point is that I have seen in patients where sometimes the other way around. On the CT scan, it looks like there are a lot of areas of infarction, areas of hypodensity. Actually, I have seen it all the way around the brain, and you think the prognosis is poor, and then that resolves. Whether that's same as your ghost infarctions, then that they disappear, or whether they are actually good brain that they had just edema, I don't know. Can I bring Professor Schroeder and Prof. Grotenius and Dr. Vince Giles to make any comments? Professor Schroeder, can I start with you, please?
Sorry, Naran, I was not with you. Can you repeat the question once more?
In terms of these ghost infarcts, have you seen it in your department? And when you have head injured patients, I have noticed that patients can have areas of hypodensity quite widespread. You initially think, oh, this looks very terrible scan, and then later on in the week that hypodensity all resolves. Yes, now I am wondering whether this is ghost infarct or whether it was edema that actually resolved, whether it's a good or bad prognosis. What's your thoughts?
Yeah. So what I have seen is that I think it's not an infarction. If you have really an infarction, there should be not a reversal. I have seen it sometimes that there was changes, for example, in aneurysm clipping, and we had some problems in the caudate nucleus. And I thought it is an infarct, and it went away completely. So I think the best way to make a diagnosis is diffusion-weighted imaging and MRI. And if you see there is a restriction, or you see clearly there is an infarct, then I think it should be an infarct. I think in a CT scan, we have several lesions which appear to be, or they look like an infarct, but they are actually not.
Thank you. That's very useful. So I think I take your point. I'm sure Dr. Sivakumaran will agree that if you see these areas of ghost, then you really need to get an MRI scan to be sure whether these were infarcts or not. Am I right, Dr. Sivakumaran? Did I get that right?
Yeah, I completely agree. But in our setting, sometimes MRI is not a luxury that we can afford all the time. Sure. Since we got lots of patients and only few centers are provided with the MRI, sometimes most of the time we not tend to do it. But in ideal situation, it would be better to do it, and maybe in far future we might get the luxury to do it.
Good. Professor Grottenhuis, do you have any comments, sir?
No, actually, I agree with what you mentioned and also what Henry Schroeder mentioned. But we have to realize that not everywhere an MRI scan is easily available. Mm-hmm. Of course, if we are really in doubt, and especially if you want to make any prognostic decisions, you have to have this diffusion-weighted image. You have to absolutely make that clear. And for example, brainstem infarctions are hardly impossible to see on CT scan because of the bone nearby. So this is, but what I see here is maybe these are either areas of non-hemorrhagic contusions or edema. But I have seen it certainly in the time of only CT. It's possible. So just be aware of it. That with only CT, it's hard to make any prognostic decision, and you should not do that. No. But I realize that MRI is not available so easily everywhere.
Thank you, Dr. Vince Giles. Professor Vince Giles, do you have any comments? This is slightly different from what Dr. Sivakumaran mentioned in terms of head injuries. We see these hypodensities that go away. Have you noticed it? Does it? What's your thoughts on that, Professor Giles, if you can hear me?
Yes, I can, Naren. Hello to all, and thank you very much. No, I can only agree with Mr. Grottenhuis and Henry Schroeder. I do remember cases of seeing it, and we were very concerned that it might be indication of hypoperfusion. And we actually did perform an MRI which did not show anything on the diffusion-weighted images, and prognosis was actually quite good. It's a recent case of severe head injury without any signs of larger contusions. So it does seem to happen, and the only way to sort of satisfy diagnosis is by MRI.
Yeah, absolutely. Just recently, last week I operated on a patient, a pediatric patient, and very severe head injury. And we did a MRI scan about 3 days later, which showed widespread but limited areas of signal changes. And then it was repeated a week later. And I thought 3 days is good enough, but a week later it was much more extensive, not catastrophically extensive, but extensive enough. So even doing the MRI at what point also is, at what point do you get prognostic MRIs in Aschaffenburg province?
Well, any MRI in an intensive care patient is obviously always is a big effort. And we have access to MRI sort of during the week without any bigger issue. At the weekends, it becomes a lot more problematic. But we do regularly perform MRI on intensive care patients, intubated patients. One of the disadvantages, of course, is that you have to consider that you have to then remove your intracranial pressure electrodes.
Mm-hmm. That's great. Thank you very much. Dr. Sivakumaran, well done. Very, very useful presentation. Can I please invite you to give your next presentation, which is on acute cervical traumatic spinal cord injuries, a single center review. Once again, I will warn you at 12 minutes. Thank you.
Sorry, give me a second. Okay. Can everybody see the slide?
Yes, we can. Yeah.
Oh, okay. So here we go again. I'm Sivakumaran Rajendran from Department of Neurosurgery, Sabah and Spine Center. So now I would like to talk about the acute cervical traumatic spinal cord injury. It's a single center review and it's done by me and then guided by my surgeon, Mr. Vinod. So traumatic spinal cord injury is one of the most feared injuries associated with road traffic accident worldwide, which leaves patients severely debilitated if not properly diagnosed and treated. Care and financial charges of patients with traumatic spinal cord injury often burdening to the family and also to the community. The basic management of spinal cord injury usually is a pharmacological agents or surgical intervention. And usually in pharmacological agents, we use a drug that improve the axonal conduction and block the sodium-potassium channel. As I show you a bit of a simple diagram where the healthy nerve tissue, the intact myelin potassium channels covered and there is a normal conduction. However, in the nerve damage, the conduction will be disrupted. So by using the potassium or sodium channel blockers, it can be treated. The potassium channel blocking conduction restore the functional recovery. And surgical intervention, usually we go for the decompression of the spinal cord in addition to the realignment and stabilization of the spine. An objective of this study is to identify the issues surrounding management of acute cervical traumatic spinal cord injury and issues surrounding outcome of the acute cervical spinal cord injury. And the method we use is any cervical spinal cord injury patient who were admitted in our department were included, and the data is collected and analyzed. All included patients received CT imaging within 12 hours and also MRI within 24 hours from the time of their admission. Patients with neurogenic and spinal shock were monitored in high dependency or intensive care unit as they are mostly considered unstable and need a very frequent check and then also to avoid other subsequent complication. An urgent decompressive laminectomy is performed with the patient with a canal stenosis and causing compression. Steroid therapy as the National Acute Spinal Cord Injury Studies NACIS-2 trial protocol was initiated if warranted. And subaxial cervical spine injury classification system or thoracolumbar injury classification system and severity score were used to guide for surgery, where both of it using the CT scan, MRI, also clinical condition of the patient to decide whether the patient can go for surgery or conservative management. And all patients receive neuro rehabilitation care throughout the admission. And due to the COVID pandemic, nation worldwide control order, a reduced number of road traffic accidents were observed, leading to low incidence of cervical spinal cord injury in year 2020. Usually per month, we might get around 3 to 4 patients. However, in this year, we only get 6 patients managed to able to get only 6 patients. And the mean age is of the patients are around 31 years old. And the mean length of the stay is 23 days. And all patients admitted to high dependency or intensive care unit. And polytrauma patient had a poorer Glasgow outcome score at discharge and higher ventilator dependency requiring tracheostomy. There is one mortality which is not directly related to the spinal cord injury, but instead patients succumb to secondary complication. And neurological recovery, we are based on the ASIA grading. And as we all know, ASIA grading A is give the poorer outcome and E always have a good outcome. So our neurological recovery in our patients were better in ASIA D patients, and ASIA C patients had a mixed pattern of recovery with 50% showing recovery, while another 50% had no recovery noted. This is a summary of our center review. So this one shows the spinal cord injury, which is a polytrauma patient and also isolated patient. So when we see the polytrauma patient first, they have a mortality rate. One patient is died. And also Glasgow outcome score is, there are patients with a poor Glasgow outcome score. And then also they are ventilator dependent. There are 2 patients are ventilator dependent. And there is a 2 patient with a spinal shock and 3 patients need a tracheostomy. With the isolated spine cases, there is no mortality. NGOS score is actually good, and they are not depending on the ventilator. And both the patient had a shock, and they are not ended up with a tracheostomy. And according to the ASIA grade, our patients are mostly fall in A, C, and D. There is no patient in a category B and E. And with the ASIA grade A patient, there is one patient with a mortality, and then 2 patients with a poor Glasgow outcome score, and then 2 patients are ventilated, and then both the 2 patients having a shock, and then there's a neurology recovery, not unable to achieve in 1 patient. And it's, as I said before, in ASIA grade 3, ASIA grade C, there's no mortality, and then there is a poor GCS recovery around 2 patient, and then good GO score with the 1 patient. And they are not ventilator dependent. There's a shock in 2 patients, and neurological recovery we're able to maintain with the 2 patients, and 2 patients unable to get the good neurological recovery. And ASIA grade D, there's no mortality, good Glasgow outcome score, and then they are not ventilated, and then also they have a very good neurological recovery. So in this, modernization has increased the number of vehicles on the road, which led to an abrupt increase in road traffic accidents. And timely management shows a promising outcome. So we need to identify the type of the injury and provide urgent care, which can reduce secondary complications. And pathophysiology of the spinal shock involves a very complicated cascade. And these processes start usually 4 hours till up to 2 months after initial injury, where the peaks are observed around 3 to 6 weeks. And the edema can last up to 2 weeks after the injury. Protocol from NARCISS-2 trial were accepted with the methylprednisolone loading dose 30 mg per kilo, followed by maintenance dose of 5.4 mg per kilo per hour for the subsequent 24 hours. And otherwise, patient sugar levels also need to be monitored closely. And surgical decompression via laminectomy remains a valid practice option for acute spinal cord injury with canal stenosis and cord compression. And surgical treatment of acute spinal cord injury study with the level 2B evidence supports an early decompressive surgery for improving functional recovery and following cervical spinal cord injury if performed within 8 hours of injury. And the recommendation for surgical decompression according to the modified Delphi processes are: there are strong preclinical evidence for biological benefit early surgical decompression in animal spinal cord injury models. It is recommended that surgical decompression of the injured spinal cord can be performed 24 hours when medically feasible. So it is also, we noted the patient come with polytrauma, and then also they might be unstable, where patient can be proceeded to the operation theater immediately. The optimal timing of surgical decompression, whether the surgery is indicated at all in patient with a central cord injury, remains unclear. There are clinical and neurological and functional benefits of early decompression of the spinal cord. And we also note that good outcome is rarely seen in a cervical traumatic spinal cord injury. And we conclude that rapid identification and prompt treatment will aid in faster recovery after cervical spinal cord injury and prevent secondary complication, which can lead to high morbidity. When the facet complex is not compromised, laminectomy is adequate for the decompression and no instrumentation is required. Judicious use of steroid therapy in a spinal cord injury patient can be proven beneficial. Clinicians should be aware of the wide spectrum associated condition which may present with the spinal cord injury, whether intra-abdominal injury or brain injury, and need to be addressed timely. Continuous research and beneficial to provide a global standardization approach for these patients will be needed. Thank you.
Thank you very much, Dr. Sivakumar. And once again, another excellent presentation. And you bring a couple of very important points. So first of all, I will take you through the questions and comments, then I'll come to my question. The first question is from Dr. Pashal Idas. What are the indications for steroid therapy in spinal cord injury? Does the actual benefits outweigh the risks? Do you have any comments on that? Thanks.
Sorry, I pardon your question?
What are the indications for steroid therapy in spinal cord injury and benefit versus risks? What's your thoughts on the benefits versus the risks?
Okay, usually we will start the steroid therapy for the patient with having a cord edema or cord contusion. So in these both patient, the steroid therapy will be helpful. However, the risk is usually with a high steroid, we might notice that the glucose might, the sugar of the patient will increase, and then we need to control it. However, gives a beneficial where we can, it is more beneficial where we can control the edema and buy time and prevent other worsening of the neurology. And the elevated sugar is always can be controlled in an acute setting with insulin, with the help of IVI insulin or ectropic subcut insulins.
Thanks, thank you. And Dr. Srinivasan, Rahul Srinivasan asks you, have you attempted close reduction in any of your patients? Thanks.
Yeah, 2 patients were tried with skull tongue prior to the internal fixations.
Okay. And then in terms of medical management to improve atonal conduction and block of sodium potassium channels, in terms of any medical management that you consider, any other medical management that you introduce for these patients?
Our center, we usually we usually go for the surgical intervention, where the medical one, we try to check their electrolytes like the potassium, sodium, and calcium. And then also we try we will optimize the blood parameters. And then also we'll go for the steroid trial, as is the NASIS 2, where our center is following.
Excellent. We have got Mr. Mario Ganau. He's a consultant neurosurgeon, spinal neurosurgeon at Oxford. Mr. Ganau, do you want to ask your questions and your comments? Thanks.
No, I just want to congratulate on the nice presentation for sure. And just wanted to tell basically one of the aspects that I picked up in the presentation was the surgery should be done within 24 hours if medically, if patient is medically stable. And this is an important aspect because oftentimes traumatic spinal cord injury comes in the context of polytraumas, patient that might have some other issues like pulmonary contusions or other vascular injuries that might make them unstable for immediate surgical intervention. This, I believe, is the greatest obstacle that in medical terms we might have in bringing those patients to surgery as soon as possible, despite the overall goal of offering early or even ultra early surgery, which according to recent publication from Fellings Group in Toronto published in Lancet Neurology are indicating that patient might have certainly a better outcome if operated within 12 or 24 hours. And whenever it's not possible to bring the patient to theater safely, I think one important aspect would be to try and maintain good blood pressure targets, aiming for 85, 90 millimeters of mercury.
Yes, I agree with you, doctor. Yes, I agree with Usually, there is a good prognosis if it is within the 24 hours, and according to the studies, it is a very good prognosis. If it's less than 8 hours, we manage to go in for the surgical intervention. However, the situation sometimes it's not on our side. Patient might be unstable because of the other injuries and also especially brain and intra-abdominal injuries where the importance have to give the life-saving.
Thanks. Thank you. Thank you, Dr. Shivakumar. Mr. Ganau, just thanks for letting us know about the study from Professor Fellings. And what was the outcome of the study from Professor Papadopoulos in St. George's in terms of monitoring kind of ICP in spinal cord injuries?
So I can tell you from, I sit in the EO Spine Knowledge Forum, and certainly we are looking at ways of invasive and non-invasive monitoring of spinal cord injuries and try to figure out if perioperative management might lead to better outcome. At the moment, despite very low evidence from the literature, including the paper that you were just mentioning from St. George's, there is no recommendation regarding any invasive monitoring. I know that in a recent NIHR study is looking at basically durotomy in order to reduce the ICP in those patients.
Thanks. Thank you very much. That's great. Thank you very much, Dr. Shivakumaran. You have got one or two other questions in the chat box. For the want of time, if I may ask you to answer them there. Thank you very much.
Sharon,
Well
just one comment.
Sure,
Please.
Professor Schroeder. Yeah.
Yes, I have to make two comments,
Sure,
especially
please.
regarding methylprednisolone. I think this is not indicated anymore. There were a lot of criticism even early after the study. A lot of spine surgeons have contributed to that. And there was recently published a meta-analysis in Neurology in 2019. And they compared 16 studies, and they found that methylprednisolone did not improve the outcome, but had more side effects, similar to the cortisone treatment in head injury, where we also had the studies. So I think the time is over for methylprednisolone. That's why we don't use it anymore.
Thank you, Professor. I think I have gone from both sides. I've been in departments where we used it, and then I've been to departments where we don't use it. Mario, you are in Toronto with Prof. Failings. I know that you guys wrote a paper on it. What's your thoughts on what Professor Schroeder said? I know that it's one of those ever-ending controversies, but still it would be lovely to hear from you. What's your thoughts?
So
Thanks.
Basically a clarification. The Failings is an advocate of the use of steroids. However, only if the patient falls within the protocol for NASCIS 2, which means that the steroids needs to be started within 8 hours from the injury. Otherwise, he would never administer steroids. He has published extensively criticizing basically all the veto that most neurosurgeons and at times even neurosurgical societies have put on the use of steroids. However, I can tell you that even in North America, there is a very heterogeneous practice. Here in the UK, I think is more homogeneous and against the use of steroids in spinal cord injury, and I can see that this homogeneity here is spread across both neurosurgery unit, orthopedic unit, and mixed neuro-ortho units.
Thanks, Mr. Gano. I think the only thing is that in one of the papers by Professor Failings, he mentions that use of steroids still in young patients, and certainly in pediatrics, they are still in UK. There are still a bit of a split on which way to go. I think we probably could have another meeting just on that to clarify this ongoing problem. So thank you very much, Mr. Gano. Thank you very much, Professor Schroeder. Thank you very much, Shivakumaran, once again for an excellent talk. So we will move to Dr. I'll just give my Dr. Noor ul Huda Maria. Dr. Noor ul Huda Maria, she's coming from Pakistan. Dr. Maria is going to talk to us about telemedicine supported damage control neurosurgery in less privileged area, a ray of hope for rural and developed areas. She's going to look through the various studies and what we can learn from that. Thank you, Dr. Maria. Do you want to share your presentation? Thank you. I can't see it now.
Thank you so much, sir. First of all, thank you so much for providing me with this huge privilege of sharing my humble work at your very esteemed and very popular, I would say, platform, and I guess it's a matter of huge honor for me to have this opportunity to present something that is a bit, innovative, you might say, or something that is a new concept that can be applied in areas such as my own country, Pakistan, where we do have, limited resources, and neurosurgery is not quite widely available everywhere, and many of our neurosurgeons who have been trained, who are yet to complete their exit exam or something like this, or even if they have passed their exit exam, they are being posted in the primary and the secondary care hospitals where neurosurgical units are not quite available, and sometimes these units are quite far away from the tertiary care units. So this is a new concept that I want to discuss that can be applied in our areas to save maximum number of lives while using minimum resources or what we have right now. So this is telemedical supported damage control neurosurgery in less privileged areas, array of hope for rural and less developed areas of Pakistan. I'm Noor Zamaria, MBBS and FCPS training. I've completed from Punjab Institute of Neurosciences, Lahore, Pakistan, BSc honors in sciences, in medical sciences, fellowship in spinal surgery, and also certification in stroke and accident. So what is damage control surgery? In general, damage control surgery, the concept of damage control surgery was introduced by Halsted and Schroeder, who defined it as a safe, abbreviated surgical intervention, which was meant to save the patient's life and to prevent the lethal triad of acidosis, coagulopathy, and hypothermia, while delaying the correction of anatomy and avoiding the prolonged surgical exposure for a critical patient who already have resources to survive. It is basically a concept designed to prioritize short-term physiological recovery over anatomical reconstruction in those who are seriously injured and compromised. This concept was installed by the surgical specialties, especially those which were associated with warfield trauma management. The damage control surgery was first introduced in 1998 by Rinker, who was a rural trauma center in the United States. So he just tried to apply it in neurosurgical patients. He advocated training the rural surgeons for emergency craniectomy to treat patients with severe traumatic brain injury when neurosurgeons are not immediately available. However, the term damage control was considered unacceptable by the neurosurgeons, who deemed it a term that was related with general surgery. So in fact, when they submitted their paper in the surgical neurology and later on the JNS, their paper was rejected because they thought that this concept is more relevant with general surgery and should not be adopted or should not be applied in neurosurgery. So it took them a little time to realize that it can be something that is useful for neurosurgeons as well. So DCS concept was ultimately, adapted by the neurosurgeons. The concept of DCS was endorsed by surgical disciplines, including neurosurgery. In special importance was the warfield, for which it evolved later on when we had several conflicts around the world that includes the Iraq and Afghanistan conflict. It was a time when this neurosurgical concept was set. So DCNS approach including urgent ablation neurosurgery for critically ill patients with traumatic brain injury. The DCSS approach aims to limit secondary brain injury to stabilize the patient to enable safe transfer and improve the patient outcome, because it was thought that many of the patients, succumb to their injury during their transport because the facility where neurosurgery is, specialized neurosurgery is available, is quite far away from the area where they have been injured. The DCNS approach aims to prevent the deleterious cascade of expanding intracranial hematoma or cerebral edema that because of the TBI, that is traumatic brain injury, and can eventually exceed the capability of the auto-regulatory mechanisms. This deleterious cascade results in an exponential increase in intracranial pressure, which worsens secondary brain injury, potentially leading to tentorial and foramen magnum herniations. Prevention of this cascade can be achieved through early surgical intervention using decompressive craniectomy. The already overburdened healthcare system of the low-middle-income countries, which was working under the limited resources, is undergoing an additional healthcare crisis in the form of COVID-19 pandemic. So the objective of our study was to evaluate, design, because when we were hit by this COVID-19 pandemic, and already we were running under financial constraints and obviously fiscal policies, etc., that were applied in our healthcare system. So we felt the need to see what we can do more with what we really have. So doing more from less kind of approach, you can say. The aftermath of this pandemic will be even more severe in the form of loan of resources and a backlog of operative cases which were postponed during this pandemic. The effect can be very long lasting. We need to find new ways to deal using as little resources as possible while saving the maximum number of lives and leaving no patient to die because of lack of resources. We may need to find, evaluate, and design new strategies and introduce efficient, concise training programs. Role assignment according to the level of training is also required. This is a war-like condition, so why not want to evaluate the war strategies? The generalizability and transferability of intervention tested in high-income settings are not possible for us. So the methodology, basically because it's a new concept, so we had to look into the literature that was already available. So we reviewed data on DCNS by browsing articles at PubMed, Curious, Research, The principles of damage control surgeries after the standard airway breathing circulation includes it as securing that you have stabilized the patient with the ABC. The early use of hyperosmolar therapy, hypertonic saline, or mannitol. Mannitol is more prevalent in our areas. Careful patient selection for recompressive craniectomy, securing hemostasis of intracranial bleeding, evacuation of the intracranial hematoma, limit the contamination of the compound roots by early surgical debridement, dural closure being decided on individual basis how you are going to proceed with the closure. The goals achieved from this strategy include alleviation of the intracranial hypertension, prevention or arrest of cerebral or cerebellar herniation that is earning a decompression of the brain. The approach was, first of all, proper patient selection. Then it decompressive surgery in the form of decompressive craniectomy, which is the modified Kepler's restoration of the physiology in the ICU, definitive surgery, and cranioplasty. The acute trauma management in rural and remote location is of significant interest in constitute general policy, which comprises of prevention, education, organization of an integrated neurotrauma system, and support for the early management of severe trauma program instituted by the Royal Australasian College of Surgeons. The Royal Australasian resource that has been adopted since 1992. So as this is the new recognized and evolving civilian application. There's a dearth of such data. Most of all of those researches which are available are by Rubiano et al. These are very good researches, and we can just expect much from them. However, the available data on DCNS is authentic, and as it has been performed under extremely difficulties, is quite good for you to exploit. Limited resource citing the evidence shared by Rubiano et al. Regarding the DC protocol is suitable for the centers where there are limited resources where proper ICU care and ICU that this experience is based on strict patient selection, and any deviation can result in serious consequences. So this is the Rubiano et al. Criteria that includes obviously the evaluation of parameters to assess the risk of imminent death or neurological deterioration and necessity to determine whether the use of the DCNS approach is possible or not. And 2 points and or progressive bradycardia and hypertension. Obviously, we all know about it. Rubiano et al. Applied early cranial decompression for neurotrauma in 2001 at areas with low neuromonitoring resources. They also applied it for the area. They said that in their area, ICU not quite, not available, not to begin to be performed in patient disease. TBI, who would fall in 50 years, a GCS score of less than 9 after emergency room resuscitation ratio to more than 90%. Systolic blood pressure of 90 millimeter of mercury, and after pharmacological sedation of paralytic agents have been metabolized, fused short-term agents to the rapid sequence induction institution part. Isolated non-penetrating injuries, head injuries without other associated traumas like abdominal, thoracic, or extremity injuries. CT finds compatible with diffuse injury, motion score 3 or 4, evolution of less than 12 hours. Waiting none of the the patient and move and TCNS and survive. The same author shared that for further successful experience with the EDH and SDH, which were too unstable to be shifted there and had to undergo DCNS, before transfer. A special study on damage control surgery was reported by Ross and Felt, a military neurosurgeon from Australia, where he showed improved option to treat patient in the specific condition, and especially suited the condition in the low and middle income countries where neuromonitoring available. So in the PCNS, there's a rising incidence of TB in the developing countries to an extent which is considered. The second, the LMIC work in a limited resource. I think this seems to
Dr. Huda.
Citing, like I've mentioned before. There's a lack of ICU and neuromonitoring facility as well. Okay, I'll keep it short. There's a lack of ambulance service as well. It's like many such trust to play the management. This is the Defatol experience training center course that in Afghanistan for they trained about 100 surgeons in Asia to who were not neurosurgeons. Evidence improved survival in patients who were managed by in the water by DCN. The battlefield neurosurgeons allowed safe transfer, and this type of approach allows safe transfer of the critical patient of tertiary hospital located at a distance longest. We can enact for damage control when the deleted effect of brain swelling that may appear during the long transport or during on the way to the definitive care center. So have we got a panacea for all the surgically? No, we have not. But there were complications that have been reported. Some complications that include strangulation of brain tissue through an inadequate craniectomy, because those were not neurosurgeons, so they did not have any idea about that. Even in some trains, you know, this thing. Because of inadequate craniectomy, the chance of complication like cortical impasse, fungus cerebri, hygrooption, DCN has modified temperature to set superficial temporal and occipital artery in prevention of necrosis of the skin slab. Reports where doctors were not able to take prompt decision, even trainers were not able. So now we have several complications where many doctors were not compressed, even in our many trainings. So these complications made realize that there should be telemedical support, telemedical supervision, partially through a neurosurgeon, a specialized neurosurgeon who can just look over those surgeons who are working in those primary and secondary healthcare centers which are performing DCNS approach. This is very cost-effective, approach for them, because many hospitals are regularly using WhatsApp groups. In our sector, we have a WhatsApp group where the junior trainee shares the report in the WhatsApp, all the scans and everything, and they just ask what we need to do and how should we plan the flap and etc. and what complication they have. So this is something that is sort of a telemedical support. This can be applied to the peripheral centers where DCNS approach is applied, so that we are going to prevent the complication. So conclusion of this point, the damage control surgery can be applied in limited resource setting, and there was the access to a specialist at a distance and transport time cast additional negative impact. The application of DCNS needs decision making and proper surgical approach. So this is what mentioned before. Effectiveness, solution, telemedical health is cost effective. These are all the points that it So thank you so much for your patient listening. Brief overview for Izmir Online Neurosurgery. I will like to extend my invitation to everyone. Thank you so much.
Thank you very much, Dr. Maria. You introduced very important concepts. We didn't quite, because of the breakage of the sound, we didn't hear all of your talk, but certainly we got from your excellent slides, we got what you had wanted to mention in those gaps. I'm just going to, if I may, invite Professor Grottenhuis, Professor Goel, and Dr. Francia to comment. Professor Grottenhuis, Dr. Maria brought up important points in terms of, even with the internet, we are having problems. And so the neurosurgery training, should it be all aimed at what is taught at the advanced centers, or the education should be such that we should be training general surgeons to do damage control surgery, should decompressive craniectomy in these countries should be done earlier, and decompressive craniectomies are not without their own complications if they are overdone. So Prof. Grottenhuis, your thoughts. Thank you.
Well, in general, thank you, Maria. It's a very interesting topic because there are still many rural areas and areas in the world where there is hardly any access to sophisticated neurosurgical care. So I think there are 2 points. That the telemedicine means there is a possibility to consult a neurosurgeon somewhere else. And what is important, and I think Maria told that is the indication to do anything. I actually remember that a general surgeon friend of mine who, after his retirement, went to Zambia, and he's now and then teleconsults me about cases. Should he do a burr hole for suspected after a motor vehicle accident for subdural hematoma, yes or no? Because even CT facility is 500 kilometers away. So it's interesting to think. I think indication is number one, where telemedicine can help. And the other question about who should do that, I think that explorative burr holes can be taught by basic medical trainees. So that will be an issue. But you agree, a full hemicraniectomy is not a simple surgery. And if you don't know a lot about doing craniotomies, you can end up with a lot of troubles and actually causing more complications, especially if you only want to do it to say, I can safely transport the patient like they do in war situations. So the first line field hospitals in war times do this very often to stabilize it. They are trained also general surgeons in the US military doing hemicraniectomies. Okay, it's a matter of training, but how often can they do that? So there are some issues here, but I think the most important part is to send something about the patient and consult with a neurosurgeon who can guide you what to do next. But it is not the type of surgery that you would easily guide through a WhatsApp camera. That's certainly not so easy. But nevertheless, I like the topic very much, Maria.
Thank you so much, sir. It's a huge honor for me.
Thank you, Prof. Grottenhuis. Professor Goel, if I may please invite you. I know that you are at the, working at the top of the game, but you in India, you see the very best and very rural areas, and neurosurgeons tend to, however much that we talk highly of helping poor people, there's a lot of talk that even I do, but we all want to be in a big city, etc., etc. So in rural areas, you are not going to get a neurosurgeon. Do you see any way around? Do you see, and what's your thoughts that Dr. Maria raised? Thank you, sir.
You can hear me, Naren?
Yes, I can, yeah.
See, Maria is a very fantastic speaker and good work. I have been watching her, and there's no question she's involved in her work. But, unfortunately, I couldn't hear her complete presentation. My feeling is, whether it is in rural area, whether it is in big cities and all, we have to give state-of-art medicine, state-of-art neurosurgery, and there is no way we can compromise. If we have to do something in the rural area, we cannot compromise on the treatment. Treatment has to be perfect, whatever is there in rural. If for some reason we are unable to do good neurosurgery in rural area, it may better be that we do not do neurosurgery rather than do a compromised neurosurgery. So this is my feeling, even for poor people in, the kind of hospital I have been working throughout my life, whether it is poor person or whether it is a rich person, we cannot compromise on investigations. That is my principle. We cannot compromise on the kind of treatment we have to give, and we have to learn, and we have to dedicate ourselves in doing the best neurosurgery, even if it is in rural area. And I know it is not possible, but that should be the aim, Naren.
Sure, thanks. Thank you very much. I take your point. I think, certainly decompressive craniectomies are not without enough hemorrhage and without having a good anesthesis and transfusion, and the coagulation going off, things could be actually much worse than, even in developed countries, if you operate on a slightly wrong indication for decompressive craniectomy, it can make things worse than better. But in terms of let's say that we have got a neurosurgeon, but we don't have ICU, we don't have what you call CT scanners, we don't have ICP, sorry. And in those conditions, is it just worth just doing for a neurosurgeon to do a safe decompressive craniectomy and then manage the blood pressure and let the nature do? What do you say there?
No, we should not do just decompressive craniectomies for the sake of doing decompressive craniectomies. As you rightly mentioned, Decompressive craniectomies have their own problems, own issues, own controversies, own conflicts of thoughts. And if we can do decompressive craniectomies, that hospital must be catering to, there should be an ICU, at least a reasonable ICU. What matters is the care. You know, now with the COVID times, ventilators have been provided in all kinds of rural hospitals. So I don't think that we should compromise the quality of work and the way we work with our neurosurgery. We just cannot have an excuse that this is what I did because of my poor situation, compromised situation. We cannot do wrong things for these kind of indications. I am a very firm believer of this. If even in a hospital where I am working, I am saying that we have to do world's best. We cannot say I cannot do world's best because of the situation. Don't blame the situation because I am, compromised. So that is what we should at least aim for, Naren. That is
sure. Sure. But
exactly.
What about
exactly?
Sure, Maria, please.
No, sir. I want to.
We can't hear you so well, Maria.
To make the point, the surgical. Hello, I want to make this point clear. I don't mean that we have to compromise the surgical procedure, but sir, what I mean here is that we need to save lives. Like if we say that, there's a patient which is about 18 hours away from my center. If they say no, we are going to shift that patient to our unit, which is 18 hours away. What if, and we are not going to perform any type of surgery. So if we shift this patient, what if he dies of his injury? This is the main point I wanted to point here, because if that patient dies, so no surgery, some very high quality surgery.
Well,
but in the meantime, during the time the patient becomes surgery. So
okay. Thank you. Can I bring back both Professor Andre Grottenhuis and Professor Atul Goel and then Dr. Francia? Thanks.
Yeah,
Professor Grottenhuis.
Just to a few additional remarks. If somebody comes in unconscious after an accident, after a major trauma, and you will say this is a neurotrauma, but you don't have any facilities to do that, just doing a decompression as a matter of damage control is probably not right, simply because, the term actually comes from the general trauma surgeons. They do abdominal damage control surgery. That means they open the abdomen, they put in a lot of gauze to compress the liver that is bleeding and remove the spleen and do some initial things. Then they place that patient to be resuscitated and to bring in a better condition to then undergo a larger surgery to repair everything. That was the idea of damage control. But in that sense, decompressive craniectomy is not damage control. It's actually maybe even doing more damage, because what you should do, the life-saving issues here are only about the epidural hematomas, not even the thinner subdural hematomas with contusions. You have to rule out an epidural hematoma. So that's the point. And then I think that you could say he is 18 hours away from your facility. So do it, decompression with a lot of possible complications, and then transport the patients, because if you transport them, he will die before he reaches your hospital. He probably will also die with the decompressive craniectomy. This is just doing blindly without any knowledge of what type of trauma was going to the brain. It doesn't feel right to do this to the patient.
Thanks. Thank you, Prof. Grottenhuis. Professor Goel, thanks.
Yeah, you see, with Huda, with due respect to what you are saying, I must say very clearly and without any doubt, you see, even a decompressive craniectomy, if it is in a remote town, will be done by a neurosurgeon, not by, or at least a little bit trained neurosurgeon. So if the neurosurgeon is little bit trained or enough trained or satisfactorily trained, he should do a complete job, not just decompression. I just don't believe in this Absolutely, you cannot do just for the sake of buying time, do some decompressive craniectomy here and there. I am completely, absolutely against these kind of things.
I think I have to say, having done a decompressive craniectomy last week, and it is not an easy operation, and it's pretty tough, and there's a very small, as a surgeon, you have also got very small width from making things worse than not with brain mushrooming out or bleeding. So it's not an easy operation, and anesthetists have to be on the ball like a craniofacial surgery to make sure that the coagulation is okay. So Professor Icarino, do you want to make any comments, sir?
Yes, thank you. Good morning, everybody.
Thanks.
And colleagues and friends, just to emphasize that decompressive craniectomy is not just one shot surgery. I mean, decompressive craniectomy is the first step of a long treatment that it takes postoperative care, the reconstructive phases and rehabilitation phases. So we cannot talk about decompressive craniectomy just for the first one problem of that emergency in that days. That means that when we talk about low resources, the low resources is not only just for surgery, but also about the postoperative acute phase and chronic phase. So what Professor Goel says, and we are totally agree with him, that you cannot talk about your limited resource and you can manage the patient just in that limited resource. If you are a neurotrauma neurosurgeon, you have to think about all of this. So when we talk about decompressive craniectomy, we cannot talk just only for the bleeding problems and neuromonitoring problems, because if you accept a patient to be decompressed, that means that you accept a patient that needs all of this treatment. And after this, we can talk about if we are agree or not that the decompressive craniectomy is the right surgical solution. And we have a lot of discussion with Professor Goel and other professors about this. But first of all, we have to talk about decompressive craniectomy as a big first step treatment of a long, successful treatment in the second phases.
Good, thank you very much. I think Mr. Gano is making the point about just burr hole exploration. I mean, your thoughts, Professor Goel, is it just worth just doing a burr hole exploration just to exclude any extradural in a remote area?
See, Naren, I'll make a point. See, if we have to do neurosurgery, any neurosurgeon, young or old, or in remote town or in small town, in a poor country, in a poor setting, or in a most advanced setting, our aim is, as a young neurosurgeon, that we have to do the best neurosurgery possible in the world on that particular patient. Whether he's poor, you cannot say, I will do a compromised neurosurgery. I will not do investigate. I'll do without investigation, just burr hole. I don't have a CT scan and I'm doing neurosurgery. You should not be, I have worked with poor people all my life. And I can tell you with great confidence that I have never compromised on investigation. And I have never compromised. So the aim of the neurosurgeon, young, should be to do the best neurosurgery and not blame the surrounding or situation or country or poor remote area and say that I am doing this compromised neurosurgery because I am a poor neurosurgeon. I think this attitude I don't like in general. I have never had this attitude for my own patients.
I agree with you.
No, I got, sorry, sir. I got one point. Sir, I'm again trying to tell you that I not mean that sir, we operate on poor patients. In our center, in PACE, it's a tertiary care specialized neurosurgical center, where we operate on every poor patient. We give them maximum investigation. We have 3 Tesla MRI. We have the neuroangiographical suite. We even perform embolizations and advanced treatment, whatever is available in Pakistan, to the highest possible level, which include neuronavigation, everything. It's not about the patient who is poor. We are performing everything, and we are providing free of cost treatment in our center. You can, I think you might know about this.
Maria,
it is not about money. I am again telling you, it's not about money. Have any facility to perform such high-class surgery. So I am not talking about poor patients. I'm talking about those situations, like in a war fields or in the periphery, where there's not much things that we can do. So we are not going to leave them to die, or do we think that they are going to transport, or they do not get transported. Many patients, many patients do not even get transported. They die. They are left to die. So this is the point. Yes.
Sure. Maria, thank you. I'm just going to just wrap it up. Professor Goel, I think what I understand, because of the sound, what I understand from, I agree in the sense that we are not talking about neurosurgeons not doing excellent surgery, but in rural places, we don't have neurosurgeons at all. It will be general surgeons. That's what that's what the point is. In that
let
point,
me add this point, sir.
Mariam, we have to quickly go. We'll just ask Professor Goel to come back. We are not talking about, and then we go. Prof. Goel.
You know what, Naren?
Yep.
If we are seeing not only neurosurgeons, but also general surgeons doing, then you will start talking of some quacks doing, then you will talk of some Ayurvedic doctor doing craniotomy. See, if those kind of situations, then, that country has to be changed, and that the whole country is an unfortunate country in that case. You cannot let any person who is not trained in doing neurosurgery, doing even craniotomy, as you mentioned, is not a small operation.
Sir,
Mariam,
another point here. Sir, you might have... Just one point, sir. Sir, just one point. Sir, you might have missed that I have shown a slide of Teff et al., where he has designed a course that I think you must know about this course, because it's a very famous course of 1 year duration. Here they train every surgeon who is meant to perform DCNS approach. This is a military course designed by the US Army. Okay, so they just train that person for 1 year, then they go into workshops, they perform in these workshops and have the pass an exam, and after that they apply the DCNS approach. So I think this slide might have been missed by you. That is already
that's brilliant.
The presentation.
Maria, I need to move on. I think you made your point.
Yes. Thank you.
Thanks. I think this we can have this is an important topic,
exactly.
And we can have another meeting just on this hopefully with the WFNS Global Neurosurgery Group. Great. Thank you very much, Maria. Thank you very much, Professor Goel. I take all your points. I think we have to do safe surgery, but also look at other ways as well. Thank you very much. So now I have the distinct pleasure of inviting Professor Grottenhuis and Professor Schroeder, two heavyweights of neurosurgery, and it's a real honor to have them to moderate another fantastic session we have. If I may ask Professor Grottenhuis to kick off this session. Thank you, sir.
Yeah, thank you, Naren. And actually, you asked me to co-chair this, so
with
the
Professor,
first chair is
Professor
actually. No, I think it is Professor Schroeder. So, but it's always a pleasure. It's always a pleasure to see you, and also Henry. I mean, we know each other for so long time, sure. But because of the time, let's move on.
Sure.
And the first, I had to look to your booklet, very nice booklet, to find it. It is we invite now Julia Eva Martin Colom from Spain, speaking about minimally invasive endoscopy-assisted evacuation of acute subdural hematomas. Please,
Dr. Colom, I'll give you the. Yeah. Good, brilliant, excellent.
Yeah, she already opened it. Perfect.
Oh wow, well done.
Hear me?
Yes, we can. Yes. Thank you.
Go ahead.
Okay, thank you very much. So thank you very much for this opportunity. Good morning. I'm Julia Eva Martin Colom. I am a 4th-year resident from Reina Sofia University Hospital in Cordoba, Spain, and I'm going to talk about minimally invasive endoscopy-assisted evacuation of acute subdural hematomas. Life expectancy in many developed countries has gradually increased, and birth rates have fallen, resulting in an increasingly older population. Also, the number of patients undergoing anticoagulant and antiplatelet therapy and with a lot of comorbidities has increased, which is a restriction for us when we plan a surgery. One of the most common neurosurgical conditions in the elderly is acute subdural hematomas, and it is expected to become the most common neurosurgical condition by 2030. The conventional surgical management of acute subdural hematomas consists in a wide craniotomy and evacuation. And since for us, it is really important before we plan any surgery to think about the surgical outcomes and the quality of life of our patients, the increasing age or comorbid burden of the patients may render invasive treatment strategies inappropriate. We try to find some less invasive and also effective treatment for those patients. So we started performing in selected patients minimally invasive endoscopy-assisted evacuation. From 2016 to 2020, 8 patients were selected to perform this procedure. Our inclusion criteria were the presence of symptoms and of comorbidities and or the age more than 65 years old, and no moderate or massive brain concussion or hematoma, and patients are then going antiplatelet or anticoagulant therapy. It was really important for us that we didn't see any signs of brain edema in the CT scan. So for that, we performed a 3 centimeters average craniotomy, focused on the superior temporal line, and for the evacuation, we did use a 4 millimeter with an optic of 0 degrees rigid endoscope. The most important technical aspects for this were the patient positioning with the head parallel to the floor. We did also perform a deploy milling in order to have enough space to introduce the endoscope. And there were 2 points that were really important to protect the brain: the use of cotonettes, and also checking that we have enough space to introduce the endoscope or the aspirator to avoid any more brain damage. The data we collected were the Glasgow Coma Scale, the use of antiplatelet or antithrombotic drugs, the comorbidities, the etiology, the complication, deaths, hospitalization rates, pre- and postoperative MRS scale, and the postoperative CT images. Our results were that more than the 80% of evacuation of acute subdural hematomas was carried out in all patients assessed with the postoperative CT scans. We have 2 perioperative deaths in less than 30 days from the surgery in patients with early clinical deterioration and severe neurological impairment at the time of the surgery. 2 complications were reported, rubilin and pneumonia. 1 patient required reintervention, and the mean hospitalization rate was 9 days with a median of 4 days. The functional success rate was 85%, assessed with the MRS scale for the patients that survived. If we compare our results and look in the literature, we see that the factors associated with the outcome were the preoperative and postoperative DCS score, the presence of fixed or dilated pupils, the midline shift, and patients undergoing anticoagulant or antiplatelet therapy. When we compare our results with the literature using endoscope or some case series that compare the craniotopy in the elderly population, the first point we see is that some cases when they used the minimally invasive treatment with the endoscope, they didn't use general anesthesia with it. Our complication rates were similar to those who use endoscope-assisted evacuation and less than the ones who use the craniotomy for the elderly population. We had less perioperative deaths compared to both, and it was really important to select the patient in order to reduce the morbidity and the mortality. We found that it was really effective treatment for patients undergoing anticoagulation or antiplatelet therapy because it did reduce the risk of bleeding and hemodynamic instability. But when we compare, it is really difficult for us because there are so many case reports and not so many case series. The longest we saw was with 10 patients. So for us, it is really difficult to compare if this is really we are having best or worst results comparing to the other centers. So if we see all, we have some advantages, which is the reduced intraoperative bleeding, the shortening of the operative time, less infection risk, and less anesthetic risk if you use local anesthetic, and some disadvantages, which is it is more difficult to perform the direct hemostasis when you use the endoscope, and if you have delayed cerebral edema or hemorrhage, is not enough treatment for those patients. So for us to conclude, we saw that it was a safe and feasible option for elderly and high-risk patients, and it is a good option for patients undergoing antiplatelet or anticoagulation therapy. And our two adverse events might serve to reinforce that the time to surgery and the neurological impairment are the most important prognostic factors. Thank you very much.
Thank you very much, Dr. Colomb, for this interesting, be it very small study. May I assume that the fact that you only treated patients older than 65 was that because the type of acute subdural hematoma in those elderly patients is often different from, it can be spontaneous even, or it can be inside a chronic subdural hematoma. And there is usually a little bit more space already, because on that video, I could see that there was a kind of already thin membrane on the cortex. So that is what you could see in let's say, an acute subdural hematoma inside a more already chronic subdural hematoma. Is that assumption correct?
Well, for us, this series was of acute subdural hematoma, so it was less than 3 days from the presentation. It is right when there are spontaneous. Sometimes we don't know precisely when was the start of the bleeding. We did use, as you say, that because of the atrophy, we have more space to introduce the endoscope, and also because with less than 65 years old, we perform a craniotomy.
But
we haven't tried this yet.
But those patients all had, your patients all had severe traumas. So these were trauma.
No. Some of them were spontaneous. The ones undergoing anticoagulation.
Yes.
Sorry.
Yeah.
Sorry.
No, that is what I meant, because it is different to an acute subdural hematoma in, let's say, a 25-year-old male with a motor vehicle accident. That's another type of problem that we have to deal with.
Yes.
And usually in those acute subdural hematomas, we do not only a larger craniotomy to be able to maybe do decompressions. This is always the case. Now, I recently read that 70% already always leave the bone flap out. I don't agree with that, but that's another point. But you know that you can find the cortical arterial bleeder in such cases. If you make it wider, or a venous bleeder, which is often very close to the sagittal sinus. So therefore, you have to open more widely. This is a type, and I was surprised. Of course, 8 patients. Usually, patients above 65 in the Western world, and not many of them not using any antiplatelet drugs. It's a high incidence of patients. At least here in my country, patients over 65, I think 90% of them are taking aspirin. Yeah.
No, for us, we did want to include those that were under the anticoagulation, because first, when we started in spontaneous in those patients.
Mm-hmm.
And then we started performing that in the patients that were 65 years old, that you wouldn't do a craniotomy, but they have good quality of life. So
yes.
We have good results in the others. So we started performing on them. But of
course,
we wouldn't do that when we suspect that there is brain edema and we might need a craniotomy.
Okay. I have to go into the chat because of the time, and I see if there's a question. If you found a bleeder, how would you coagulate that? I think how would you coagulate that?
That's why we would use the bipolar and the
Yes.
endoscope. Yeah.
Okay, that was one question. The other is, do you leave a subdural drain after the evacuation of the hematoma?
No.
No, okay. And what was the position of the patient? Was it a lateral decubitus or prone or?
Lateral decubitus with the head parallel to the floor.
Okay, perfect. And my final, no, there's one more message now coming in. Let's see, one new message. 1 out of 8 patient dies. 1 out of patient died for pneumonia. 1 out of 8 was reoperated, maybe for rebleeding. Where is this safe? Which kind of endoscope and which kind of anesthesia?
We said that it was general anesthesia and the endoscope was a 4 millimeter rigid endoscope. Also, I didn't specify that I did include the deaths in the complications, and that may lead to confusion. Also, for complication, I would say there are patients with comorbidities, for example, the history of cancer, that the complications were not always related to the subdural hematoma, but for the hospitalization and the context of for us, it was a complication, as we would say, the morbidity for one patient we have in our unit.
Okay. Well, I was actually a little bit surprised that you take a 0 degree, because if you have a small space and you want to go obliquely into it, then a 0 degree would be not the most effective way to do. I would take a 30 degree and then turn it 90 degrees into it, so I have a look into the subdural space. But okay, that would be my suggestion of doing that. But maybe Henry, do you have any suggestion about that?
Yeah, I think the main message should be that that is not a good technique for all acute subdural hematomas, which are trauma cases. I think this is clear. Dieter Hellwig, I think Dieter Hellwig was the first who published in 1996 about endoscopic treatment of chronic subdural hematomas.
But with a flexible endoscope.
Exactly.
Yes.
I was surprised by one of your conclusions. You said that your surgical time is shorter when you make this technique. So I would expect the other way around, because you make the craniotomy, let's say 2 centimeters larger, so you don't need an endoscope, and with a big suction, you are very early done. So you have to explain why are you quicker, because the craniotomy is a little bit smaller, or why do you save time?
We save time because of the incision, because we perform a linear incision. We don't have to do all the flap. For us, maybe in our hospital, this is a really fastest procedure than to prepare everything for a craniotomy. But everything depends on your hospital and your medium. We don't have the flexible endoscope.
That's interesting. This is really interesting.
Every place has their limitations.
Yes. The final question, because we then move on, from Andrew Reisner is, were you prepared to extend your surgery to a larger, more extensive craniotomy if you were unable to evacuate the hematoma, or if you would see that there is a new bleeding?
Yes.
So you made a kind of possible, already you prepare it as the possible extension.
Always. Also, when we prepare it for a chronic subdural hematoma, we always think that something could go wrong.
Okay, but that's a clear answer, and thank you. And you see, it provokes nice discussion.
And it's good to have. It's good to have Dr. Reisner, who's now the chairman of the WFNS Neurotrauma Committee. Thank you,
yes,
Dr. Reisner, for coming.
Thank very you. Good to have him here.
Thank you.
Thank you, Dr. Colomb. Henry, will you please announce the next speaker?
Yeah, it's a pleasure to announce the next speaker, who is Erika Karasi, and she is talking about the combined approach to large clival chordomas. Please, Erika.
Good morning.
Good morning. Yes, we see your screen. Perfect.
Okay.
Enlarge it, please. Yes.
Yes.
Slide presentation.
Okay. Good morning. I am Erika Karasi from Ancona. Thank you for the opportunity to speak to your conference. I'm going to talk about combined approach for large clival chordomas. As we all know, chordomas are rare tumors that arise from notochordal remnants. They are midline tumors, usually extradural, and they are in proximity of many critical neurovascular structures. The median survival of a patient is about 7 years. The total surgical resection is very difficult to achieve due to their proximity to many critical neurovascular structures and their big size and also their infiltrative nature. Therefore, they are complicated by a high rate of local recurrence, and despite their benign histological characteristics, they have to be considered as malignant tumors. There are different philosophies about the treatment of chordomas. Some prefer the endoscopic endonasal approach, others prefer the classical microsurgical approaches, and other the combination of both approaches. But what we all know is that the complete resection plus the proton beam therapy guarantees the best overall survival and the best progression-free survival of patients. Therefore, we can say that despite the different philosophies, we can draw the same conclusions, and that is that the optimal treatment is the gross total resection in a one-shot surgery followed by adjuvant radiotherapy. From the surgical point of view, we can choose among several approaches, traditional open or minimally invasive like endoscopic endonasal approach, or the combination of these approaches. This is the case of a patient of 36 years who presented with a DAIC and epistaxis. We can see in the preoperative MRI that the chordoma is big, but all located in the midline. And therefore, we selected a minimal invasive approach, like the endoscopic endonasal approach, and it allowed us to achieve the gross total resection of the chordoma. The patient fared well, and he had no recurrence during the follow-up time. This is to say that minimal invasive surgical approaches should always be preferred when it is possible to achieve the gross total resection. On the other side, we have this patient of 17 years who presented with a rapidly progressive left hemiparesis, dysphonia, dysphagia, and the DAIC. She was at their third recurrence of chordoma, and she already underwent occipitocervical fixation and proton beam therapy. We can see on the preoperative MRI how the tumor has completely subverted the anatomy of the craniovertebral junction, and it is responsible of a compression on the bulbomedullary junction and also of the invasion of parapharyngeal tissues on the left. Therefore, we decided to firstly decompress the bulbomedullary junction with an endoscopic endonasal approach. In the video, we can see that we performed an inverted U-shaped flap of mucosa. And since the anatomy was completely subverted, we used the intraoperative neuronavigation system to better understand the anatomical landmark. You can see, okay, now the use of the intraoperative neuronavigator, and we use the ultrasound osteotome to remove the lesion, and also the high-speed drill to remove the infiltrated bone. Now we are dissecting the tumor from the underlying structures, and this is the intradural compartment. But the most important thing is that this approach allowed us to have a direct visualization on the structures, and in particular, allowed us to free the vertebral artery, which was completely encased by the tumor, as we can see in this frame, minimizing the risk of injury in the vessel, because we were able to see it. At the end, we can see the decompressed structures. And this is the postoperative CT scan, where we can see the bulbomedullary junction decompressed, but the persistence of a residual on the left. Therefore, we performed a second step in collaboration with the maxillofacial surgeons. In particular, we performed an extended open transmandibular transcervical approach to complete the resection of the residual of the tumor and to reconstruct the craniovertebral junction. We can see also in the postoperative CT scan that for the craniovertebral junction reconstruction, we used 2 heterologous bone splints, since the patient already had an occipital cervical fixation and she had to go for the proton beam therapy. This is the last case, and it's about a 56 years old girl who presented with epistaxis and diplopia. We can see that the tumor is very extensive and it has invaded both the cavernous sinus, both the carotid arteries, and also the left orbit. Therefore, we selected a midfacial deglowing in collaboration with maxillofacial surgeons. And this is the postoperative MRI, where we can see a macroscopically gross total resection. And this is to show that the patient, despite the invasiveness of the approach, had a very good cosmetic result. The patient fared well, but 15 months later, she presented with a recurrence. This time it was located in the midline, and therefore we selected the endoscopic endonasal approach. And this is the postoperative CT scan. We had no recurrence in the remnant of the follow-up. In conclusion, we can say that the surgical route must be tailored on tumor characteristics and on the patient. The best approach is the one that guarantees the gross total resection in a one-shot surgery. From the surgical point of view, we can say that minimal invasive surgical approaches should always be preferred if the tumor characteristics allow it, but the combination of the approaches, or also the traditional open approaches, offer various surgical corridors to increase the radicality of the tumor resection and to allow the craniovertebral junction reconstruction if required. Thank you very much for your attention.
Thank you, Dr. Carrassi, for this very nice talk about chordomas. Chordomas are very difficult lesion. You have pointed out, and you show very nice cases. And of course, if you have a tumor which is just midline, there is a good chance to get it out with the endoscopic endonasal approach alone. But especially in the lower clivus lesions, and I agree, we have also several cases where you have no chance to get it out completely just with an endoscope. And most of them anyhow require occipital cervical fusion, and you have to come from a posterior approach or a lateral approach. I was surprised you said in the last case, or was the second case, this was previously irradiated with proton beam, and you said you sent him again to proton beam. When we asked for another radiation, always they refused because they say the dose was so high already, we cannot irradiate anymore. Did this patient receive really a second radiation with protons?
This patient unfortunately died in the postoperative follow-up before she could go for proton beam therapy. But yes, she has a planned proton beam therapy.
What was the reason for the death?
Systemic complications. Yeah, bleeding and the gastrointestinal hemorrhage.
Okay.
But I agree generally with Henry that I remember one of my cases that I operate and sent to proton beam at that time in Paris because we didn't have itself in 2001. And after 20 years, there was a recurrence. But even after 20 years, they didn't want to re-irradiate him because the dose of a proton beam is so high. They didn't want to do it, not even after 20 years.
Professor Iaconangeli, do you want to comment on that? Thanks.
No, I agree with it. Hello. Ciao.
Good to see you.
I just won't stay on the beside Erika because Erika is our chief resident. So
she did a great job.
Yeah. So, regarding the proton beam, this was a particular case, and our radiologist was particularly, I would say, involved in this patient. So he would have treated again the patient in the border of the lesion in case. But unfortunately, the patient died for a massive gastrointestinal hemorrhage 1 month later. This is why we had to leave the treatment.
We had one patient where we added CyberKnife for a small nodule. That was quite effective for a while. But the proton beam or carbon ions, usually they don't do. Do you have any experience with other treatment options like checkpoint inhibitors? There are some case reports showing that it might be effective. Do you have any experience if you have no option for any radiation?
No, we had no experience in this sense, but we have at the last meeting of the Italian Association of Neurological Oncology, people coming from the CNAO in Pavia starting this protocol.
Okay. Okay, we have to continue. We are running out of time. There were two questions.
There are a few questions.
Yes,
I don't mind.
Maybe Dr. Carassi can answer them in the chat. It is about if you ever had complications like arterial injuries, nerve injuries, and in general a question about mobility of these approaches. But maybe you can, so that we can move ahead,
Okay.
and you answer it.
Of course.
Yes.
In the chat box. Okay, thank you very much.
We can go on with Dr. Serena Vittoria Lisi about piezo surgery, an innovative and safe technique to approach cerebral. Oh, sorry. Eric, maybe you should mute.
Who's making noise? Sorry about this. I'll sort it out. Who's that? I'll just move to everyone. Yes, a second. Dr. Lisi, Serena, let me get you, Serena. Serena, you can go ahead. Yep, you can go ahead. Thanks. You should be able to share your presentation. Thanks.
Yes, just a moment.
Sure.
Probably Dr. Carassi should
yes,
out of the she should stop sharing.
Yeah.
Dr. Carassi, could you please stop sharing your screen? Click on the green button below and say stop. Yes.
You could.
Okay.
No, you start. Perfect.
Oh no, devo stoppare la condivisione. Aspetta.
Yes.
È andata Okay, good morning. My name is Serena Vittoria Lisi from Ancona, Italy. It's my pleasure to be here today with you, and I am going to present our experience with piezo surgery. That is an innovative and safe technique to approach cerebral lesions.
Could you please go to presentation mode so that it is larger for us?
Yes.
In the lower part of your screen, you click on slide presentation and then it will enlarge.
Okay.
No. There it is. Very close. Click on it. Yes.
Okay. In recent years, the method to access intracranial structures has experienced significant modifications. It's a problem, sorry.
It's nobody can read this.
Moment, sorry. Just a moment, sorry.
Take your time, no problem.
Enlarge the screen.
That's it. Yeah, that's it. If you click that one, that's it. Well done.
Okay.
Please go back now to number your second slide. Yes.
Okay. In recent years, the method to access intracranial structures has experienced significant modification. In modern neurosurgery, in fact, the gold standard is to achieve the maximum therapeutic effect with the least iatrogenic injury. This has been made possible also thanks to piezoelectric bone surgery, simply known as piezosurgery. Piezosurgery is not a new technology. In fact, it was first developed and used in oral and in head and neck surgery 20 years ago. But in neurosurgery, Piezosurgery is a new promising technique for bone cutting that allow to perform precise and thin osteotomies with soft tissue sparing. The instrumentation consists of piezoelectric handpiece and a peristaltic cooling pump, discharging saline solution at an adjustable flow rate. Ultrasound are generated by ceramic transducer crossed by electrical current. The interaction between the saline solution and the vibrating tips causes a change of pressure by ultrasound with the subsequent formation of vibrating gas bubbles. This vibration provokes the cavitation, which makes possible the selective cutting of bone. The piezoelectric scalpel bone show the power 3 times greater than conventional instruments. So the benefits of piezosurgery are highly precise, minimal damage to the surrounding soft tissue, minimal intraoperative bleeding, no osteonecrosis, better and faster healing, and minimal postoperative swelling. Therefore, piezosurgery may be extremely useful in skull-base surgery, especially around the orbit and anterior skull base, where craniotomies have to be performed in visible regions and so require good aesthetic results. So in our institute from January 2019 to January 2020, 23 patients were treated using piezosurgery. These patients were affected by meningioma 13, schwannoma 6, craniopharyngioma 2 patients, epidermoid cyst 1, and low-grade glioma 1 patient. We performed 4 tailored craniotomy on frontal parietal, 5 presigmoid and retro translabyrinthine approach, 7 retrosigmoid approach, 3 anterior transpetrous approach, and 4 paternal approach with clinidectomy. All patients were evaluated with pre- and post-operative CT scan, and after 3 and 6 months, with 3D bone reconstruction to verify the ossification of the craniotomy and possible complications. In our series, we observed venous sinus rupture in none of the patients, no postoperative CSF leakage, and we observed only in 1 case thrombosis. Moreover, the ossification rate of the craniotomy borders was 60% at 3 months and over 19% at 9 months. Moreover, in no case bone resorption or mobilization has been documented. Now I present an illustrative case of a woman, 52 years old. She presented at admission with an history of headache, progressive headache, and anosmia. She was operated in our institute using piezoelectric bone piezoelectric, and that performs supraorbital approach with incision over the high brown. Now in this video, we can see the skin incision, dissection of soft tissue, and now the supraorbital craniotomy using the piezoelectric bone scalpel. And we can see the small size of craniotomy, and that is a few centimeters. And now the removal of bone. And the tumor removal was complete, and the patient do not present any complication. And after 5 days, she returned to home. And in conclusion, Piezosurgery is a new promising technique for selective bone cutting with soft tissue preservation. These characteristics make this instrument particularly useful in skull-based surgery because it allows performing osteotomies near neurovascular structure and eloquent areas without damaging them. Moreover, in our experience, these allow reaching a better and faster ossification of the craniotomy with a significantly superior aesthetic result than a traditional instrument. Thanks.
Thank you very much, Dr. Lisi, about this. I don't know how many people use piezo surgery, but may I, just to start, to correct one thing. You said it was developed 20 years ago in 2000.
Okay.
No, it was way earlier. And actually, it was an Italian dentist who did it. It was Professor Tommaso Vercellotti from Genova. He developed this in 1988.
Okay.
So it's Italian, so you should you should be reminded of that. No, but as you said, it was bone work. So it was in implantology and periodontology and in dentistry, yeah, in first and maxillofacial. And that's. Let me see if there are questions in the chat about. No, not yet. And Henry, have you experience with piezo surgery?
Yes, we have used it.
Mm-hmm.
We made a study with our spine guys, and they measured the temperature. And that is what she nicely said. If you take the piezoelectric element, it becomes not so hot. And that's why maybe the bony healing is earlier. But what I don't like is I tried it to open the internal auditory canal for vestibular schwannomas. It takes too long, I have not the patience to wait. With a high-speed drill, with a cutting one, you are easy going through. And then what I think it's nice for the last piece, if you are close to an aneurysm and you make an anterior-clinopectomy, for example, and then of course you have not the risk that you catch it with a drill. For that is good, but from the beginning, I have no patience to wait so long. That is the only problem I see. Thank you for the nice presentation.
Indeed, very nice, and I agree with that. I only did it twice for posterior clinoidectomy, because that is very much in the depth and very difficult to do with a drill because of the vicinity of oculomotor nerve, the posterior cerebral artery. So that was very nice, but that's all. So it's interesting, and I thought that it would be a more widespread experience, Mauricio, also, and with this technique. But apparently for the bone work, neither spine nor skull base, it really has gained a lot of popularity in neurosurgery.
You agree, and Henry is right. In one of the slides, we demonstrated that we made a piece with the piezosurgery, another piece with the drill. Because of course the piezosurgery is less damage, less the bone, so the bone healing, the gap is short. But of course takes a very long time. An entire craniotomy is almost impossible. But the opening of the internal acoustic meatus, the posterior clinoid, in the cellar
anterior clinoid,
the endoscopic. That is the use, the preciseness, the safeness, and a sort of better bone healing. This was the concept. But of course, we use in combination. Not.
Please, in the next time you give this presentation, give the credit to Professor Vercellotti, because he deserves it. Yeah?
Okay.
Yeah?
Okay.
Professor Grottenhuis, can I just make a general comment, not in skull base? I have used the piezo surgery in craniofacial. It's a nice cuts, but again, it's beautiful cuts compared to the bone loss that we have with the drill, but the time, so we have it nicely packed next to us. And Professor Ludwig, Hans Ludwig, posted from Göttingen, and he posted, he donated one of his operative videos for pediatric spine surgery when he did untethering, and it was absolutely beautiful. The little loss of bone, very tidy operation, and certainly I think there's a nice indication for
laminotomies. Yes, that
yes,
was interesting. Yes, I agree.
I use the oscillating saw for the laminotomy when we
it's also
the same cut.
Yeah,
can also be used. So we have to continue, Naren. We are running out of time.
No problem. Time is always elastic.
The Italian girls are very active. So we have another talk from Italy about skull-based craniofacial approaches to minimize approach-related mobility for intracerebral complex neoplastic and vascular lesions. Maria Rossella Fascinella, please.
No, Serena.
You have to stop.
Serena, you have stopped screen sharing. Yes, and now Rossella can. Yeah.
Good morning.
And again from Ancona. Oh, that's a very
we're a big team.
Yes, very good.
Good morning, everybody. I'm Zacher Pasinella. I'm from the neurosurgery department of Ancona. And today I'm going to talk to you about skull-based and craniofacial approaches to minimize the approach-related morbidity for complex lesion. So let's start from saying that over the past decades, the evolution of the treatment goals of skull-based surgery has evolved, both for minimize the morbidity and to maximize the quality of life. Very often, a minimally invasive surgery may have less impact on morbidity, on quality of life, but the label minimally invasive may turn out to be a misnomer, being associated more with a different morbidity profile, rather than less morbidity at all. So how to choose the best surgical strategy and the least invasive approach? For example, by remembering that there are no fancy or obsolete approach when the goal is to reduce the manipulation of the neurovascular structures. Like the Dr. Sami said during a conference in 1995, the skull base is like a no man's land. So where there is a mix of multiple specialties, from maxillofacial surgeons, ophthalmologists, ENT surgeons. So the multidisciplinary approach may be vital, essential to guarantee the best surgical option for a patient. The first illustrative case I'm going to present to you is about a 48 years old male admitted for intense nuchal headache, but no focal deficits. So the basal CT scan showed us a subarachnoid hemorrhage of the basal cisterns, and the following DSA study detected an arteriovenous malformation whose arterial origin was from an abnormal right pontine artery and ICA, so classified as a Spetzler-Martin grade 4. Both the lesion, so the aneurysm and the AVM, were considered not suitable for an endovascular treatment because the origin angle from the basilar artery was too sharp. So this is why we opted for surgical treatment. The goal was to treat the AVM, reducing the flow, and trying to potentially eventually provoke the disappearance of the hyperinflow aneurysm. So we chose the Cavazzi approach, subtemporal craniotomy with anterior petrosectomy, and this is the video. So after the exposure, replating and removal of the zygomatic arch, we add the access to the middle fossa floor, and so we started with the petrosectomy, also with the helpful use of the tool my colleague speak about just a few minutes ago. So also with the endoscope, we were enabled to reach even the darkest corner of the surgical field. And then the nidus of the IVM was isolated and coagulated by bipolar categorization. And then we performed also a closure after a final control, also with the endoscope, to be sure and to verify the safety of the neurovascular structure. We performed the reconstruction of the middle fossa floor by sealing the bone defect to prevent the CSF leakage. So the postoperative results, there was no angiographic evidence of an AVOM residual, and the patient had no neurological deficit except for transient diplopia due to 6th cranial nerve deficit, but he fully recovered in the following weeks. So the last DSA study also showed us a spontaneous and complete disappearance of the hyperinflow aneurysm, which was our initial goal. And the second illustrative case I'm going to present to you is a similar clinical scenario. Is a 63 years old male admitted, even in this case, for acute subnuchal headache, dysarthria, and vomiting. In this case, also we found an AVOM with an arterial origin from the ICA with an hyperinflow aneurysm. And even in this case, for an intense vasospasm, which was found at the DSA and the aneurysm enlargement, it was considered, even in this case, unsuitable for the endovascular treatment, were unsuccessful. And even if it is not the most common way we have to treat an ICA aneurysm, we opted for a transmaxillary transclival Lefort type 1 approach in collaboration with the maxillofacial surgeons. This was our choice based on the angioarchitecture of the aneurysm. We had in this way a direct entry on the lesion, which was the source of the bleeding, actually, no brainstem retraction and neurovascular structures manipulation. And at the end, a good surgical exposure of the aneurysm. The postoperative results in this case, you can see in the images above on the left, the clip positioning and the surgical trajectory. You can notice also how the patient could experience a good aesthetical result, notwithstanding the apparent invasiveness of our approach. And the residual AVOM was then referred to the Gamma Knife radiosurgery. So, to conclude, the surgical route must always be tailored on the patient's anatomy. And even if minimally invasive surgery is preferred when we want to reduce the morbidity, an open craniofacial approach should always be involved in part of a neurosurgeon's armamentarium for the complex skull-based lesions. And we wanted to underline, even in this case, the essentiality of the multidisciplinary strategy. So thank you for your attention.
Thank you, Maria, for this nice talk and showing challenging cases. So I agree, the first case is, I think it's a very nice approach to deal with it. And as you have shown, it was a very good outcome. The second one, I am wondering, should that not be better done with an endoscopic endonasal approach nowadays and not the Lefort? When I was young, my older chairman, he also did a chordoma together with the craniofacial surgeons, and they make a Lefort osteotomy. But this is exactly midline. Why you haven't used an endoscopic endonasal approach for that one?
I think that it was mainly for the space we needed for the clip positioning. Maybe by this approach we could gain some millimeters more to have a better manipulation and maneuvering space to position the clip, I think.
And maybe also the closure, because sometimes in the endoscopic approaches to the skull base, when you place the clip, the end of the clip can hamper your proper dual closure technique and your flap. I had to treat once a case where they did try to do it with the flap, but the clip went through the flap after all. We had to do a second surgery. So it is
But dural closure, Andre, should be the same problem with the other approach, because you have
well,
to
not necessarily. You have, it's more wide. You can you can do more because it is in the open approach. You can even use suture techniques. But I have to say, it was challenging. But I very much liked already in the very early beginning from your talk is that you said minimally invasive is maybe a misnomer. But I think that is true because
on the bone.
Yes, but our patients think that minimally invasive is also not risky at all. It's a little surgery, and that's of course not a detail. This is major surgery. Actually, I always like the physiology or the philosophy of Axel Panetsky, who said with his keyhole approach, it is minimally invasive means the smallest approach to reach the maximum effect of the surgery. And therefore, if you have a 6 centimeter meningioma here at the vertex, you cannot have a 1 centimeter opening. That's of course ridiculous. So it always depends on the lesion you have to treat. And sometimes, yes, we have to do a large opening and be more aggressive to the bone, as Mauricio was saying correctly, and gentle to the brain. That was always, I mean, this was general skull-based thinking. And now we do less invasive, but through the nose, we can also be very invasive. We can make huge defects in the skull base that you can't see because it is through the nose, but we can be very, very, very invasive in that sense. So the problem, the point is, and that was very nicely illustrated here, that it is the individual tailored approach to that lesion of that patient. And the next patient will have another kind of approach. That's also the thinking of minimally invasiveness and keyhole approaches. That's the tailored approach to this individual patient. So that was nicely illustrated. I liked it very much.
Thank you.
The idea coming from a case we saw with by Paul Gardner in Pittsburgh that did a sort of the, and I simulate the clipping of aneurysm in pituitary adenoma. Even with the Panetsky clip that opening inside the lid, but really the space was really narrow. You cannot see, so it was really risky. But the concept was right because the neck was just straight. You pass through an almost natural way. And so that was the approach. And if in the future, or if there is more clip, I don't know, some dedicated clip, maybe it's possible to use, but I simulate the clipping and I feel not confident. This is why I need a little bit space.
That is also something essential. It is also that people, if you, I always say, if you don't have experience, for example, if you see your first case of a colloid cyst and you are very versatile in microsurgical approaches in craniotomy, don't take the endoscope then, because it is about the patient that needs the best possible neurosurgical approach in your hands. So that means also in how you feel as a surgeon, feel comfortable in treating that patient. That's something we tend to forget, but it is also about your own thing. And I like it very much, Mauricio, that you simulate that already before.
Yeah,
that's very nice, very nice.
Okay.
I don't see in the chat any questions. Do you, Henry? No, there was no in the chat, so we can. I think we can
continue. Yeah.
Yeah, with the next two talks that will come from Mumbai, not from Italy this time. And the first is our great friend Atul. Please, Atul, you start with the en masse tumor resection strategy for low-grade gliomas. I'm looking forward to it.
Thank you, Andre. And obviously, I'm not going to introduce to you some huge technical mastery or technological mastery, but I am going to introduce to you a new concept about a tumor which we do, which is a most common tumor that we do in our subject of neurosurgery. So the concept is that gliomas are confined and they grow along a named white fiber tract. And according to my understanding, this is a revolution in the understanding of gliomas and more importantly, in the surgery of gliomas. According to this concept, is en masse tumor resection a safe surgical strategy for low-grade gliomas? This is what I am going to talk about. How the gliomas grow, what is the pathway of growth of gliomas? Not many articles are there in the world literature, except one, which is by Yasargil and of course some by Dufau and others. The mention is that they grow along the vascular territory of the brain, and when the tumor grows, it grows in a wedge-shaped fashion. So this is one article from Yasargil. We know low-grade gliomas, and we have learned low-grade gliomas from the teachings of Dufau, from Michberger. We have understood high-grade gliomas, and we have heard the presentations from Michberger. And most of the technological advances in neurosurgery have been focused on how low-grade gliomas should be operated, whether it is neurophysiological monitoring, intraoperative monitoring, various dyes. But the most important revolution in the understanding of low-grade gliomas is by understanding of fiber tracts of the brain. And we in our department have produced several fantastic articles on the neural circuitry of low-grade gliomas and fiber tracts. And what are the functions of fiber tracts we know very well, and some of these are mentioned in our article, and how these fiber tracts functions we know, and they were not known elaborately few years ago. Maybe not more than 10 or 15 years ago or 20 years ago, this understanding has become profound and it has become intricate in the understanding of fiber tracts of the brain. So we divided fiber tracts into 5 groups. Superficial group are the short association or arcuate fibers. Middle group are fibers of middle longitudinal fasciculars, uncinate fasciculars, IFOF, and things like that. Deep group is along the ventricle, like fornix, striae terminalis, striae medullaris. Central group is the corpus callosum, anterior commissure, these kind of commissural fibers. Vertical group are internal capsule and thalamic radiation. And this we divided in these 5 groups. We divided low-grade gliomas into 2 groups. One is localized glioma along the short arcuate fibers, for instance, and these are localized gliomas. Diffuse are like those arising from commissural fibers. They grow along the commissurals, and this extension is diffuse or widespread. So this is our division. And we introduced this article where we mentioned that what are the radiological parameters of anatomical extension of gliomas along the white fiber tract. So this is what is the subject. And we needless to say that understanding of white fiber anatomy is the most critical part. So my concept is that low-grade gliomas are defined tumors, are confined tumors. They grow along a white fiber tract and they displace the adjoining tract. More importantly, you can find a plane of dissection along the tumor and you can save the adjoining tracts, like even the projection fibers, the SLF in this instance. So they are defined and confined like meningiomas, like extramedullary tumors. And you can remove it like pituitary tumor for Cushing nodule. You can have there is a kind of a pseudo capsule and you can have a plane of dissection. So that is the concept. They create neurological deficit not by destruction, but by compression. And if you remove this tumor within the defined plane, that compression can be removed and the person can improve in the deficit. So this post-central tumor, low-grade gliomas displace the projection fibers, and the deficit are by virtue of pressure, and you can have a well-defined plane of dissection. This tumor, how it displaces the IFOF, it displaces the arcuate fasciculus, and you can have a well-defined plane. That is the concept. My understanding is low-grade gliomas and high-grade gliomas are both confined tumors. But as far as the intraoperative situation is concerned, and you can develop a plane of dissection for radical tumor resection. So now, for instance, this is in the supplementary motor area. You can imagine the relationship with the motor strip. And I want to show you a complete tumor, complete surgery. Now, you can have evoked potentials handy, but now with my more and more experience, I'm not even using these on a regular basis. What we do is have navigation, identify the location of the tumor. Then with your vision, you can identify the tumor from the adjoining normal brain. You see how I am designing a plane of dissection in the most critical area of the brain. If your understanding is incomplete, you can create a very huge deficit in the supplementary motor area, and those deficits will be permanent otherwise. You see, I am showing you an unedited version of the operation. And you see, I'm designing a plane of dissection in a form of how you design along the pituitary tumor in a case of Cushing disease, that nodule, like adenoma. Similarly, how my suction is dissecting. It is like a sweeping movement in a plane of dissection from normal to abnormal. And if you have realized there is not a single coagulation in this operation, in most instances, I'm not saying never you do and all those things, but by virtue of consistency, by virtue of vascularity, and more important is designing a plane of dissection, you remove the tumor and design a plane. So the thing is, even in this most complex of areas of the brain, and you have seen this not even 2 minutes of unedited version of surgery, I'm designing a plane of dissection and removing this tumor en masse and completely. My feeling is you can do this in the most dangerous areas. You can do a radical dissection, and you can improve the deficits which were there and which I have mentioned that they are by virtue of pressure and not by virtue of destruction. So this is a alternative kind of concept which I am showing you, and I am not showing you a hugely technical mastery in this operation, but a most beautiful concept that you just enjoy and see. So in these 3 minutes, I have almost completely resected this tumor. And if you have realized, I have already mentioned this is unedited version. There is no coagulation that has come into picture. So this is the complete tumor resection, and these are the motor evoked potentials after surgery. Now I'm going to show you another tumor, and you see the location of the tumor, and everybody of you will believe completely that this is a very highly critical area and all those things. And I want to show you an unedited version of this. Whatever editing is being done is by my mouse here, which I'm moving a little faster or slower. So you see how I'm designing a plane of dissection in the one of the most dangerous, one of the most critical areas of the brain, by going around the tumor, by visually analyzing the tumor, by feeling. This suction is not a suction. I'm sucking, of course, sucking away the blood, but the tip of suction has my eyes. I know exactly by feel, by consistency, by virtue of the technique, by the texture of the tumor, by virtue of the vascularity. And you see how I'm designing a plane of dissection. And this is I have a feeling that if you have this, this confidence in this concept, you can do a radical, and you have to understand that this is the motor strip which I'm dissecting away from the tumor. And unless and until I have a clear understanding of this concept and a clear plane of dissection that I can develop during operation, this kind of surgical resection is impossible, or you create a huge deficit. And as I have mentioned for the 4th time, this is not an edited tape. This is a complete operation that you are seeing little bit editing here and there, maybe, but you see there is hardly any coagulation and the whole tumor and nothing but the tumor. We have discussed with our neuropathologist on several occasions, the entire tumor, except on the periphery, there is some specks of normal brain, but the whole tumor, whole specimen is tumor and nothing but tumor. The concept is first identify the tumor by virtue of its color, and then design the tumor from the adjoining brain by navigation and intraoperative ultrasound. And then you see in the most critical motor area, and this is the patient in the COVID times. So en masse tumor resection is a huge possibility, and this tumor has a confined kind of extension and location. Even the connectomes are displaced by the tumor, and you can design a beautiful operation. So this is the tumor. You can have functional mapping and all those things. So you can avoid, and this is the surgery, and I'm going to show you the entire operation in 2 or 3 minutes by virtue of this technique and virtue of this concept. And you don't have to, I'm just a little bit hurrying here because of the time. Even 3 minutes is long time to make such a presentation. And you see, you can design a little bit of dissection plane around the tumor. And this suction tip is my eyes. And I can feel even in the bloody territory how I have little bit coagulation is coming here. But this is a kind of a rare situation that if it has to come, it has to come. But you see the whole tumor and nothing but the tumor, by virtue of its consistency, by virtue of its vascularity, by virtue of its feel by my eyes and visual impact, you can have such a resection, and you can avoid awake craniotomy. You can avoid neurophysiological monitoring. Avoid. I'm not saying don't do. I'm saying you avoid. You can avoid. And you can avoid awake craniotomy if you are very convinced about this concept, which I am absolutely, with my experience now over several years. I have not made too many presentations on gliomas in my career, but you see, this is a surgery which we commonly do, which I have been involved all my career. And this is the way I do this with dissection plane in a critical area of the brain. You have to, of course, identify if you have like a meningioma, like a nodule that you removed in a Cushing disease. If you are able to remove completely that nodule, you cure the person. I'm not saying that gliomas can be cured and glioma cells are not around the tumor. Of course not. Glioma is a malignancy. It is an aggressive tumor. But for surgical issues, we have to realize that you have to do radical resection, and you see such a radical resection is possible with this kind of understanding. And this is the tumor. You see how this tumor has been removed. This is another tumor. I don't want to show you. You see the color and adjoining brain, and you can quite safely develop. I want to just show you the last few things in this tumor, and you see how this tumor can be removed with a well-defined plane of dissection, and there is no need for monitoring or even awake craniotomy or even intraoperative monitoring or even any kind of dyes. You can do a beautiful resection as has been done. So this is my concept on the basis of large number of cases. And in malignant tumors, in glioblastoma, even in those tumors, you can have a well-defined. So the concept is even the gliomas are high-grade glioblastomas are confined tumors, and you can design a plane of dissection around these tumors to do a radical resection. This is in the fusiform. More important is that anatomical understanding. Insular tumors are also in the arcuate fascicular. Understanding of anatomy is critical. Understanding of arcuate fascicles, understanding of uncinate fibers, and all those important IFOF and these kind of fibers have to be understood, needless to say. And if you do not have that understanding, you should not even attempt these kind of surgery. So insular tumors, if I have to say what is the most critical issue in insular tumor, you have to save every single blood vessel, every single perforator. And if you damage, you create deficit. This is in the Broca's area. And this is obviously a dangerous area. So I tried awake craniotomy, but this man just refused awake craniotomy. And I will show you how I did this operation with this concept. The most beautiful concept in insular area is you cannot damage a single vessel. Identify the tumor by virtue of color if it is surfacing. If it is not surfacing, open the Sylvian fissure, identify the tumor. And I will just rapidly show you how I design a plane of dissection in this tumor. And I am editing here with my mouse. And this operation lasted not more than 10 minutes or 5 minutes. And you see how I'm getting a plane of dissection. You see this? How this beautiful, this plane of dissection in the most dangerous area. You cannot make this person aphasic and say, I have done this en masse, I have done this like this and like that. You have to preserve the function of the patient. And also everybody in the world now agrees that radical surgery is better in the longevity of the life and quality of life is improved. You see how the plane of dissection I am getting around the tumor. And I have to tell you that this kind of plane of dissection can be consistently available. And you have to just see what I'm showing you. And you have to also realize that in my presentation, which is of 15 minutes, I've almost shown you 4 or 5 complete operations. And you know, many of these things are done in hours and with all kinds of monitoring and all those things. I don't want to show you. Papez circuit, beautiful anatomy has to be understood. And this is for the first time we remove the entire Papez circuit from the brain in its entirety. Corpus callosum, how it extends, is the most magnificent structure of the body. How it extends and circumferentially envelops the ventricle, goes along each and every critical territory of the brain, and how you remove this tumor, how it displaces that joining, never it will encroach into the projection fibers. You can develop a beautiful plane of dissection and remove this tumor. In consideration of time, I cannot show you these tumors. This is a tumor in the parahippocampal gyrus. We removed it by middle temporal gyrus approach. We described it for the first time, how the optic tracts, how the other important tracts are displaced by the tumor, and how inferior temporal gyrus approach is beautiful, has been discussed in this article of mine. Orbital cortical approach we described for paraventricular tumors, and this we recently published our anatomical correlates for these tumors and how to save uncinate fibers, how to save IFOF fiber is obviously a very critical part of this operation, but you can do a beautiful resection and essentially en masse kind of resection in these tumors. Brainstem is another chapter I will discuss with Naren for my next presentation on brainstem tumors and gliomas. So thank you very much, my dear friends.
Well, thank you, Atul, for this wonderful presentation. I only saw one question in the chat that I will ask, and immediately is: do you use cranial ultrasound?
Was that?
I don't know. This was the question. Do you use cranial ultrasound?
Yeah. Intraoperative ultrasound is the most important navigational tool for me.
It's real
intraoperative.
Real time.
Real time intraoperative ultrasound. Navigation, of course, has to be used, but more important than anything, your visual impact of the color, of the consistency, about the vascularity is the most important thing for me.
And that is one of the things you can't see really on the videos, that is this difference in consistency. Because there is a difference when with the suction tube, you more or less can dissect, because normal white matter has a different consistency than the usually somewhat more softer glioma. No? And the what we call the oligodendrogliomas are often a little bit more firm, but there is a difference in consistency. Actually, what I, because of this importance of white matter tracts, I had all my residents already in the past 2 decades learn in the lab to dissect white matter tracts with the Klingler technique. Then you learn about, we know cortical anatomy, but white matter anatomy, to get a 3D understanding, and actually several of them have published nice studies with using that technique, for example, on anatomical substrate of mutism to find out the dentate, the thalamic rural thalamic tract, and you can dissect it, and you start to understand the whole 3D of white matter in the brain. And that is, for me, I would say this would be so important for all neurosurgical residents to study this. Absolutely.
No question. Artur, thank you for the nice presentation. But
yeah.
This technique, of course, is only working for superficial lesions. If you have a deep tumor, I hope you will not advise to make en masse resection because you have a small craniotomy. Sometimes we use even a tube to go too deep down to these lesions. And you are right, there are some gliomas where you have a good plane, at least you think there's a good plane, but there are also the diffuse astrocytomas, at least in Germany, where I cannot say this is the border of the tumor because it goes very diffusely into the brain, and you see initially it's clearly tumor, it's a little bit more fibrous, more firm, and then it disappears, and it looks the same. And if you take a biopsy from this specimens, always a pathologist say there are some tumor cells leaving, unfortunately. So it's not like a meningioma, please. Don't say that.
Henry, I'm not saying that whatever I'm saying is, this is my concept and this is the way I do. Even in, like for instance, in the insular area, nobody will do en masse resection and damage the blood vessels. No, I'm not recommending that. I'm saying that you keep this concept in the insular area also. When you are having an issue, you can come around it. Along the uncinate fascicle, you can come around the tumor and remove the part of the tumor like that. So basically, you keep this concept, and even if in the critical area like insular area, where blood vessels are the most critical, as I mentioned, you keep this in mind, but you can come around get a plane of dissection if you have to do a complete radical resection. And if you are not getting a plane of dissection, you have not done a radical resection. This is my firm belief, Henry.
All right.
Okay. Thank you very much, my dear friends. And I have to leave, so please pardon me, and you please continue to enjoy.
But Abhida will be now following you, so he will be around.
So the next talk will be connectivity of the supplementary motor area in the clinical anatomical analysis of the SMA syndrome. Please, Abhi.
Hi, good evening, good morning, good afternoon, everyone. Can you see my screen?
Yes.
So we've seen the concept just illustrated by Professor Goel, how we are performing glioma surgery in the department. And I'm going to discuss this ill-understood entity of this SMA syndrome and how you can analyze the cause of its complications by understanding the connectivity of the supplementary motor area. So the motor network of the brain consists of these 4 components: the pre-supplementary motor area, which actually plans the movement; the supplementary motor area, which initiates, executes, and coordinates the movement. So it essentially performs a learned movement; the primary motor area, which commands the movement; and the sensory cortex, which gives sensory feedback and adaptation. So these are the main components of the motor network: the pre-SMA, the SMA, the motor area, the sensory area, the internal capsule, and other various fibers that I will show you. So if you see the surface of the brain, this is the central sulcus, this is the precentral gyrus, the postcentral gyrus. This yellow circle here is the supplementary motor area. It is bounded laterally by the superior frontal sulcus, posteriorly by the precentral sulcus, and it extends on the interhemispheric region on the medial side of the hemisphere. These areas that you see is the motor activation area, the classical omega area that you can see here. And this blue circle where the superior frontal and the precentral sulcus meet is the dorsal premotor area. On the medial aspect of the hemisphere, the SMA ends at the region of the foramen of Monro, and actually in a perpendicular plane which crosses the plane of the anterior commissure. So this is the region of the supplementary motor area and the pre-supplementary motor area of the superior frontal gyrus. Also, it is quite nice to know that SMA also has a somatotopic organization similar to the motor cortex, where the upper limb is represented anteriorly and the lower limb is represented posteriorly. The pre-SMA has an organization similar to the sensory cortex. So what is the SMA syndrome? The SMA syndrome is a transitory akinesia of the hemibody contralateral to the damaged side. So basically, the tone of the patient is normal, the power is normal, but the patient is unable to move the limb. This may be accompanied by varying degrees of aphasia, or it may be associated with mutism when the lesion involves the dominant hemisphere. So as you have seen in these various concepts that Professor Goel has just illustrated, these are our various papers on the subject. So this is a tumor. You see here, this is the central sulcus, the precentral gyrus, postcentral gyrus. This is the supplementary motor area represented in this anatomical image. And you see post-operative, post-resection, the motor evoked potentials are normal. A radical resection has been performed. But this is what happens to the patient. This is an Indian language, but you see she's having difficulty in initiating her name. She's being told to say her name.
Okay.
She's been asked what it is. She's unable to name it. She's trying to name it, but she's just unable to perform the activity. It's not that she's not understanding. She's understanding, but she's not able to say her name. Sorry for that. Now you see her limb activity. So this is the left side, which is completely normal. Now you see the right side. She has power, the tone is okay, but she's unable to initiate the complex movement. So you see the power is okay. Once it is up, she's able to bring it down. But when asked to initiate the movement, she's unable to do it. And this is after a few days, not before discharge. It's just a few days after surgery, and now you see. She has started verbalizing. This is just a few days after surgery. She's not yet been discharged. She's standing up on her own. She's moving her left side well. She's also started moving her right side. With all motor activity preserved, she's able to walk. And a few days after that, when she came back to us, she's absolutely normal. So this is the supplementary motor area syndrome. Now, so you see this another tumor in the pre-SMA region. So this is the central sulcus, the pre-central and the post-central gyrus. This is the SMA, and this is the region of the pre-SMA on the right side. And as you can see, a radical resection has been obtained. Now this is the patient. So his right side is okay. He's able to verbalize well. He's able to follow complex commands. Now you see on the left side. Now you see, we are lifting the hand, we are keeping it up. You can see he's able to move now. Now he's able to move. So indicating that the power is normal. This is for the lower limb. So when helped, he is able to perform this. And this is a few days after surgery, and you can see it's absolutely normal. So you can see that he's absolutely okay. There's another tumor in the SMA region who developed an SMA syndrome in the post-operative period. A radical resection has been obtained, and this is a patient few days after the surgery. Now, this is an interesting case which I want you to remember. This is a region of the SMA, but as you see, it is going right up to the corpus callosum with some enhancement in this area. A radical resection has been obtained along with part of the corpus callosum. You see the preoperative DTI where it is extending up to the corpus callosum. This is an important aspect while understanding SMA syndrome, as I will discuss later. I will not go into the videos of the presentation. This is the patient, the one I just showed you. This is in the immediate post-operative period. So you can see that she's moving her left side well. Right side, as you saw in the previous videos, she's not able to initiate the movement. And this is a few days after surgery. There you can see she's moving both her limbs well. She's moving both her lower limbs well. And a few days after the surgery, she's absolutely fine and comes back for the follow-up. And this is an interesting case, which I did, a bilateral parafalcine meningioma, where it was resected completely. This patient interestingly developed a bilateral SMA syndrome. She was kind of quadriplegic, and mute immediately after surgery. But 3 months after surgery, she was absolutely normal. So what is this SMA syndrome? As I showed you on the cortex, this is the SMA, this is the pre-SMA. It is connected to various areas of the brain. It is connected to the motor area. It is connected to the limbic system. It is connected to the basal ganglia. And it is also connected to the inferior frontal gyrus. So these connections are by the short and long association fibers. So this is an image. This is the region of the SMA. And these are short arcuate connections which connected to the middle frontal and the inferior frontal gyrus. So if you see this lateral image, this is the connection of the SMA to the precentral gyrus, this circle here. These circles show the connections of the SMA to the middle frontal gyrus and to the inferior frontal gyrus. This is the connection, just to show you, of the middle frontal gyrus to the precentral. And these are the connections of the inferior frontal gyrus to each other. Now the fibers on the middle aspect of the SMA, which connect it to the various aspects, is the cingulum and the SLF. So this part is the middle part of the SLF or SLF1, and this is the cingulum. So the cingulum connects very prominently by a fold that you can see here to the pre-SMA region, as you can see in this image. It also connects to the region of the precuneus. So this is how the SMA connects to the limbic system via the cingulum. How it connects to the inferior frontal gyrus. So this is the yellow circle shows the Broca's area, which consists of the pars triangularis and the pars opercularis. And this area here, right in front of the precentral gyrus, is the ventral premotor area. Stimulation here will cause a speech arrest. When you dissect in this region, the first fibers that you will see are the arcuate fasciculus and the SLF 2 and 3, or the lateral part of the SLF. The important tract that to note here is the frontal Ashland tract. This is the tract that connects the superior frontal gyrus, or the SMA and the pre-SMA, to the inferior frontal gyrus. As you can see in this image, here you see them more clearly. These are the fibers of the frontal Ashland tract. How do you distinguish them from the fibers of the external capsule? Is these fibers run lateral to the superior limiting sulcus of the insula, and the external capsule fibers run deep to the superior limiting sulcus of the insula. So you see this magnified image showing the frontal Ashland tract, which connects the superior frontal gyrus to the inferior frontal gyrus, and is the reason why there are problems with speech during the SMA syndrome. The other connections of the SMA to the other areas is, this is the region of the insula, and here you can see the claustrum, and you start seeing the claustrocortical fibers. The claustrocortical fibers are actually parts of the dorsal external capsule, as you can see here. So the external capsule merges with the internal capsule and forms the corona radiata. These are fibers of the dorsal external capsule or claustrocortical system. These are frontostriatal tracts and the claustrocortical fibers. You can see it clearly here. This is the putamen, this is the external capsule, and these are claustrocortical fibers. Going deeper, these fibers also connect to the putamen and this is the frontostriatal tract, as you can see here, and also the corticoputaminal tract. So these are the connections, how the SMA and pre-SMA connects to the basal ganglia, and how does recovery of the SMA syndrome occur. As you know, the brain has a lot of potential for plasticity. And this major structure, the corpus callosum, which almost connects all areas of the brain, plays a major role in plasticity for the supplementary motor area. So you see this, the pre-SMA and the SMA are very largely connected to each other by these corpus callosal fibers. And these callosal fibers are actually responsible for the recovery of the supplementary motor area. What happens basically is that the contralateral SMA takes over the function of the affected SMA and the patient recovers. But if you remember, I showed you one patient where we transacted the fibers of the corpus callosum also, the callosal fibers that connect the pre-SMA and SMA. So we speculate that apart from the callosal connections, it is also these short arcuate connections, which are multitude in number, which connect the superior frontal gyrus to the middle frontal gyrus and the inferior frontal gyrus, also take over the function. And that is how plasticity of the SMA occurs. Thank you very much.
Thank you for this nice presentation. Really a great job done in the lab. Very interesting to see all these fibers. I think it's very important to understand. When I was a student, and our anatomist said, the fibers you don't need to know, it's just like rucksacks, all connects to everything. So it's very easy for you to answer any questions, but you have shown very nicely that it's different. Yeah, we have sometimes patients with these tumors in the SMA. And for these tumors, we never make an awake craniotomy, because if you make an awake craniotomy, you stop too early and you leave tumor, which is not necessary. I have one case, there was an AVM in the anterior part of the corpus callosum. Around, I would say, 1/2 to 2/3 was involved, and I had to cut all these. And this was an acute disconnection syndrome. She could not understand us. She was only moving one side. So the left hemisphere understood and could move the right one, but the other side not. Why it came back so early? So after about 5 days, it recovered. How do you explain that? Because the fibers are cut, so they will not reconnect. How can this improve so quickly?
So that is what we have also observed, that the SMA syndrome in most of our patients started recovering within the first 4 or 5 days. And as I showed you in one of my patients, we had cut the corpus callosum. So if you go through the literature, plasticity of the SMA is explained by these callosal connections. But I think that there are multitude short arcuate connections. So you're disconnecting the SMA and the frontal aslant tract, but you're leaving the connections that are superficial, that connect the superior frontal gyrus to the middle frontal gyrus, to the precentral gyrus, and to the inferior frontal gyrus. I think some of these connections take over on the ipsilateral side, and that's how it recovers so fast. I have not yet proved it by any tractography or something like that, but I'm looking towards trying to get an explanation for this.
Yeah, very interesting. Andre, any comments?
No, absolutely. As I said, I started 20 years ago to make it an obligation for all residents to go to the anatomy lab and study the white matter tracts. This is a nice technique. Does everyone know the Klingler technique? Yes. First, you have to fixate the brain, then you have to freeze it, and then you have to thaw it, and then you can nicely study the white matter tracts. That's and you learn a lot of that anatomy. And as you said, Henry, and also in my med school in the 70s, that was nothing. Zip, zero on white matters. Yeah, that's true. Based on the time, I think we move on, because yes. I don't see questions in the chat to that. And it's a pleasure for me to now see and introduce my friend from Thessaloniki, Nikos Sirmos. You were there. Please share your screen.
Hello, everybody. Good evening, or good afternoon, or good morning from Thessaloniki, yes. Greece. It is a great pleasure, a great honor to be in this conference organized, promoted by my friend Naren. Great pleasure, because I see and I saw before, and I saw now great friends, as my friend Andre from Holland. true master of neurosurgery. Also Professor Schroeder, old friend from endoscopy courses, and also other great friends as Baga Karupanan, and before Mario Ganao from Italy, my dearest friend. I will speak about history of neurosurgery. Is one of my interesting research project. The most important steps of neurosurgery as a medical discipline, and I try to answer this question: if does knowledge of the past determine the present and the future? This is the important question to respond. For many time and for many colleagues around the world, still now, history is the dark side of the moon. And sometimes we think that speaking about history is not an important knowledge. But let's see how neurosurgery starts. And if we saw the Bible, we saw mythology, we saw Cain and Abel to fight, and Cain.
Because your slides are not moving, so you should go to presentation mode. And then, because it is still, we only see a small part of it. Yeah, now we see the moon, but it is not in presentation mode. It is not in presentation mode, so it is not large. We see all the other slides in small, still to it.
Now it's better.
No, let's see. Yes, this is better. Absolutely. This is Cain and Abel. Okay.
How everything starts? Cain and Abel. Cain kills Abel with a hit. The first craniocerebral injury of mythology, and after. Not moving.
It's not moving now, so that's odd. Use your arrow and go all the way down to that little screen there. No. This is. You were in presentation mode. You know where it is in PowerPoint? You don't see the screen anymore?
One moment, dear Andrea, one moment. It's technology problems.
Mm-hmm. But go down, and now your arrow is at presentation mode, yes. So click on that, it should be enlarged. Click, no, click on that one, yes. Why is it not enlarging then? That's strange.
Okay, that's okay. If you press.
Can you see now?
Yeah, if you press function 5, then it should come as well.
Yes.
If you go to the top one where it says presentation and click on presentation, it goes. Otherwise, you can carry on. It's not a problem. We can see it.
Okay. And we are moving into Zeus, the Greek the Greek king of the gods.
No, Naren, we don't see it.
No, we don't see it.
Because it is now still on the first slide, on the introduction slide.
Sure.
But why?
Nick, if you go to your presentation, and that's it, yeah.
Yes.
Now use your arrows to go back and forth.
Try to use arrows. See if it's moving.
The forward and
not
forward
your mouse. Not your mouse. Use the arrows on your
Yes, I am using my arrows. Yes, but I don't know why she doesn't move.
It doesn't move. That's very strange indeed.
Okay. If you right click it, you will see on the screen. If you right click, you should see arrows that you can see. You can on the bottom you see on the left hand bottom you see arrows. You can click that one to move. Here, if you come to the left hand, you can click on that one.
Now?
Yes.
He's moving now?
Yep, yep.
But the best is to use the keyboard arrows. That is good. Yes, yes.
Yes, okay. I talk about Zeus and then Hippocrates, who was the first documented neurosurgeon and also spine surgeon of the history. But all the rise of the ancient civilizations have some important steps in the history of neurosurgery. We are moving into our father, who is Harvey Cushing. In the beginning of the 20th century, he separates neurosurgery from the general surgery. He is a masterpiece of surgery performance, and all the kind of operations that we are still as neurosurgeons operated. Also, Harvey Cushing, before 120 years before, he was able to perform. Another important figure of this history was Walter Dandy, the first perhaps pediatric neurosurgery of the history, and the relationship between Walter Dandy and Harvey Cushing wasn't very good. And this is perhaps an example how our relations and our professional and how professional relationship between neurosurgeons are. A very important figure of the history of neurosurgery for the European history this man here was Victor Horsley, who performed in the same period of time with Cushing and Walter Dandy. He performed also functional neurosurgery of his era. A very important step, a very important evolution was the introduction by Mahmoud Ghazi Yarsagil, the introduction of microscope. It's microscopic neurosurgery. It's a very important step. But also the introduction of neuro-intensive care and the introduction and the beginning of neurorehabilitation. A very important step and a very important talk is about how we can manage as neurosurgeons to collaborate with other disciplines. It is a very important topic, this, how we can manage to collaborate with psychiatric doctors and also with neurologists. This is a very important thing and a very important consideration. We cannot make nothing without images. Images are very important in neurosurgery, and the introduction in the early 70s, the beginning and in the decade of 80s, the huge expansion of CT images, and the beginning for the 80s and the huge expansion in 90s of MRI scan and all the consequences of MRI evolution. The introduction and the foundation of important organizations as the WFNS in 1955, and after the years, André was also a great president for the European Society, but also and other societies around the world, as the Asian and the American and the African Neurosurgery Society was very important, because we met in a discussion, we met all the neurosurgeons in a dialogue. Dialogue is very important. We must learn to listen the other colleagues. It's very important. In the field of pediatric neurosurgery, the introduction of International Society for Pediatric Neurosurgery and the European Society for Pediatric Neurosurgery was also important. In the field of introduction of International Society of Pediatric Neurosurgery, a leading figure was this man, Anthony Tony Raimondi, an Italian-American neurosurgeon, in the beginning of his career, first in Chicago and after in Verona and after in Rome. He developed the International Society of Pediatric Neurosurgery. This is a very important photo from pediatric neurosurgeons of his field. as Carlo Mazza, the same Tony Raimondi, Maurice Su, and a great vascular neurosurgeon. He was the mentor of my father, Dappian, a very important vascular Italian neurosurgeon in Verona, Italy. In the beginning, in the middle 80s and 90s, the neuroendoscopic surgery was beginning to perform a very important step in the order of minimal invasive neurosurgery. And the big concept is if it is microscopic assisted neuroendoscopy or neuroendoscopic assisted microsurgery, a very important topic. For the field of the European neuroendoscopic procedures, the leading figures was Kamaert in Belgium, and also a great friend of Greek neurosurgery as Axel Pernetsky in Germany was very important. The introduction first of the International Study Group of Neuroendoscopy and then transformed in the International Federation of Neuroendoscopy, and all the courses and the congresses was very important. A very big question in the early 90s and still now is if we are both brain neurosurgeons and spine neurosurgeons, if we are only brain neurosurgeons or only spine neurosurgeons. It's a very big question. So you look now the new Journal of Ian's Brain and Spine. We don't know. We will see the future how he evolves in this field. And perhaps the exoscope 3D in neurosurgery will be the future, and you see now some characteristics of microscope, endoscope, and exoscope. Perhaps it will be the future. And the young neurosurgeons, our trainees, it is for sure that they will see robotic neurosurgery to come. We don't have to forget the ethic part, how we treat our patients, and we have to manage to follow ethical issues. It's very important. And of course, the last 2 years, the pandemic era and how COVID changed us, and perhaps now with the Omicron metallaxis, after the Delta metallaxis, how our practice will be. And if I can respond in this in my question, I will respond that the knowledge of the past is essential in order to manage the present and essential to determine the future. I want to dedicate my presentation, these small historic presentations, to my great friend that we lost last year from COVID pandemic, James Woodridge, a true master of neurosurgery, true master of pediatric neurosurgery, my mentor for over a decade in ESPN and ISPN courses, and we will remember him as a master of pediatric neurosurgery, as a good man, and of course as good historian, because he wrote many works about history of neurosurgery. Thank you very much, and I apologized for imagined problems. Technologies is the true master, perhaps.
Yeah, thanks. Thank you, Nikos, for this presentation on history. I don't see in the chat any questions, and usually to history, we don't have a lot of questions. We just want to know how this all developed, how we reached the point where we are sitting now. According to the time, and I have to apologize, my co-chairman, Henry Schroeder, because he had to leave now already. I have to leave at 3, so I have a little bit more time, but I would ask you, Nikos, to immediately go ahead with your next presentation.
I will be, Andrei, thank you very much, and I will be very, very quick, because we have to, we have also to make a small
lunch time.
A small lunch, because lunch is very important.
Yes.
For all the Greek and all the the people now. I will move very quickly.
So share your screen again. It works.
I hope to not have the problem of before. Did you see everything now?
Well, like try to get it into presentation mode again, like it was. I don't know how.
I don't know why. Now, did you see?
Well, it is not presentation mode. We go ahead this way. If you,
this is a small presentation about post-concussion syndrome disorder in amateur athletes.
Yes, it's good. This is so we can see it.
The aim of this small study, I was trained also in sports medicine, was to evaluate the post-concussion syndrome in amateur male athletes. We have various athletes as basketball, football, volleyball, boxers, women, and long distance runner. And we saw that the most common disturbances of these young male athletes was headaches and dizziness, fatigue, anxiety, insomnia, and loss of memory. With appropriate neurosurgical, neurology, and psychology support, we saw that the most of them, 9 of them, returned, improved, and returned to physical activity after a small period of time. And the conclusion was that it seems that cognitive behavior therapy and medication would be helpful in patients with post-concussion syndrome. And post-concussion syndrome remains a post-traumatic condition than its accurate evaluation and management. The discussion, I will present them tomorrow because, dear Andrea, I have a similar presentation also tomorrow in the next sessions of this conference. And I dedicate this presentation to our friend that we lost recently, Michel Gerach, true master of pediatric neurosurgeon, a good friend, and we will always remember him.
Yes, this was indeed a very short presentation, and yeah,
I go very quickly.
Yeah, very good, very good.
As say or tachitita that they saw the Greeks in order to manage to have a small break, and I am grateful to my dearest friend Naren. Our souls are together, and our minds are together. And after the Corona pandemic, I don't know when we will be together in real life. I hope so.
We hope so. Yes, we all hope so.
Thank you very much.
So, Naren, I give back to you.
Thank you very much, Professor Grotton-Hughes. Thank you very much, Nikos. Thank you very much, Professor Schroeder. That was a fantastic session. We had an amazing session. Just before we go to the next session, just one quick question to Professor Grotton-Hughes. We just touched on concussion. Professor Grotton-Hughes, in children with concussions, when do you say that the kids can go back to sports? What was your rule of thumb? It's always never short or never long. What's your? How did you approach it?
You mean this is in children?
Children, yes.
I don't think it is that you can have a rule of thumb for that. Of course, they only can return if they are not symptomatic anymore. So, and you have to look for the subtle symptoms, and that was already in the lecture of Nikos also. Sometimes it's only they are a little bit fatigued. They are not, and actually, for me it's very easy. I ask the mother, because the mother usually from a child know my child is not the same as he or she was before. Mothers have 10 antennas for that. Fathers probably only 1, but mothers do have 10 antennas. They know that. So it's and that's the same with shunt problems. I always trusted the mother when they came, doctor, my child is different. We have to believe that because we don't know the patient, and therefore for children there's no rule of thumb. In adults, we usually say that if there was any type of unconsciousness involved, they would not be allowed to contact sports for the next 6 weeks. And that could also be if it is not 50 minutes of amnesia or anything that, but if there is any part of unconsciousness, we really stop them from contact sports. I mean, you can play tennis if you feel well, but so not American football, not European soccer. So anything that involves the possibility to have a contact should be stopped. And to be honest, I think we are only becoming more and more aware of the long-term effect also in professional sporters, that they, on the long term with contact sports, football players, just when they hit the ball with the head, if they do that for 15 years, consecutive years, they can have, like boxers, they can have damage. So this is something that was not so well known. I know in Europe, the one who really studied that was Nicholas Markland, who is now in Lund, but in Sweden. So it is a little bit more awareness now that that we have to realize that these are injuries, traumatic injuries to the brain. I mean, the skull can protect you, but not for everything, especially some contusions that we simply don't know and not aware of. But for children, I never had a real rule. No, not a strict rule.
Fabulous. That's very useful. They're very insightful. Thank you very much again, Professor Grottenhuis. Now we are in electronic world and virtual world. I wish you all a virtual lunch. Because of the time, we have to go to the next invited lecture. Professor, I'm going to invite Dr. Komal Prasad to introduce Dr. Cockcroft. Thank you, Dr. Prasad.
Thank you, Naren. It's a nice conference, intercontinental. It's my pleasure to welcome Dr. Kevin Cockcroft to talk on update on management of aneurysmal SAH. Professor Cockcroft, I had a brief meeting when we had the INRC meeting in Hershey 2 years ago. He's a co-director of Penn State Hershey Stroke Center, director of cerebrovascular and endovascular neurosurgery, professor neurosurgery, radiology, and public health sciences. Over to you, Professor Kevin.
Thank you very much, Dr. Prasad, and Naren. Good to see you guys.
Pleasure.
Even if it is virtual. So yeah, thanks very much for inviting me. This is just going to be a little kind of overview of some of the updates of things that are going on in aneurysmal subarachnoid hemorrhage. It'll be a review for some of you, obviously, and we'll talk about a little bit about some of the controversies that are still going on, at least in the U.S. with regard to ruptured aneurysm management. I'm going to go ahead and share my screen, and we'll get started.
Thank you.
Let me see. Try again here.
Yep. If you have two screens, sometimes you have that problem.
Yeah. Yep, that was a problem. Here we go. How does that look?
Yeah.
Yep, that looks great.
See that? Okay, very good. All right, so as we said, a kind of an update on aneurysmal subarachnoid hemorrhage. Not supposed to be comprehensive, just kind of an overview of a few, I think, important things that's going on. So by way of an outline, we'll start with a little bit of background on subarachnoid hemorrhage. Most of you should already know this, obviously. Quick overview of the management, and then we'll talk in a little bit more detail about aneurysm occlusion strategies and decision-making for that. Then I'll look into complication management, particularly some clinical trial updates, and then some final thoughts, and we'll try and keep this to the time of about half an hour or less, time for questions. So as you probably know, aneurysmal subarachnoid hemorrhage constitutes about 6 or 7% of all strokes. The incidence is about 6 or 7 per 100,000 in the US. That constitutes about 30,000 cases in North America annually. World numbers vary slightly, but that's a good representation. Clinical presentation, classic, everyone knows this, sort of severe cataclysmic headache, worst headache of your life is the usual quote, accompanied by nuchal rigidity, photophobia, focal neurologic deficits are also often present, and you can be as severe as to present with coma. Statistics on outcome are still not good despite many advances in therapy. So we still have a 30-day mortality rate of around 40 to 50%, with 30 to 50% of the survivors being left disabled, depending on how you characterize disability, whether it's return to work or just not being able to take care of yourself. So those are not good numbers, obviously. So in terms of management, the initial management really is this resuscitation, keeping the patient alive and getting them into the ICU, managing their blood pressure, managing their intracranial pressure until you can get to the point of securing the aneurysm to prevent rebleeding. So that's the part of the diagnosis and then treating the underlying etiology. But then in subarachnoid hemorrhage, you're not done. So this is an important part of the management of subarachnoid hemorrhage. It's not just managing an aneurysm, it's managing the entire patient. And so being vigilant for the complications and managing those complications well is a key part to impacting survival and outcome in this disease. It's not just about treating the aneurysm. So in terms of management strategies for aneurysms, obviously microsurgical clipping has been around for a long time, and this is sort of the classic tried and true treatment, and can involve trapping of the vessel, parent vessel occlusion. But traditionally, this is using nowadays a titanium clip to occlude the saccular aneurysm. That's a proven therapy, is excellent durability. However, we know that the morbidity can be high in elderly patients or those with posterior circulation aneurysms. And now that there are other alternatives, this presents even more of an issue. So there have been some advances in microsurgery. This doesn't remain static over the years, but the advances have, I think, less of an impact than we see the advances in endovascular having. So some of the things that I thought worth mentioning, using now the ICG, indocyanine green for non-invasive angiography during the surgery, so you can get an idea, confirmation that the vessels are patent without having to do invasive angiography. Takes a lot less time to do an ICG and a venous injection, get a good view of what's happening with the aneurysm, using a microvascular Doppler intraoperatively, even with quantitative flow. Is another nice way to get some good information about the flow in the vessels and get it rapidly. We tend to also do neurophysiological monitoring, so we're monitoring SSEPs and EEG during the procedure, and that can give you some good information if you have to do temporary clipping, temporary occlusion parts during a dissection of a complex aneurysm. Give you some immediate feedback as to what the status of the brain is in that area. One of the neat things that I've been using recently is an exoscope. So this is a nice change from the microscope in that you really get some 3D visualization, and one of the key points here is the excellent depth of field. So with a traditional microscope, especially under high magnification, the depth of field is not that great, and you constantly have to adjust the focus. Some people are very good at that with a foot pedal and then moving the scope using a mouthpiece. But if you're not particularly good at that, then having an exoscope, and this is just a couple of pictures showing you some of the other techniques, but having an exoscope, which I'll show you here, is our setup. This is a very small scope, and it's right above my head, and I'm sitting here and I'm looking at this huge screen in front of me with 3D glasses on it. It's almost like I'm in the head. The 3 dimensions, and I can move my head and turn, and I'm not encumbered by a scope or a mouthpiece in front of me. Great visualization. Some people say, well, you're not looking at the patient. Well, you're certainly not looking at the patient when you're working through a microscope either. You're looking straight ahead. So I found this to be a really nice adjunct. This particular one is Orbi exoscope. The downside here, though, is that the current version we have does not have the ICG technology. So if I need vessel flow visualization, I really have to do an intraoperative angiogram, which, since I do angiography myself, is not too much of a hindrance. And in this particular setup, you'll see here, if you can see my pointer, this is our angio table right here. Here's the screen, obviously, that I'm looking at as I'm operating, and then we're sitting right here, and we got plenty of room in the base of this Orbi scope is quite tiny compared to, say, a Zeiss Kaniva with a very large base. Slide back here. This was just showing you this is the Charbel flow probe. Great way to get some quantitative information on the flow of vessels that you're working around. Here's some pictures, intraoperative pictures showing the aneurysm with the clips on it now, and then ICG showing the patent vessels next to it, and no longer any filling of the aneurysm itself. So moving on to endovascular. Obviously, this is embolization now with coils, sometimes adjuvant stents or flow diverters, depending on the aneurysm, parent vessel occlusion or balloon occlusion, also techniques for this, obviously. The long-term follow-up in the past has really been the concern here. It's been sort of mixed for some aneurysms, but we do know it's probably safer than microsurgical techniques for other aneurysms. It can be challenging for some configurations of more complex aneurysms, but as our tools get better, our ability to treat these complex aneurysms also gets better. So some of the advances I thought I would highlight, really, because everyone sort of knows about flow diverters and knows about coils and stents at this point, but the intrasaccular flow diverter, the Webb device, is sort of the prototypical device on the market for that now. That's the picture on the left here. Nice way to intrasaccularly occlude, intrasaccular flow diverter. And then one of the advantages here is that you don't need the antiplatelet therapy, the dual antiplatelet therapy that you might need for a flow diverter, the traditional flow diverter. And in that sense, it's a great thing to use for a subarachnoid hemorrhage patient. And then we're also seeing improvements in the flow diverters themselves with antithrombotic coatings on the stent. And one of sort of the prototypes for that is the shield coating on the pipeline device. And this is just a graphic from the company showing the platelet aggregation without shield, and then the lack of that aggregation on when they use a device with the shield technology. So this, I think, is a way to expand our use of flow diverters, both intrasaccular and extrasaccular, for subarachnoid hemorrhage patients without the concern of the dual antiplatelet agents, and that when you need to do other procedures such as external ventricular drains or eventually shunts on those patients. So the dilemma still is in deciding which therapy. At least in the U.S., this is still an issue of debate. I think in Europe this is a bit more of a settled issue, but in the U.S. we're still constantly debating, which treatment is best, and then arguing over what does the data say. And there are two main pieces of data here that people use, and that's really the data that comes out of the ISAT trial, which is now several years old, and the Barrow ruptured aneurysm trial. Now, both of these trials have had long-term follow-up, and that's where we get into the continuing discussion. As the long-term follow-up comes out, these points get raised over and over again. So I thought it'd be worth kind of going through this a little bit to kind of refresh people's memory and talk about where things are now in the current debate. And this is, again, kind of US focused, because a lot of this has been settled, I think, a bit better in Europe and other areas. So the ISAT trial, published in 2002, so data was collected well before that. Prospective randomized trials, comparing microsurgical clipping to endovascular coiling, mostly centers in Europe, but also in North America. So over 2,000 or over 2,100 patients randomized, about evenly distributed between coiling and endovascular clipping, clinical outcomes at 2 months and 1 year in the initial study. And the primary outcome was a modified Rankin score of 3 to 6 at 1 year. So that's the disabled or dead. 1 year follow-up in just over 1,500 patients, almost 1,600 really. More patients were dead or dependent in the surgical group at 1 year compared to the endovascular group, and that was highly statistically significant. A relative risk reduction of almost 23% and an absolute risk reduction of about 7%. So that's really kind of what drove the change to endovascular, particularly in the US after seeing this, and I think also in other parts of the world as well. So interesting things about the results also, though, 1 year case fatality rates were not significantly different. Post-treatment rebleeding was actually 2 times more likely in the endovascular group, and death from rebleeding was higher in the endovascular group. Endovascular patients were also more likely to require retreatment. Interestingly, though, symptomatic vasospasm was less common in the endovascular group. There's about a 6% absolute difference for that. But importantly, all of those endpoints, even though some of them do favor endovascular, they are all included in the primary endpoint. So there are several criticisms as to what this meant. The randomization was a small percentage, a majority were not randomized, but they actually went to surgery, the majority that weren't randomized. 1 year follow-up was 74%. That's actually not too bad. It was a questionnaire that was used to determine, so it wasn't, the patients weren't actually assessed, and there was not a blinded follow-up. The follow-up's relatively short term, but we see that sort of gets fixed down the road. The experience and the expertise of the practitioners wasn't known. It wasn't really as well sorted as maybe in some other trials. And then the US obviously complained that the US representation was minimal. But in response to that, you see that the long-term follow-up was planned and has now been published. We'll talk about that in a second. And that change of a greater than 6% in good outcome, that's really included in the overall outcome, as I mentioned. So, and it would take about 40 years to overcome that present 1 year benefit. So it's unlikely that was going to change. In terms of surgical expertise, these are all major referral centers. They're all doing between 60 and 200 cases per year. And the neurosurgeons that participated clipped many more aneurysms outside of the trial than they did in it. So they were clearly experienced. And the overall results were very similar to the North American Trilizad study, with about 9.2% dead at 3 months versus 8.3 at 2 months in this one. So, so not too far off. The clinical relevance, well, this analysis was predetermined. That modified Rankin difference between 2 and 3 is about dependency, and that I think is something that patients do worry about. And the absolute difference is very similar to other trials that you can see here. So then what about the 10-year follow-up? Well, in a 10-year follow-up, it turns out that the endovascular treatment group was more likely to be alive or independent at 10 years. Endovascular coiling group was also more likely to be alive, just plain alive. The rate of independence, however, was not statistically different. So now what about the BRAT trial? That's the other sort of parallel to this. And this was conducted in the US, and it was at the Barrow Neurological Institute site, where there are some really well-known neurosurgeons doing open surgery. And they had 500 patients enrolled prospectively, and they were assigned in an alternating fashion. About 238 patients went to clipping and 233 to coil embolization. There were no anatomical exclusions, but crossovers were allowed. So patients did cross from one side to the other. Outcomes were assessed at 1 year using modified Rankin, and they used a poor outcome as defined as a modified Rankin of greater than 2. So using intent to treat analysis at 1 year, they had 403 patients available. Poor outcome was observed in almost 34% of the clipping patients and 23% of the coil patients. And that was significantly different in favor of the coil patients. So this obviously kind of upset a few people in the surgical world at the time. Now, interestingly, only about 62% of the 199 patients assigned to the coil group actually received coil embolization. So they were concerned that these crossovers from clip to coil, that was what was from coil to clip, was causing some of these poor outcomes. But the crossovers didn't do any worse than those assigned to embolization. They didn't do any worse than those assigned to clip occlusion. So it wasn't really that they did so horribly. And no patient was treated with coil embolization actually suffered a recurrent hemorrhage. So now we have the 10-year follow-up, and this was relatively recently published. Now, interestingly, there's some nuances that are different here. So this is a post hoc analysis of a subset of the saccular aneurysms only. So the initial group, or the initial paper, included all the aneurysms that were seen at that time and were randomized, not just saccular aneurysms. So this, though, it takes a select group of that, and it's only about 178 patients per group. And what they found, there was no statistically significant difference in the poor outcome or death at the 10-year follow-up. And they noticed that the clipped 2 of the clipped saccular aneurysms, that's 0.8%, and 23 of the coil saccular aneurysms required retreatment. So that was significantly different, more retreatments in the coils, no surprise there. And 93% of the clipped aneurysms were completely obliterated, compared with 22% of the coiled aneurysms, and this was statistically significantly different also. So then just a couple of other points here. There are only 2 deaths related to aneurysms. One of those not even from the target aneurysm, but both deaths were actually assigned to the coil group and the coil treated group. So, but interestingly, the deaths in these groups were overwhelmed by the deaths from other causes, not from the aneurysm itself. But when this was published, the feeling was, well, now this is showing that actually coil embolization and open surgery are equivalent in the long run for a ruptured aneurysm. And I say that's not really the case. And there were a bunch of editorials about this, and I had the privilege of getting to write one as well. And some of the limitations we had concerns about here were the fact that this is a post hoc analysis. So we're taking a subset of patients, not the entire study, not how the study was originally designed. And the finding that the outcomes eventually converge doesn't really negate the initial benefit. So these patients had an initial benefit, and they had the benefit of independence for many years before the outcomes actually converged. And this is a study done using 15-year-old technology. The predominant coil used here was a coil called the Matrix coil, which some of you may or may not remember. And that was actually really withdrawn from the market because it had such poor occlusion rates. So to think that technology is representative of what we do now I think is a big mistake. And interestingly, after the first year, we don't see that the coil patients, the clip patients improve, which is what had been proposed by some. Well, they're gonna get better. They just have these, it's a rough time because the clipping is more invasive. What we see rather is that both groups get worse. In other words, both groups of patients die, because that's what happens as you age, you die. So if death is your primary endpoint, they're going to converge eventually. So the convergence at 1 year in terms of death does not, I think, really negate the benefit that you see initially. So this is basically what do we do at Penn State currently? So our current protocol is the endovascular as a default treatment for ruptured intracranial aneurysms. Aneurysm is challenging for endovascular therapy. That is, it needs a stent or a flow diverter, and open surgery is reasonable. Then we'll oftentimes choose open surgery. Now, this is changing though, because as I said, with some of the newer technology, using an intrasaccular flow diverter can be a way to get around that antiplatelet problem that we want to try and avoid. And for some of these blister type aneurysms, using a flow diverter is worth the risk, because it's just the surgical alternative is just not very good. Now, if an aneurysm is very challenging for endovascular therapy and open surgery is also high risk, then we're going to tend to go with the endovascular, because we think if those risks look pretty similar, we're going to probably be more comfortable with endovascular therapy in the end. And that's just our protocol, and it varies across centers, obviously, throughout the world. So I want to touch a little bit on some of the complications. Obviously, you kind of know all these already: hydrocephalus, hyponatremia, and delayed cerebral ischemia or vasospasm. Those are sort of the main ones that almost every patient's going to get to some degree. Hydrocephalus, hyponatremia, not too much to talk about there in terms of advances. It's really the focus of most research these days, obviously, and it has been for a while, is on delayed cerebral ischemia and vasospasm. I just put a couple of pictures on here showing their TCD. Monitoring a case of pretty bad vasospasm after coil embolization of an MCA aneurysm, and these resulting multiple infarcts that you get from sometimes in patients with bad vasospasm. So what we're referring to here, this is only after aneurysmal subrectal hemorrhage, really, or the clinically significant version, pretty much only after aneurysmal subrectal hemorrhage, and the ischemic strokes are what lead to the problems. And it's really the main cause of morbidity and mortality for those patients that survive the initial rupture or re-rupture. And we still don't really know the exact molecular mechanism. It's biphasic, but it tends to be the peak that we're interested in is really around 7 to 10 days. It's usually done by about 14 days. And obviously the patients present with a wide variety of clinical syndromes. The things that we know that influence it: the severity of the initial hemorrhage, the amount of blood as well. Women tend to get a little bit more than men. And there are some possible associations, things with smoking, with infection or fever, hyponatremia, and age that are sort of controversial throughout the literature. And you'll see papers that may cite one or another of those factors. Diagnosis, typically, we want to look at the clinical examination, but this can be difficult if the patient's intubated or sedated. So we need to look at other tools. But basically, in the awake patient, we're looking at neurological deterioration in somebody where you cannot explain this by rebleeding, hydrocephalus, seizures, or some new kind of metabolic abnormality. So TCD, I think, is our main screening tool, and we're doing this daily. Some centers I know do this twice a day even. And it's the problem here is the sensitivity and specificity. So having the same operator do it, following the trends, those are some of the key things to try and help with that part of it. CT perfusion is increasingly being used for diagnostic confirmation and for targeted treatment. So we can do this. We can see if there's in fact a perfusion deficit. At the same time, we're getting a CTA, so we know what the vessels are looking like. Is there in fact large vessel spasm that we can treat with angioplasty? Is there some more visible small vessel spasm that we can maybe treat with an intraarterial vasodilator? And that's where the angiography comes in. So the nice thing here is you not only get the diagnosis, but you can also treat. But importantly, I think you really need to correlate this with the CT perfusion or the clinical exam, because many patients will get angiographic spasm and it's not clinically relevant, and there's risks to these procedures. So doing them for patients that don't really need it is not, not always optimal. Now, the mainstays of therapy, Triple H therapy was sort of the traditional thing. I think most places don't really use that anymore. Keep patients usually euvolemic. We allow some permissive hypertension and active hypertension in patients that are going into significant spasm. Hemodilution has never been a thing with leeches or anything. It's just that's kind of what happens over the time in the ICU. Calcium channel blockers are sort of the mainstay of the approved treatment in the US. At least we only have the oral version of nimodipine. Other parts of the world obviously have an intravenous version, or we'll use nicardipine. The intraarterial vasodilators, as I mentioned, using those in conjunction with angiography and balloon angioplasty for some of the more proximal vessels, or using small coronary balloons for more distal vessels, where you can be very specific on the size. And then there's all these thoughts on research on alternative prevention and treatment strategies, and I'll talk about a couple of those coming up. So just some trial updates. I mean, some of these are a little bit older now, but the topics come up again and again. You know, magnesium, should we be using that or not? Well, there's a couple of trials suggesting that really that's not really useful. So this is the IMASH trial. This was published actually in 2010. So the favorable outcome, 64% in the magnesium group versus 63% in the placebo. So no significant difference there. This is MASH2 trial, similar thing. You know, poor outcomes, very similar in the magnesium placebo group. So not really good evidence for magnesium as a therapeutic intervention or preventative measure for these patients. Statins, another one where people looked at several times. There was a wide variety of literature on this. Large STASH trial, prospective randomized trial. And you can see here, favorable outcome was not statistically different between the two groups. So kind of not. Now, statins, I think, have a little bit, you know, certainly relatively low risk, and I think you'll see some centers still using them, but really the data to support that is not good in terms of impacting outcome. Clazosentan, you know, this comes up again and again. This was one of them, a large meta-analysis that looked at about over 2,100 patients. They found that the high dose, that's the 15 milligrams per hour, was associated with a decreased incidence of DCI, but it did have some other complications, hypertension, pulmonary issues. And so that kind of limited it, and there was no real difference in the overall clinical outcomes. However, the high dose part here was sufficient enough to actually start a new prospective randomized trial that Idorsia is running. And we're actually a center for this. And this is using that high dose and randomizing patients to the infusion versus placebo for 14 days. So we will get some more level 1 evidence on this with this new PRCT that's coming out. They're enrolling mostly centers actually in Europe and around the rest of the world, but we are one of the centers in the US for this. Another one, you know, one of the ones I thought worth mentioning, because nicardipine and the calcium channel blockers come up again and again. So this is a phase 2 trial being run that's looking at these NICA implants. So these are implants of nicardipine. They're 4 milligram sustained release capsules that are implanted in the basal cisterns, randomizing patients to this after open surgery. But obviously the patients have to have open surgery, so that kind of eliminates those endovascular patients. And we know from the previous trials that the endovascular patients tend to have less spasm anyway. A couple of other things just to see what people know about going on in the future. Deferprone for ruptured aneurysms is out of the University of Iowa. Heparin for subarachnoid hemorrhage, that's from Indiana. And in Amsterdam, there's a trial they're running looking at nedroparin. This is a low molecular weight heparin, minocycline, a tetracycline antibiotic, MASH trial out of USC. So a bunch of other studies still going on, trying to look at some of these ways to reduce the severity of the delayed ischemic neurologic deficits in these patients with subarachnoid hemorrhage. So plenty of research still to come, and we don't have a good understanding of this difficult complication. So in conclusion, we'll just give you a couple of take-home points. Remember, this is obviously a high morbidity and high mortality disease, and it's mainly related to the presenting condition and the subsequent complications. Endovascular and open surgical treatments are both effective for certain aneurysms, but I would say that if the aneurysm is amenable to both therapies, that embolization is typically going to give you the better outcomes. Managing the complications, and this is, I think, one of the most important take-home points, and the sequelae is at least as important as occluding the aneurysm, if not more, in subarachnoid hemorrhage. Because as you've seen in these studies, even if you have a higher recurrence rate, even if you have a slightly higher rebleed rate endovascular, if the other complications are less, you impact the outcome in a greater way. To leave you with a couple of final thoughts here. So this is from the Barrow group in response to the editorials about the 10-year follow-up on the BRAT trial. And what Dr. Special says here is the sole purpose of treating these patients as subarachnoid hemorrhage patients is to prevent further hemorrhage. And in both BRAT and the ISAT trial, this purpose is best accomplished by clipping. So I would dispute this. I think this is not true at all. I think that the primary purpose of treatment is to restore the patient's independent functional status. as soon as and for as long as possible. And I think that the evidence suggests that endovascular treatment actually does this better. Because in a ruptured aneurysm, it's not just about preventing rebleeding, it's about taking care of the entire patient. And that's where the endovascular embolization has the edge. So with that, thank you for your attention. Hopefully this was informative to you. And I don't know if, Naren, if we have time for a couple of questions, but happy to answer them if we do. Thank you very much.
Thank you, Professor Kevin. Thank you. That was a nice and comprehensive coverage of the entire spectrum of topic of management of subarachnoid hemorrhage, aneurysmal bleeds. After a brief interaction with your team 2 years ago at Hershey, so actually my thinking changed, because you have this kind of protocolized management which sort of gives a clarity on what to do, deciding what to do, particularly for MCA aneurysms. Even our residents were risking their fellowship clearance if they had uttered the word coiling even a few years ago. Only now we are starting to accept that, and your final thought was really thought-provoking, and that definitely eased the concern, because it's not just a rebleed but a fully independent life the patient leads. So for those places who does not have a protocol like your place, if, for example, a 45-year-old lady with left MCA bifurcation aneurysm presents with clinically equipoised for both coiling and clipping, and if they want to take an informed choice, what disadvantage and advantage would you briefly mention when you're talking to the patient relatives, if I may ask?
Right. Yeah, I think, as you said, well, at MCA aneurysms, there's a wide variety, but if we, as you're saying, this is one that's amenable to both treatments, then as I said, from our protocol, we would tend to favor endovascular, but my discussion would say, yes, we tend to favor endovascular because we think that the long-term outcomes in terms of your returning to an independent status and staying that way longer are going to be better with endovascular. However, if you have endovascular treatment, you're more likely to need a retreatment, and there's a chance that you might have rebleeding again. But despite those things, you're more likely to do better in the long run. With surgical clipping, we can give you a permanent solution. You may never need another therapy, but you may not do as well up front.
That gives real clarity to a very difficult question. Thank you very much, Professor Kevin.
You're very welcome. Pleasure to be here.
There's a question for you, Dr. Cockcroft. Is risperidone help in aneurysm patient?
Yeah, I think, the jury's still out on that. I know some of our rehab folks are using it. I think there's not a lot of good data to say that that's a definite therapy at this point.
Thanks. And going back several years ago, when I was a resident, there was this, there was about pituitary dysfunction in patients with aneurysmal subarachnoid hemorrhage. That was meant to be a big game changer, but then I hadn't heard, but then I hadn't been so much in vascular neurosurgery. Where has that gone, Dr. Cockcroft?
Yeah, I can't say I've heard anything about that recently either. The pituitary axis dysfunction, no, I haven't really heard anything in terms of new research in that area.
Thanks. Thank you very much. Thank you very much again, Dr. Cockcroft. It's a fantastic lecture, and this is important for vascular neurosurgeons as well as those of others who don't do vascular, but it's good to keep in touch with this important area. I thank Dr. Komar Prasad for chairing this session, and Dr. Cockcroft, and look forward to your support, and hopefully we'll meet again we have to always live in hope, and we have to meet again somewhere in Greece, hopefully, for our next INRC. We have to go to India first, of course, to go to Dr. Komar Prasad, and then come anywhere else. Right. Thank you very much. Thanks a lot.
All right. Well, thank you very much. Very happy to be here. Great to see everybody, and good luck with the rest of the conference. Thanks for organizing.
Thank you very much. Thanks a lot. So we'll now move to our next session, which is our spinal symposium. This is a great honor and privilege that this is the first collaborative meeting that we are having with the World Spinal Column Society and the WFNS Spinal Committee. I really thank the collaborative spirit of those two august institutions for this fantastic symposium that you are going to have from the great spinal neurosurgeons of our time. So without further ado, I'm just going to hand over the chairmanship to Professor Zileli, Mehmet Zileli, who is from Izmir. He is the chair of the WFNS Spine Committee until recently, and one of the most active committees in any societies that I know. And then Professor Salman Sharif from Pakistan. He's the president of the World Spine Column Society. They had a fantastic meeting just last weekend, and now the chair of the WFNS Spine Committee. I hope I've got those things right. Thank you very much. Thanks for this collaborative session. I transfer the moderation to you. Thank you.
Thank you, Naren. It is great to be with you. A very informative meeting. I'm sure you'll enjoy our speakers. We have top-rated spine surgeons with us. First, I want to introduce Dr. Oscar Luis Alves from Portugal, who will talk us the cervical arthroplasty limits and complications. And please keep your talks in 15 minutes, then we can discuss in 5 minutes. Thank you. Dear Oscar.
Thank you, Mehmet, for this kind of invitation. It's really an honor to be among giants of spine surgery. My topic is on cervical arthroplasty, limits and complications. I have no disclosures relevant for this presentation. What are the limits? This is a mainstream case: single level disc herniation, minimal spondylosis, lordotic alignment. And I think most of the surgeons tend to offer this kind of operation to a patient like this one. But we try to push our indications, and here you find idiopathic hyperostosis, 35 years old female with severe dysphagia, this kind of situation. And we did an arthroplasty, 7-year follow-up, and there is an index level range of motion preservation with a very good location of the center of rotation. Even though there was a loss of segmental lordosis over time, the arthroplasty implant was still mobile. And this is not a problem for me because sexual alignment parameters, there is a significant variation of normative values. Even from this paper from Luwek, it has been shown that 1/3 of the patients, they are asymptomatic and they can have a kyphotic alignment across C2, C7. And there is an intimate relationship between lordosis and T1 slope. And cervical kyphosis is acceptable if there is a small T1 slope. This is our patients that we look at the sagittal alignment, small cohort of 35 patients, single level, and there was a significant increase on segmental lordosis. And most of the global lordosis that we also achieved was derived essentially from an increase in the index level lordosis. And this is supported by other data from the literature. We have demonstrated the same if you do multi-level cervical arthroplasty, as you see here, a significant increase in the lordosis. 3 or 4 levels, that's really the same situation. Here we try to push a little bit further the indication, and this is a case of segmental kyphosis, as you see here, minus 13.2 degrees in neutral position. It was a flexible but not fully reducible kyphosis, as you can see here, still some kyphosis in extension. And this is what we got 4 years after operation with arthroplasty, a significant increase of segmental lordosis, and with a good quality of motion, as you see here. We look at all our patients with kyphotic level, 23 patients, 25 levels, and there was an increase that was significant in all kyphotic level patients. And this is really in contrast with the literature. Only 13% of patients with KIM shown to become lordotic. But I have to tell you, these were completely different kind of implants. T1 slope had no influence in the degree of kyphosis reversal. This is a kind of patient I see more and more in my practice, rather younger patients with multiple collapse disc disease and straight spine. And we also push forward the indications like you see here. These patients it's a challenging to offer a surgical solution for these patients. They have a higher life expectancy and multi-level fusion has a significant impact on their functional status, as you can imagine. Two-level fusion just amplifies the loss of motion and increase of stiffness of if you do one-level fusion. The same for significant hypermobility, even if you do a lordotic two-level construct, as you see here. And you offer to the patients many adverse effects when you do multi-level fusion. Hardware failure, pseudoarthrosis, subsidence, and this is in direct correlation with the number of levels being fused. And also, if you do a fusion and if you think that with aging there is an increase on SVA, you will abolish these compensatory mechanisms of flexion of the lower cervical spine and hyperextension of the suboccipital segment to maintain horizontal gaze, which is really the case when you do a fusion, you abolish this kind of compensatory mechanism. So this is what we do in surgery. After we operate this kind of patients with small slit discs, we test for the mobility with this leverage maneuver. And let me show you just a patient with almost a straight spine, 1.8 degrees. And after 48 months of arthroplasty, pre-level, we could have a very nice cervical lordosis. Look how the range of motion was almost vestigial in 4-5, and there was a significant increase in range of motion. The same for the disc height from 2.6 millimeters to 6.6 millimeters, especially in the most collapsed disc. And that's the MRI 48 months, asymptomatic, and decompression was not compromised. Just another dramatic case here. We were able to reformat this very spondylotic disc, and this is the follow-up with the gain of lordosis and good range of motion at 48 months post-operatively. So we look at our patients with pre-op disc height less than 3 millimeters. We identified 28 patients, 39 levels, and there was a significant increase in the disc height, in the angulation, and also on the range of motion. And it was interesting to see that more collapsed discs show a higher increase in disc height. Also a tendency for more collapsed discs to show a higher increase in range of motion. So based on this, we have really a broad indication for cervical arthroplasty as it restores index level range of motion, limits adjacent levels hypermobility, restores quality of motion, and has a beneficial effect on sagittal alignment. Of course, there are limits, and most of the limits comes from the technology itself. Here you see the center of rotation of the disc, which is really different at different levels of the cervical spine. So I think in the future, you'll probably have custom-made devices according to the level of spine that you are operating. The same for degenerative cervical spine. We need devices that take into account age-related changes as well. So these are my contraindications. If you see significant facet joint degeneration, modic changes, large osteophytes, diffuse OPLL, ankylosis, facet arthroplasty in CT scan, kyphotic deformity over 15 degrees, a dynamic cervical radiography that shows you instability or very residual motion, significant osteoporosis, osteopenia, active infection or allergy to implant components. And it's for sure that poor candidates for arthroplasty are more prone to complications. And what are the complications? Above all, the most important complication is an erratic surgical technique, poor patient selection. There are some implant-related complications and anterior cervical related complications. Among the technical errors, you can have subsidence, migration, kyphosis, residual radiculopathy, and a contribution to heterotopic ossification. And you see a technical error will lead you to different type of complications, as you see in this case. Subsidence is radiographic, is more prevalent than clinical. Less than 3% of patients will need a reoperation. Either subsidence or migration are related with overstaffing, which means higher implant than disc height and undersize, an implant that it's not covering most of the end plate, over drilling and then end plate violation during disc preparation in the case of subsidence, or during positioning if you put your patient in too much in lordosis or distraction during disc preparation. I don't do personally any distraction during disc preparation. Post-op kyphosis, it's also a technical error. Again, positioning extension, lordotic distraction, excessive end plate drilling. It might happen that there is some rigid preoperative kyphosis and that the implant itself does not incorporate any kind of lordosis. The effect of insertion depth, it seems to be important. Anterior located arthroplasty leads to lordotic segmental angle, whereas more posteriorly implanted can lead to a kyphotic angle. Persistent radiculopathy, as you see in this case that I took from the literature, you should never compromise proper decompression to fancy techniques. But you have to be aware that when you do a cervical arthroplasty in comparison with ACDF, you do much less indirect decompression. So behind the removal of the actual compression, you should do some sort of functional uncus removal to avoid nerve root compression in extremes of the range of motion, especially in lateral bending. And it might be due also to subsidence, disc space collapse, and foraminal stenosis with nerve root compression. Heterotopic ossification is a hot topic in cervical arthroplasty. It's by definition the formation of bone outside the skeletal system. If you have this sort of heterotopic ossification in fusion, in ACDF you call it fusion, or you call it pseudoarthrosis, but in arthroplasty you call it heterotopic ossification. And of course, I'm being a little bit provocative. Actually, this is a patient of mine that I did a two-level ACDF, and you see HO in one level, but no on the other level. And it was me who did the operation, same technique. So the occurrence of HO, it's still a great phenomenon. And I saw in the literature very recently some observation by this US surgeon operating this grade 4 HO, recurrent neck pain, lack of facet joint fusion. He found out intraoperatively a large amount of dark gray metal debris granulation tissue proceeded to the implant. And he questioned if this is an inflammatory reaction or really bone formation. So what's the nature of what we are seeing in postoperative images? Heterotopic ossification, the most accepted classification is the Marian classification. And why this is pertinent for the cervical arthroplasty? Because HO can decrease the range of motion, eventually in grade 4 to functional fusion due to bridging osteophytes, which is contrary to the fundamental aim of arthroplasty. The incidence is really variable. It is affected by the definition of HO degrees and also by the length of follow-up. The more you follow the patient, the more HO you discover. Fortunately, there is no significant difference in functional scores between HO and non-HO patients. And in this study from Barbagallo, no patient required revision surgery. This is also my experience. And even though you get some degree of heterotopic ossification, processes are still mobile, as you see here in this case at 32 months postoperatively. So what are the strategies to avoid HO? Of course, patient selection, advanced spondylosis and osteophytic disease will likely require more extensive bone preparation, drilling, and cancellous bone exposure. You have to have a proper and sound surgical technique, copious irrigation during any drilling at the end of the operation, extensive PLL removal. PLL is a kind of scaffold for ossification. If you leave bone, if you leave dura without any ligament, very unlikely you will have ossification. You have to apply bone wax to any exposed cancellous bone, proper implant sizing with maximal end plate coverage. This is really important. Avoid keel implants. They are prone to more ectotopic ossification, and avoid kyphotic positioning. And some of my patients, if not all, will do some sort of NSAIDs in the early postoperative period, generally for 2 weeks. We have shown in this paper that in 32 patients, 71 implants, multi-level, look at the grade 1, 83%, grade 2 in 2.7% of 2-level patients, and 8.6 in grade 1 in 3 and 4-level patients. And no, we didn't have any grade 3 or grade 4 HO, and this was based on our surgical technique, which is quite different from other publications, namely this meta-analysis by Kim. Another complication is related to poor patient selection, like here, vertebral body fracture during distraction to insert the implant, and this is due to osteoporosis. Osteopenia, osteoporosis, bone metabolism disorders are very poor candidates for surgical arthroplasty. A very important concept is, which is related to the implant, is the gradient resistance to motion that you see in so-called third-generation implants. And this is a study of one of my PhD students with 31 patients, 46 implants in different clinical scenarios, 24 months follow-up. And you see that arthroplasty reproduces the range of motion and the relative percentage along cervical spine segments as in asymptomatic adults. They tend to move more in C5, 6 levels. Also, very nice biomechanical study showing that there is an increase of range of motion when a prosthesis is coupled with a 2-level fusion compared with standalone. So this is a quite reactive technology. We had this patient with a cervical trauma, 37 years old, diparesis grade 3, 1-level disc herniation, X-ray excluding major instability, an MRI, no posterior band lesions, and we decided to implant the disc prosthesis, and we observed a buffering effect. The implant could correct for the excess of segmental motion. There was a significant decrease of range of motion from 17 to 9 degrees. Of course, I don't advise you to do these cases in trauma cases, but this is a very selective case, and the patient did well with a very good range of motion and quality of motion. For example, on the opposite, this patient with 45 female, great motor deficit, grade -4, paresthesia, with this straightforward cervical disc. We did an arthroplasty, single level, resolution of arm pain, neuro recovery. She was very happy at 9 months postoperatively when she started with the exclusion neck pain due to hypermobility of the implant, 19 degrees. We did a facet block that produced relief of pain, and we did an arthroplasty, posterior fusion, MIS, and the patient was asymptomatic. So this is a case of excessive range of motion consecutive to arthroplasty. Again, vertebral body osteolysis, as you can see, related with implant. These are extremely rare complications. I never faced such a complication, although I do a fairly important number of cases. And this is related with wear, debris, or immunological response to biomaterials. It might be reduced if you use metal device. This is another case recent from my department, not a case of mine, which after 2 years, 1 year of cervical arthroplasty, you could find a pervertebral abscess with vertebral body osteolysis. Another complication, it's related with an anterior cervical approach, dysphagia. You would think that arthroplasty implants are zero profile, so they would generate less dysphagia. This is not the case. The literature is very controversial. There is most of the papers don't show any difference if you do an arthroplasty or an ACDF, and this is because the cause of dysphagia are multifactorial. A very important topic is adjacent segment disease. of course, there is a definition bias. There is very different definitions was what is an adjacent segment problem. You have the concept of degeneration, which is a new radiographic change at the spinal level, above or below the surgically treated level. This is when this becomes clinically relevant with radiculopathy, myelopathy, or mechanical instability, or adjacent segment reoperation, which is the most significant manifestation of adjacent segment disease. There is also a report and decision bias. There is no direct relationship between radiographic and symptomatic adjacent segment disease. And adjacent segment disease is largely follow-up dependent. The more you follow the patients, the more you see those problems, either in ECDF or in arthroplasty. And all this is poisoned by the use of reoperative rate to define ASD. Of course, and why is that? Because surgeons are less likely to revise and patients are less likely to agree to surgery if they believe that devices like arthroplasty reduces the incidence of ASD. ASD, as arthroplasty can mimic normal motion, in theory, ASD and AS reoperation could be reduced. But this is not always the case because ASD development is multifactorial. It depends on the natural history of the underlying degenerative process. It's related to patient selection and individuality, the type of procedure and implant, if you do a decompression alone or fusion or arthroplasty, the surgical technique that we use, the number of levels treated, and whether or not, this is a very important point, asymptomatic but altered levels on MRI were included at the time of the index. So,
Oscar, sorry, we're running out of time. I apologize. We're 10 minutes over.
Yeah, I'm sorry, very quickly. So this is the incidence of ASD according to Willebrand, around 3% per year, 25% per 10 years. So that's why the reason why arthroplasty still, there is the possibility of ASD if you do an arthroplasty. It seems to be not, in terms of secondary surgery, not inferior to ACDF, in some cases superior. And the more levels you do, the superiority will come out. And this is just one of those papers showing to level a difference in subsequent surgery. This is, again, reinforced by meta-analysis, as you see in this case, or even from real-world data, as you see here, almost half of the operations with arthroplasty. You can see most of our concepts, and if you read some of our papers on Journal of Spine Surgery, recent paper that we published in Neurosurgical Clinics of North America, and a paper on spondylotic myelopathy that we advocate use of surgical arthroplasty in selective cases that you can see in this brilliant textbook. Thank you. Sorry, Simon.
Thank you, Oscar. Great talk. There is one question that if there is a limitation you recommend to the supporters with the possibility of high velocity trauma, do you limit or do you give a time limit?
You mean for returning to sports, right?
Yeah.
Okay. Well,
especially the dangerous sports like rugby, fighting sports.
Yes. I mean, I have a very interesting case that I can share with you. It is a patient around 40 years old that operated in 2019. I did a 3-level arthroplasty because of compressive disc disease. I operated on a Wednesday. On a Saturday, the patient was calling me, asking me permission to go to the gym for rehabilitation and because he wanted to race, and this is a sailing guy, on the European Championship on 1.5 months after surgery. Actually, I told him, you do it, but I don't know about. But the guy eventually went and raced and was vice-European champion. And so I think the primary stability, that's what this question addresses. It's quite good with the most of arthroplasty devices that we have nowadays. So you shouldn't fear if you do multi-level or if you allow patients to return very quickly quickly, I would say 1 month, 2 months to the contact sports.
Thank you. Thank you. I think we must skip the other speaker. Dr. Edward Benzel is with us, and then he will talk on the biomechanics of spinal deformity correction. Ed, welcome.
Thank you, Emmett. I'll try to make this quick here. I'm going to focus predominantly on the cervical spine, but the principles apply to all regions of the spine. First of all, we need to think about, if we're correcting a deformity, think about how the spine deforms and mechanism of spinal column failure. It's all related to the application of a bending moment, which is the product of the force times the distance. So a force applied at a distance d from an axis of rotation creates a bending moment, which is the product times the force times the distance. This creates an increased stress ventrally, which initiates failure and which propagates dorsally. The other thing I think we have to be well aware of is the issue of subsidence, not only from a failure perspective, but from a failure of our surgical perspective. If we push in the middle of a tin can, it will indent, whereas if we push on the tin can around the edge, it won't. This is called the boundary effect. So the edge of the vertebral body, which is like the edge of a tin can, is much more resistant to subsidence, and henceforth placing interbody spacers near the perimeter or circumferentially around the perimeter versus in the central portion of the disc interspace can make a big difference. The biomechanics of instrumentation is critical because instrumentation is what holds the whole thing together. And Archimedes made the statement, give me a lever long enough and a fulcrum in which to place it, and I shall move the world. We think about the spine as moving along or about the 3 axes of the Cartesian coordinate system. And it's important to understand that the instantaneous axis of rotation is at the center of this coordinate system right here. Again, bending moment is a product of force and distance. And there are 6 types of mechanisms that we can use to correct deformity or reverse the process of failure. One is distraction. And if we distract in line with the axis of rotation, there is no bending moment applied. But if we distract, say, dorsally, we can create a bending moment, sometimes not desirable. Then there's 3-point bending, where the device can be used to correct a deformity. Compression or tension band fixation, like with a cerclage wire or a clamp. And then 3 types of cantilevers. A fixed moment arm cantilever beam. A cantilever is a beam that is affixed to an immobile object, like a wall or a screw attached to a rod. And it's rigidly, in a fixed moment arm cantilever beam, it's affixed rigidly at one end only. If we were to hook it up by a hinge or a screw that could toggle, for example, we'd call it a non-fixed moment arm beam. And if we use the implant to correct deformity, we can call it an applied bending moment implant. A common mechanism that we use to correct cervical deformity is the Caspar pin. That's applying a bending moment to the spine. Implants function differently under differing loading conditions. And I asked the rhetorical question, is there such a thing as a ventral compression implant? We know we can compress from behind, but can we compress ventrally? Well, let's dive into this a little bit further. Of course, we can compress from behind with a cerclage implant, but what about this implant? It resists compression, so it's a distraction implant. It's a fixed moment arm cantilever beam, so it's a cantilever beam. But if the patient who harbors such an implant is attempting to extend his or her neck, it is actually applying ventral compression forces to resist extension. So if we don't think of all the modes of loading that an implant might be exposed to, we are going to be doomed to failure. So those modes are distraction, tension band fixation, 3-point bending, and cantilever. This is a long bridging implant. And we know that with this long fibular strut and no intermediate points of fixation, that this is prone to failure. This is called a bridging implant, and it's a distraction device, it's a compression device, it is a applied moment arm device, but one thing it doesn't do is have an intermediate point of fixation. So it resists axial loads very effectively, but it doesn't resist translation or rotation, and henceforth failure. The application of one intermediate point of fixation in a native vertebral body, for example, causes the whole construct to move in unison with much less chance of ultimate failure like this. So using intermediate points of fixation increase the integrity of the implant tremendously. All these people have two things in common. Well, first of all, they have a fixed kyphotic deformity of the cervical spine. Second of all, they have the kyphosis trapezius sign. They got this thick, tense, myofascial, pain-generating trapezius muscle. The trapezius muscle is an accessory muscle of extension, and it's not very effective at it, but if the patient can't extend the spine in any other way, it becomes reflexively activated, as depicted here. But these patients also have back pain. And this is a patient who had a fusion from occiput to upper thoracic spine. And you can see she was fixed in a slightly kyphotic or moderate kyphotic posture. But you can see that she's got the kyphosis trapezius sign, but look what she's doing in order to look forward. This is illustrative of the notion that we should get scoliosis x-rays frequently when we're dealing with cervical deformities, because they can tell us a lot of information. So she complains of back pain and this myofascial neck pain. And here's a great example of the same thing with a patient with a fixed deformity, kyphosis trapezius sign, and look how she's angling her back just in an attempt to look forward. There are a variety of surgical strategies that we can use. And we do understand through a lot of work by a lot of people, but in particular, Zoe Gogolwala from Leahy Clinic in the United States, that when the SVA is small post-op, the health-related quality of life metrics are much improved as compared to a situation where there is a large cervical sagittal axis, vertical axis. This is a patient that I failed. She has these flexion extension x-rays, had cervical myelopathy, and I did this operation on the right. But I did not correct her to a nice lordosis as she was able to achieve preoperatively. And I left her in a straightened spine situation and with a chronic neck pain problem. Her myelopathy improved and she was grateful for that, but she was not grateful for her persistent neck pain. So we need to focus on deformity. Why? Because it diminishes neck pain, it treats the myelopathy, it decreases end fusion, degenerative changes, and there's ample evidence to suggest that when the spine is not aligned properly, the adjacent segments to any fusion will degenerate faster and improve short and long-term success. So we can place Caspar pins convergently and then straighten them out to correct deformity. I've already alluded to this as an applied bending moment. We can bring the bone to the implant using 3-point bending forces, but creating a lordosis by simply applying the intermediate screws. Here's a kyphotic spine, intermediate screw, deformity correction by tightening, bringing the bone to the implant with the intervening screws into native vertebral bones, as depicted here. We can use gravity. If we use gravity, we use in the cervical spine, we think of the head as being a 10-pound weight at the top of the spine, and viscoelasticity is the gradual deformation under exposure to a constant load. This patient has had multiple operations, fusion, posterior decompressions, has a kyphotic deformity, myofascial neck pain, and a signal change in her spinal cord. At no point along the course of her cord through this, through her canal, is there significant or overt compression, but nevertheless, she has a signal change. We figured that we could correct her ventrally because the facets were not ankylosed, and she did move at the lower level of the fusion. So we put a roll under her shoulder, a donut under her head, began some of the manipulations as we see here, and then removed the donut and allowed her head to go backwards to assist us in the correction of the deformity. And we got her corrected from a 15-degree kyphosis to a 5-degree lordosis. It's all about leverage. It's very difficult to achieve this in the prone position, but we must be persistent. And if we're not satisfied with the amount of correction, break scrub again and move the head back further. Fixation follows. Again, bringing the bone to the implant. Here we see this patient post-op, comparing pre and post-op. Kind of scratch our head, but moving forward 20 years, this case was done by me 20 years ago. We realize now that these signal changes are often related to position, and I frequently get dynamic imaging in order to determine what position the patient is best served to be in, and to see if and to make sure that we're operating on the correct problem. So here she is post-op. And about 2 or 3 years later, this gentleman presented to me. He'd had a laminectomy 10 years prior and had improved with his myelopathy, but his myelopathy began deteriorating again. We know that CSM, cervical spondylotic myelopathy, is a manifestation of repetitive trauma, tethering, and distraction. He couldn't extend his neck because of the arthrosis of the facet joints, but they were all mobile and he could flex his neck. So we got a flexion MRI scan. This is the first dynamic study that I had ordered. It's about 18 years ago. And he's got this laminectomy membrane, and every time he flexes his neck, he creates a profound compression of his spinal cord. So left is neutral, right is the flexion study. So we knew we could correct dorsally because he relaxed and released at each facet joint. And so we did multiple level facet osteotomies and corrected his deformity. He did well, very well, but he presented back to his surgeon in Puerto Rico several years later with a lot of neck pain. And you can see here at the upper end of his fusion at C2, he started topping off, if you will. And it's probably because of the fact that we went to C3 and did not include C2. And also with his prior 2 operations, he probably had a significant amount of disruption of the C2-3 facet joint. So lesson learned here is I almost routinely go to C2, particularly if this C2-3 angle is tilted downward. And I'll expound upon that in a bit. Here's that angle pointing downward. There is a strong association with subsequent failure at that joint and complications associated with the surgery if this is not level to the floor in the standing position. So his surgeon did this for him, and the patient, although his C2-3 angle wasn't improved much, was now relieved of his chronic neck pain symptoms because of the fusion. So now I don't hesitate to go to C2. This is another gentleman who had a C7T1 traumatic disc herniation, and the surgeon who took care of him at an outside hospital placed this implant and fused him. Because the patient had persistent neck pain, he took the implant out, and this is his x-ray on the right. He doesn't have any myelopathy, no compression, but his spine is fixed in a diffusely kyphotic position. Notice his kyphosis trapezius sign and hyperlordosis of his back so we can see forward. So he's sort of a miserable guy. We did multiple level facet osteotomies and then flipped him over, brought the bone to the implant, used Caspar pins to apply bending moments, used viscoelasticity principles of letting his head drift backwards. And in addition, we used trapezoidal shaped graphs, as you see here. This is what he looks like post-op, standing. So compare and contrast just by correcting a cervical kyphotic deformity, cervical thoracic kyphotic deformity, we were able to eliminate his back pain and eliminate his myofascial neck pain. We did a study several years ago at the Cleveland Clinic looking at the reoperation rate, pseudoarthrosis rate, progressive kyphosis rate, and adjacent segment disease and degeneration when the C2-3 angle was tilted downward as depicted here. And we found that all these complications were statistically significantly increased in patients in whom that angle was not corrected with the operation. The other angle that is very important is the T1 slope, or the C7-T1 angle. I use this to determine what to do for the patient up front when you see this type of a deformity, even in the face of an upper cervical lordosis, or at least a straightened spine. This problem needs to be addressed in the upper thoracic spine and the cervical thoracic junction to get the patient's head back into a normal alignment and correct the SVA. But I use the C2-3 angle for intraoperative utility. So if we see this type of a tilt, we know that after surgery, the patient is going to have more problems if we don't get this corrected. So, case in point, this is a lady who had a long segment deformity, and we use this prone film in the operating room to look at this C2-3 angle right here. And we say, okay, if we tilt this patient up, rotate this image, which is an intraoperative image, 90 degrees, we see that we have approximated the C2-3 angle being relatively parallel to the floor. So here she is, pre-op, intra-op, and with the focused x-rays on the right, post-op. So we corrected her C2-3 angle. Her plumb line, which used to fall near the L5-S1 posterior joint, now falls forward. She's no longer leaning backwards in an attempt to see forward, and henceforth her plumb line obligatorily moved a bit forward. So remember the C2-3 angle, it is critical. Use all the mechanisms possible to correct deformity, and recognize that if we don't correct deformity and we create an abnormal posture of the vertebral body, we are going to see greater stresses at adjacent segments, and we're going to see greater chance of failure. And I'll just leave you with one thought. Here's two patients who underwent a discectomy and fusion. Both of them had relief of their radiculopathy. And although I don't really know what happened to these patients, you can see that this patient's disc space is going to be stressed extensively because of the lack of retention of a normal lordosis and a focal kyphosis at the operative site, whereas this patient's adjacent segments are much less adversely affected. And I would suggest that a lot of the adjacent segment disease and degeneration that we see are related to the posture that we create rather than other factors such as preserving motion, etc. Thank you very much.
Thank you, Ed. Excellent talk.
Yeah, there is one question from Atul Goyal asking if there is a place of inserting a spacer into the facet joint. Do you think it can help for some?
My opinion is, this is my opinion, but I think there's practically no role for those kind of spacers, because what they're going to do is to encourage flexion or kyphosis. I think using regular lateral mass and pedicle screws, etc., from a posterior approach with burring down of the facet joint and packing bone into the facet joint is very helpful. Using a spacer in and of itself is going to generate a kyphosis, not help prevent it.
Thank you.
Can I ask a general question, Professor Zileli?
Yeah, please.
Thank you. We had Dr. Bensel, who was very generous in 2015 to give us a lecture at the Royal London Hospital. Thank you very much, Professor Bensel. At that time, that was fantastic. At the time, I asked you that question, whether, I rarely see anyone nowadays walking straight, looking forwards. Everyone is walking, looking downwards with their mobile phone. Without exception. And have you seen any increase in cervical spine pathologies with this?
Well, we most certainly see a lot of cervical spine pathologies. Probably the increased rate is not so much related to that, but related to the aging population.
Mm-hmm.
Yeah, I guess using a cell phone all the time predisposes to subsequent kyphotic deformation. We know that people such as dentists have a higher rate of cervical degenerative disease because they're always bending over, looking into somebody's mouth, and their posture is very poor during the surgical procedure. I also warn our very tall surgical residents who are trying to accommodate somebody who's on the other side of the table who might be 6 inches or 7 inches shorter by leaning way over. So I try to encourage the surgeons to accommodate the tallest person in the room, and the shorter people use stools.
Thank you. I think certainly in my career, I have had a number of surgeons who use microscope, ended up having ACDFs. At least I can think of 3. But thank you very much, Dr. Bensel.
Thank you for having me.
There's a question from Dr. Alves, I think.
Yeah, very quick question, just to add that the interfacet joint cages at the cervical level, they have a very short leverage arm related to the central rotation of the disc, of the segment, which is quite different from interspinous process devices in lumbar spine. So the chance to produce kyphosis, I believe, is less. I don't know if you, Professor, agree on that.
Well, it's still dorsal. The facet joint is still dorsal to the axis of rotation. I guess I just don't understand the theory behind that, because you're putting a device that doesn't in and of itself fuse into a space where there's limited fusion surface area. And you can create, Roy Camille, who basically invented the posterior cervical plate, didn't even fuse. He just put screws in, and they went on to fusion, probably because the plate was right on the facet joints and disrupted the joint to a certain degree, and then they went on to fusion. But the bottom line is, I just try to get as much bone packed into that facet joint as I can, so I don't have a failed fusion.
Thank you.
Okay, thank you. I think in the interest of time, I think we'll just move on. It was a brilliant talk as always, Ed, and it's good to see you again. So now next we have Professor Mehmet Zalili, who's going to be talking about spinal deformity, surgery, limits, and complications. Mehmet?
Yes. Do you see my screen now?
Yes.
Okay. My talk will be dealing with spinal deformity surgery, limits, and complications. In general, saying there are adolescent idiopathic scoliosis, congenital scoliosis, and adult degenerative scoliosis or kyphosis. We commonly practice in our spine armamentarium. Actually, if we make some comparison between adolescent idiopathic scoliosis and adult degenerative deformity, in adolescent scoliosis, there is no pain problem, and main indication is cosmesis. However, in adult degenerative deformity, always painful, and main indication is pain and disability because of the deformity itself. And they have osteoporosis, frailty, and delirium tendencies. So then they need rehabilitation after surgery, and they may have worse outcomes in comparison to adolescent idiopathic scoliosis because they recover very well and they have good outcomes. If you look at the adult deformity complication rates, it's approximately 40% in lumbar degenerative deformity surgery. And the pseudoarthrosis rates are very high, and the reoperation rates is approximately 36%. And the reasons are pseudoarthrosis repair, need to lengthen the fusion, and adjacent level disease requiring decompression or another fusion surgery. And if you are doing some sort of osteotomy, the major complication rates may reach up to 42%. And the older age, 2 osteotomies and thoracic osteotomy increases that range. Complications of adult deformity surgery may be divided in 3 sessions. One is the adjacent segment disease. It may be caudal, especially at L5-S1 problem, or sacral or hip joint problems. It may be cranial adjacent segment disease. Most commonly, we use the term PJK, proximal junctional kyphosis. Another great division is the instrument failure and pseudoarthrosis, screw loosening, breakage, non-union. And systemic complications are also very important, especially in those ages. Avoiding adjacent segment disease is major concern in adult deformities by shorter fixations, less rigid fixations, compressive forces instead of distraction, providing a good sagittal balance, as Ed Benzel in recent talk stressed that by osteotomy or interbody fusion, and augmenting upper level by prophylactic vertebroplasty and some other measures. Caudal disease, especially L5-S1, can be avoided by trying to stop at L5 and do not involve sacrum to fixation if possible. If you make a very rigid fixation, the stresses may go downwards, and then sacral insufficiency fractures may happen. Even the hip joint problems may happen. PJK is probably the most common complication of adult deformity surgeries. The description is if the angulation more than 10 degree of proximal junction compared to preoperative measurements. For instance, this patient has 10 degree PJK. Incidence has been very different between different series. Proximal junctional failure, the term, if there is a mechanic failure and or spinal instability at the level, so then without kyphosis, this can be used. Mechanisms causing PJK are the lack of sagittal balance, deformity progression with aging, posterior ligamentous injury and facet injury or fracture, instrument failure, and degenerative disc disease. So risk factors are, major risk factors are age, wide preoperative sagittal parameters, using pedicle screws only because the screws may get loosened in comparison to hooks or other anchoring devices. Overcorrection is a risk factor. Fusion of the lower lumbar spine and sacrum is another risk factor. So the spinal implant density has been named as a predictor for PJK by some authors, like the one in this paper. And postoperative lumbar lordosis is a predictor for PJK. And PJK is more common with greater postoperative lordosis of the upper lumbar spine and greater postoperative upper instrumented vertebral angle. this series with 44 cases, PJK incidence was 38%. Risk factors they have found lower muscularity and higher fatty degeneration at the level of thoracolumbar junction. So then another concern is the muscle strength and atrophy. How can we prevent it? As I stressed before, sagittal balance, we must provide it better. Multi-level stabilization, longer instrument design is a better way of prevention of BJK. Protect soft tissue on upper instrumented vertebra as the muscles and facet joints. Using hooks, wires, or polyethylene junctional tethers at the upper instrumented vertebra. Proximal transition rods of reduced diameter, less rigid instruments and hybrid constructs, cement augmentation, especially in the upper level, and using composite metal in long fixations like cobalt chromium instruments and distal osteotomy. Sometimes achieving a good sagittal balance is very important to prevent BJK, even compensated balance cases. But if it is unbalanced, you may predict BJK in the future. Again, the importance of the sagittal balance, the whole spine films may show it us. Another concern is the osteoporosis. We must also take some preventive methods against osteoporosis using screws with larger diameters, more fixation points, do not apply forceful correction maneuvers, and using cements. This is a case of mine that I have used upper instrumented vertebra and 2 more level prophylactic vertebroplasty after a long fixation for deformity in an elderly patient. No correction loss in 3 years follow-up. There are papers saying that prophylactic vertebroplasty is good for PJK, like this one or this one, but there are also some concerns about the application of methyl methacrylate, since it decreases the disc nourishment and causes degenerative disc disease, and it may cause fracture risk on adjacent vertebra. So it is not good, they say. But using screw and hook has been studied by many, and then incidence of PJK is decreasing if you use some screw or hook instead of screw on the upper instrumented vertebra. This paper has Dr. Hart has collected many patients and then used a PJK severity scale by looking at the neurologic deficit, focal pain, instrumentation problem, changing kyphosis, PLC integrity, and upper instrumented vertebra +1 fracture and level of upper instrumented vertebra. So this is a scale actually, and after some scales, you'll consider a PJK will develop. So if it has developed, more revision if traumatic etiology, if proximal junctional angle is very high, if sagittal vertical axis high in female patients, and combined approaches. How can we treat it? First thing to do is to lengthen the instrumentation. If it is ending with L2, in L2, then you can go up to T10. If it's ending T10, you can go up to T2 or T5. Add vertebroplasty, use hooks, make decompression, and correct sagittal balance with an osteotomy or interbody fusion. This is one example with lengthening, it was corrected. But this is an example of my friend, Dr. Sedat, that is showing multiple revisions were required. Every time with lengthening, another PJK has developed, and the surgeon has gone up to T3 after 4th revision. In adolescent scoliosis, the incidence is very low, 7%. In adult scoliosis, 35 to 45%. And revision after deformity surgery, in general, I said in the beginning of my talk, is about 35%. And mostly the revisions are because of proximal junctional kyphosis, non-union, or infection. Another complication is our systemic complication, and major blood loss may not be tolerated by the elderly patients. In case of major systemic disease, simple decompression and limited fusion may be preferred. So the recent trend is using MIS surgeries. And there are new studies telling that major complication rates are quite lower with MIS surgery than open surgery, like this one. 14% with MIS, open surgery 45%. But MIS techniques is not good if SVA more than 100 millimeters, if more low doses correction is necessary, and in case of osteotomy necessary. Another thing, we must look at the elderly before correction of their deformities, the frailty index of those. And this paper from Journal of Gerontology 2007 is defining different scales and saying that robust, prefrail, or frail patients, if there is a frailty, so then the complication rate is very high in this report from 2018, and frail patients' 30-day mortality rate is very high, 16.7%. So using frailty indexes is a concern in the elderly patients. We must look at them, and we must also try to eliminate problems before surgery by improving their general conditions. So in conclusions, adult deformity surgery is like to operate or not to operate, and because of high complication rates, and we must try to resolve them, diminish those complication rates by trying to perform fixation as short as possible. And if you decide a long fixation, you must look at the sagittal balance, use cement augmentation for osteoporosis, use interbody fusion or osteotomy if necessary, but we must not forget osteotomy is a bloody surgery. Think twice for L5S1 level and tell the patient very high complication rates. Otherwise, you will have a good radiological views at the end of surgery, but patient may develop delirium, depression, and psychosis, and the patient may not be mobilizing much, may be frail. Thank you for listening to me.
Thank you, Mehmet. I think, again, a wonderful talk, all common sense stuff. What I wanted to ask you was, if really 1/3 of our patients are being reoperated, are we doing justice to our patients? Or do you think just by looking at frailty index, we might be able to reduce that complication that we are giving to our senior citizens?
Yeah, even if you are not exactly measuring the frailty index, because it's somewhat done mostly by geriatric physicians, you must look at the mobility of the patient. If the patient is not mobile, then you can get off making a big surgery, major surgery. practical.
Okay, and do you think MIS will take over and reduce the complication and help us in giving better results?
Yes, especially major bleeding is a big concern for those patients. After major bleeding and after correction surgeries, you can get more problems. Yes, MIS techniques will be much more used in the future, I think. Yes.
This is Ed Benzel. I'd like to make a quick comment. Salman,
Yes,
can I do that?
You are most welcome. And hi, Mary.
So, I don't do thoracic and lumbar deformity surgery. And I see the high rate of adjacent segment degeneration. And we look at the C2-3 angle that I spoke of and can minimize end fusion degenerative changes by simply normalizing that disc interspace. Have we lost sight, and I don't know this, I'm asking, of trying to end a long segment fusion at a stable vertebrae, which is horizontal to the floor, and a neutral vertebrae, which is the vertebrae between a curve? That was for you, man.
Yeah, I agree with that. Yeah, we must not stop at the junctional areas. We must stop at the neutral zone vertebra, but still some problems may develop. Yeah, but the especially adjacent segment disease is less if you look at those concerns. Completely agree.
Ed, can I ask you a question? So the deformity patients who are old, do they have different biomechanics compared to patients who are relatively youngish old?
Who are you asking?
Ed, I'm asking you this question.
Okay. I'm sure there are different biomechanics because they're less strong. The myofascial system basically supports the spine to a significant degree, and as it weakens with age, we have to rely on the spinal implant more. Interestingly, just yesterday, I had a virtual visit with a patient of mine who I corrected a significant cervical kyphosis with a C2 to T2 fusion and laminectomy and so on and so forth. And in the 6 months prior to my visit yesterday, she had an incredible increase in her thoracic kyphosis. And so I showed these to Doug Orr, and I says, "What did I do wrong?" And he says, "Nothing." He says, "Just welcome to my world."
Yeah. The muscles, the role of muscles are very, very important, I think, yes.
Salman, can I make a smallish comment?
Sure.
See, Mehmet, in some of my publications that you might have read, I have mentioned that deformity is a manifestation of instability. And the treatment of instability is stabilization. And osteotomies and deformity correction is not the primary aim of surgery. Primary aim of surgery is correction of instability. What do you have to say about that?
In the young people, in congenital diseases or something, it may be applied, but in very elderly, I don't think it's quite true. Maybe Ed Benzel can answer this.
Well, I guess I disagree with you, Atul. I think that, yeah, the idea of the purpose of surgery is to stabilize the spine. But if you stabilize the spine in an adverse, disadvantageous position, you're going going to decrease the chance that you've actually stabilized the spine. And so I think stabilization surgery or deformity correction surgery should focus on both stability and the deformity.
Okay, I think we'll move forward. It was a brilliant discussion. We are going to go into future. Atul, he's going to be talking about future of CV junction area. Thank you, Atul.
Thank you, Salman. Rather than future, I will like to discuss about how the treatment of craniovertebral junction has evolved in the last several decades. Craniovertebral junction surgery is indeed absolutely important for those who need it, and those who need it, and if they get it, they get a new life. However, the treatment has been and has remained and probably still is a little bit controversial, and controversies have not yet been entirely settled. So this is one article I could get from 1964 from my own department, where it has been said, 64, so about 60 years ago, that craniovertebral junction anomalies have only recently emerged from realm of anatomical curiosities. So essentially these were anatomical and they were not actually surgical issues. So they were radiological curiosities, anatomical curiosities, but not exactly surgical. So platybursia, this term was introduced in 1857. So this has been known for a long time, and the controversy has remained for a long time. And I believe now this controversy has been settled to a great extent, if not completely. This is another beautiful paper from Chamberlain, who we know as Chamberlain line, that the basilar invagination, the weight of head, actually, the spine remains stable, the head goes down, and this is what is basilar invagination. Another very phenomenal paper that was published in 1979, where it was earlier the only treatment of craniovertebral anomalies was decompression. So this was probably the first article where it was mentioned that decompression can be associated with sudden hematomyelia. And this is a highly referred article. And my belief is it changed quite a bit about how the treatment for these entities has to be done. Chiari malformation, syringomyelia, these things have been known for a long time. But after the introduction of MRI, after the introduction of CT scan in 1980s, they have been more, this pathology has been more crystallized and understood. Screws, facets, and atlantoaxial instability. These were not in the domain of neurosurgeons. Screws, no neurosurgeon knew what screws are. Facets, we never went in close proximity to these entities, and how these are related to atlantoaxial instability were unknown clinical entities, unknown things. So as far as my journey with atlantoaxial instability and craniovertebral junction was with this gentleman, Dr. Lahiri, who was an orthopedic surgeon, and he, with Steffi and influence of Steffi, where screws were introduced for the lumbar spine, we attempted to change and include this in the craniovertebral junction. And our study involved heavy dissection, cadaveric work, day and night, till we got some answers to these problems. And the location of C2 ganglion and the utility of sectioning this ganglion to expose the joint was another great advance in the exposure of the facet articulation and the screw implantation and fixation. So my techniques since 1987, many of you know, and many and have heard me on several occasions, involve three important steps: opening of the joint, removal of the cartilage, and introduction of bone graft in the joint. So this technique, I'm using since 1988, and this technique, many of you interested in the field know it very well. And this technique has been popular and has been used quite a bit all over the world. And this was my first case in the year 1988. Now, about 32, 33 years or 34 years ago. And this article has been quite highly cited and quite highly referred. And this was several years ago. This was amongst these two articles were in the most 100 most influential publications and other honors this article has received over the period. Occipital axial stabilization was another very important advance in the field of craniovertebral junction stabilization. Transoral decompression and fixation, this combination was popularized by Crockett and others during that time. And this was very commonly used, and Ransford loops and various kinds of loops were being used. So this, for instability, we introduced screws for C2 first in the year 1988. And then we included screws for the occipital bone. And occipitocervical fixation with screws and plates or rods has become a very popular means of stabilization. But our article about 15 years ago mentioned that inclusion of the occipital bone is not necessary and probably harmful in the treatment of craniovertebral junction stabilization. Transoral decompression was a hit thing or a very popular operation in the 1980s and 90s. We also had huge experience with this problem of transoral decompression. When to fuse after transoral decompression was an issue, and we attempted transoral plating for the first time in the literature. We've published this article from the clivus to C3, and then from clivus to C3 here after decompression. And this is, we introduced iliac crest bone graft after very heavy decompression. But as you know now, my concept is absolutely clear that decompression is not necessary in craniovertebral junction, and transoral decompression for such anomalies, not for tumors and all, is a completely historical surgery. So for 20 years, not a single transoral surgery or decompression has been done in my department. Radiological advancement has been tremendous over the years, from MRI to CT scan, and these three-dimensional models where we can see the vertebral artery, the state of facets, the state of pedicles in a beautiful three-dimensional models. And these can, you know, the where to insert the screw, where to insert this screw, where are the anomalies of the vertebral artery can be beautifully deciphered. And these 3D models can have become an in thing in my department whenever a complex craniovertebral junction surgery is done. Intraoperative investigation like navigation and other things have become a very important component of surgery, but whether they are really required or not, or whether anatomical information is more important than technological information, this will depend on individual surgeons. Basilar invagination has its own story, and my personal story has been quite long. In 1998, the concept was this basilar invagination is a fixed anomaly. Anomaly is fixed and decompression is the treatment, was the thing for basilar invagination. When to do fixation was a very discussed issue at that time in 1998. So this was transoral, this was foramen magnum decompression, and this was my classification of group 1 and group 2. In 2005 and 4, we introduced the concept that there is nothing like fixed anomaly, and we can reduce by manual manipulation and realign the craniovertebral junction. According to this, our classification in 2004, we divided into two groups, basilar invagination. This is unstable and this was stable. We did transoral decompression. We did craniovertebral realignment for group A and foramen magnum decompression for group B. So foramen magnum decompression was also an issue in 2004 for us, but we did for group A several patients with opening of joint, realignment of craniovertebral junction without any decompression. So this operation, as many of you know, has become quite popular with craniovertebral junction surgeons, craniovertebral realignment and stabilization. So in this, there is an era of decompression, there is an era of decompression and fixation, and now the current era is only fixation and no decompression. rotatory dislocation, the only treatment was decompression, but facetal alignment manipulation, you can realign the craniovertebral junction. So facetal manipulation has become quite a thing. Another beautiful and currently I think the most revolutionary advancement is the understanding of issue of chronic atlantoaxial instability and how nature plays reparative games in this chronic situation. Torticollis, short neck are all nature's protective maneuvers in the event of atlantoaxial instability. You correct instability, the neck becomes long and straight, and neck becomes long and straight in the evening of operation. So atlantoaxial instability results in several reparative secondary maneuver. So we don't like to call anomalies, we like to call alterations. Cervical fusion is not an congenital or fetal anomaly. It is a protective response to craniovertebral junction instability. This kind of fusion, you don't have to do any osteotomy for this. Even when there is no compression, you stabilize and you give new smile to the patient and new life to the patient. Bifid anterior and posterior arches, we have mentioned in our articles that these are not anomalies. These are alterations in the presence of atlantoaxial instability. You stabilize, and that is the need, and that is the treatment. There is no need to do anything else. So fusion plus bifid, there is no need to do any kind of decompression. It is atlantoaxial stabilization. Os odontoideum, we mentioned that it is also a protective phenomena to take care of nature. And this protective phenomena is an evidence of atlantoaxial instability. Even when there is no instability, if there is bifid, if there is short neck, if there is kyphosis, if there is scoliosis, they are indicators of atlantoaxial instability, even when there is no radiological evidence. Syringomyelia, this one, my fantastic paper, we said that it is not a primary phenomena. It is helpful and not harmful. And I have no doubt that after introduction of these articles, the number of syringostomies and syringomyelia shunt have dramatically reduced. In the year 1999, we likened basilar invagination to lumbosacral listhesis. This is C1, C2. So this was the unstable situation and stabilization was the treatment. This is listhesis. This is basilar invagination. You stabilize and realign. There is no need for decompression. Now we introduce a brand new classification of atlantoaxial instability and introduce the concept of central or axial instability. And if you read between the lines, you will see that central instability is present in basilar invagination, Chiari, syrinx, cervical myelopathy, OPLL, Hirayama disease. And I have no hesitation to say that this entity has completely the potential to revolutionize not only craniovertebral junction surgery, but the entire spine surgery. So this is type 1, whereas C1 is listed over C2, no question, stabilization. Type 2 is when the C2 is behind, C1 is behind C2, there is no atlantodental interval disturbance, there is no compression, but this is an unstable situation. Decompression is a negative phenomena in this, you stabilize. Type 3 is even when there is no atlantodental interval disturbance, no fast syrinx and other anomalies in the vicinity are clear indicators of unstable spine, meriting the need for stabilization. So this entity, this is unstable without any question, difficult operation, dangerous operation, but if you can do it, that is the treatment. This kind of basilar invagination, do not do decompression. It is an unstable situation. Stabilization is the treatment. So now we are completely believing that all kinds of basilar invagination, both type A and B, are due to unstable craniovertebral junction. Decompressions are negative in an unstable situation. Stabilization is the treatment. Atlantoaxial instability results in basilar invagination. Atlantoaxial instability results in syringomyelia. Atlantoaxial instability results in Chiari. You have to treat only atlantoaxial stabilization. So this was my article. Many of you know that we have mentioned that atlantoaxial instability is the cause of Chiari malformation and atlantoaxial stabilization is the treatment. Now we have an experience with several hundred patients where there is no real compression, no real facetal abnormality, but Chiari and syrinx have been treated by C1, C2 fixation, and syrinx will disappear, not disappear, reduce in 100% of patients if you do a scan after 1 year, and in about 20% of patients if you do a scan after 10 days of surgery. So there is no question that the scope of craniovertebral junction stabilization has remarkably increased in the past few years. So Chiari and syrinx and other telltale evidences of atlantoaxial instability. So these are secondary phenomena, Chiari, and I like to call it formation and not malformation. And this kind of syrinx reduction is a common event in my surgical experience. Idiopathic syrinx, do not treat by syrinx or shunt, any kind of shunt. Identify instability, even manual manipulation of facets during surgery can give you the indication of unstable spine. You stabilize and you see the magic. Spinal kyphoscoliosis with Chiari or even without Chiari can be associated with central atlantoaxial instability. You treat instability, the kyphosis will disappear. There is no need to do multi-segmental stabilization and C1, C2. You cannot ignore this. Central instability can be a discrete cause of cervical myelopathy, and you can create wonders by treatment even when there is no compression, presence of bifid, presence of other evidences, Klippel file, platybasia, bifid, ossodontoideum, and syringomyelia, and so many other things are indicators of atlantoaxial instability, and you have to treat atlantoaxial instability. Can foramen magnum decompression become historical? Absolutely, yes. I will take few minutes to go further into craniovertebral junction, which I believe will be the future of craniovertebral junction surgery, is degeneration of C1, C2. Is a common phenomenon, reduction in the joint space, presence of osteophyte, presence of buckling posterior are due to vertical spinal instability, vertical atlantoaxial instability. Bone formation in apical ligament is not a negative phenomenon. It is secondary, it is protective, and it is potentially reversible. Retroodontoid pseudotumor is an osteophyte of the C1, C2 indicating instability of the region, meriting the need for stabilization. This will disappear spontaneously. Cervical spondylosis, we have never included atlantoaxial instability as an issue. Facetal instability, this is central instability, even without compression. If you do not include C1, C2 in the fixation, there is no need for any kind of decompression in this multi-segmental degenerative spine and atlantoaxial. This is C1, C2 fixation, and subaxial fixation is the treatment for degenerative spine. In severe cervical myelopathy, no, not more commonly than not, there is central atlantoaxial instability, and you have to include C1, C2 if you have to give positive results to the patient. OPLL more often than not is associated with atlantoaxial instability. Even when there is no compression, you have to include atlantoaxial stabilization, even when there is no compression, and there is no need for any kind of decompression. These are all secondary to an unstable spine. You stabilize and you see the magic. Atlantoaxial instability is commonly associated with OPLL, and stabilization has great implications in the treatment. And believe me, ladies and gentlemen, and my dear friends, if you ignore atlantoaxial instability in OPLL, you can harm the interest of the patient. Atlantoaxial and subaxial spinal fixation, can it revolutionize surgery of myelopathy due to OPLL? My answer is absolutely yes. Hirayama disease, nobody knows what is the treatment, but there is central instability and subaxial instability in 100% of cases, and you have to treat, stabilize both of these things. So thank you very much. My concept is that atlantoaxial instability has huge implications in our life as a surgeon, as a life as a neurosurgeon and spine surgeon, and we have to learn how to do this fixation if we have to treat our patients properly, completely, and in their beautiful life interest. Thank you very much.
Thank you, Atul. Wonderful talk. Any questions? Atul enjoyed that future, and hopefully we should be able to have good data on it.
But I wish to have some questions.
we have had a long discussion over this, over many lectures, so we have had too much fun, I suppose.
Can I just ask one question?
Yes,
Dr.
Naren, please.
Thank you. Mr. Professor Goel, I'm not all the way towards your shores, but my ship is slowly sailing on that direction. The thing is that I don't, in terms of the Chiari 1.5, they are for me they are the tricky ones because they are not too bad and they are not Chiari 1. In those cases, you know, Professor Dr. Brockmeyer recently published their new metrics for deciding on fixation, craniocervical fixation, or just foramen magnum decompression. If I may just ask you on that thought, on that specific point, on that metrics, thanks.
You know, Naren, one thing is very clear. You know, I have got now more than 35, 37 years experience in this field. And whatever I'm saying is, you know, on the basis of very large numbers and very positive results. As far as foramen magnum decompression is concerned, the whole world has been doing that. And most of them have been getting good results. And I was also doing foramen magnum decompression. My paper was the first one in literature where we said we don't need to remove bone in foramen magnum decompression. This dura, we don't need to open the dura. But over the years of learning and training and enjoying my work, I have realized that foramen magnum, during those times, we were told that when we were appearing for examination, we were told that we should answer that foramen magnum decompression will not relieve your symptoms, but stall the progress of symptoms. This was the answer that we were supposed to give when the examiner used to ask us. But now I am saying that you do stabilization and you give new life, and not only new life after 2 months or 6 months or 10 months, instantly in the post-operative period, you will find that the person is relieved from majority of symptoms. Now, Chiari 1.50, these are very difficult terms for me, but Chiari is a Chiari, and you have to identify Chiari, even if it is 0 or 0.5 or 0.1 or whatever. Identify Chiari, relate it to the symptoms, and relate it, if it is there, it is atlantoaxial instability. Even if the symptoms are mild, you cannot say I will mild symptoms, I will leave it untreated. If it is mild, it is instability, you are letting it go. So many people ask me, if the person has very marginal symptoms, what you will do? I will say I will stabilize, because we are not going to leave a dangerous clinical entity in the patient. So there are many things to discuss. Of course, the time is a limitation, but Naren, we can discuss this issue on a separate platform. Sure. My only feeling is I am convinced in what I'm saying, and I have no hesitation to say that a revolution in the field has been made, and made completely, clearly, and positively.
Thank you, Professor Goel. We'll have the second part 2 of that craniocervical symposium hopefully soon. Thank you. Cheers.
Thank you.
Thank you.
Thank you, really. We have out of time, and we must come to the next speaker. But since Dr. Nicolas Theodore has an emergency case, he will try to connect us later. I call Dr. Salman Sherif to talk on the update on management of spinal cord injury.
Thank you, Mehmet. It's really my pleasure. I think I really enjoyed listening to all the talks up till now. I'm going to briefly touch on some of the aspects that are important for spinal cord injury. We know the pathophysiology into two parts. Primary injury, obviously initial traumatic force applied to the spine. So it's compression from bone, disc, or ligament, that material that it's extruding into the spinal canal and causing pressure. So that's the primary injury. Secondary injury that follows this, including microcirculation disruption, loss of autoregulation, edema, and ischemia. And obviously, initial management, evaluation, resuscitation, immobilization, extrication, and transport. Patients should be transported in cervical hard collar and side head support on a hard spine board with straps. We know that if you leave patients for prolonged time on spine boards, you can rapidly lead to pressure injuries. So full immobilization should be maintained, but they should be taken away from the hard board as soon as possible. Hospital management, obviously you need to manage other things, but besides other injuries, you need to be managing neurogenic shock, spinal shock, autonomic dysreflexia, and pharmacological therapy should be started. Log rolls are important. So the standard maneuvers to allow examination of back and transfer on and off the backboards. 3 to 4 people are required for this, and this is essential. So generally we use a Canadian 3 spine rule, 3 main questions. The high risk factors of cervical spine injury or spinal cord injury, age more than 65, dangerous mechanism of injury, and another person in the car who is involved in a major injury, paresthesias in extremities. And if you have that, you need to investigate the patient. So for that, you need to evaluate the patient. You generally observe abrasions, lacerations before. You need to be thinking about some kind of an extension injury. And then palpation for localization of pain, neurological examination, including cranial nerves, motor sensory function, reflexes, rectal tone, bulbocavernous reflex, incontinence, and then you look for loss of control of bladder and bowel, and then ABC treatment has to come in. Imaging modalities, plain X-rays, CT, and MRI. X-rays, if you don't have a CT scan, then obviously plain X-ray plays a role. AP, spinous process of the second cervical through all the way down to the first thoracic vertebra. And then lateral, base of occiput, all the way down to the C71. It's important to see those, otherwise you'll miss problems. Then you can have an odontoid view. But unfortunately, X-rays can miss injury up to 33%. So 1 in 3 patients could have an injury and you could miss an X-ray. It can have devastating long-term consequences. So it must therefore be presumed until it's excluded. CT scan, why do we need it? We'll talk about it. In all cases of head injuries or intoxication, when plain X-ray is inadequate, and it includes sagittal reconstruction as well. MRI further defines the level and nature of injury. So if you have time, you can definitely do that. If there are delays in your MRI, then you shouldn't be doing this. Identify the pattern and anatomical level of cord injury for prognostication. Identify soft tissue injury, ligamentous disruption, or intervertebral disc herniation. Obviously, it identifies hemorrhage, edema, cord swelling, increasing degree of spinal cord compression, and canal compromise. And if you've got a longer rostrocaudal lesion length, it may be associated with worse clinical prognosis. So all these are essential bits of MRI, and you need to be wary. So if you've got an obtunded or unconscious patient, and patient may have a normal X-ray or fine slice CT, there's a 98% chance that they don't have a significant spinal injury, particularly unstable or subluxation. MRI scan does not give you 100% clearance, but it will assure you that you've got very low chance of potential instability in the spinal column. Obviously, some of these injuries with displaced Jefferson fracture, Hangman fracture, type 2, 3 odontoid pec fractures, displaced subaxial fractures, subaxial subluxations and dislocations, all of them may require traction. The important thing to remember is that the Hangman's type 2 fracture traction may displace the fracture and adds dramatically to the risk of spinal cord injury and subsequent death. So you should be well aware of that. Neurogenic shock and mean arterial pressure. So this is very, very important. What we have is decreased systemic vascular resistance. 25% of cervical spinal cord injury experience a component of neurogenic shock and hypotension. And these patients, if you maintain the mean arterial pressure of 85 or greater for 7 days after injury, has demonstrated favorable outcomes. And we have shown that in many studies starting from 70s to 80s to 90s, but unfortunately we haven't done a proper randomized controlled trial on that. Dopamine, norepinephrine, epinephrine are common first-line agents for treatment of neurogenic shock, and every one of them is separate indication for same. This is Mehmet Zalili with Greg Charles from Wisconsin, having some good time in one of our Karachi spine courses. Well, Vaccaro, along with this group, came up with subaxial cervical spine injury classification system, and they came out in 2007, in which they had morphology, compression, burst, distraction, translation, rotation. And then they looked at the discal ligamentous complex and gave scores on that. And then neurological status, if it was intact, they gave 0, 3, an extra 1 score. So people who had higher not required surgery. And we use this routinely, and it's been validated many times. So classification of subaxial injuries, level 1, that it is reliable overall, internal consistency indicated by worsening of score reflecting worse injury. So Caro looked at a literature review from Medline database from 2007 to 14, and they found there was high agreement rate in SLIC score and treatment chosen, with more than 90% agreement between different surgeons. There's excellent intra-observer and inter-observer agreement among the surgeons with the SLIC score. This demonstrated SLIC is safe and effective in guiding treatment. And then we had this AO classification that came into play again by Vaccaro in 2013. So they divided into the fractures in which there was the compression fractures. They got minor, non-structural, wedge compression, split, incomplete burst, and complete burst. And they gave scores accordingly. And then they had what kind of tension band injuries that we had, and if there was translation, and if there was a facetal injury non-displaced with potential for instability or floating lateral mass or pathological subluxation. And if you had bilateral injury, you get a separate score for that. And then recently they've added neurology and modifiers into it, which works really well. So for example, in the algorithm, you could have a displacement or dislocation, and if it's yes, you go into translation. If no, if it's tension band injury, if it's yes, you go into B3, B2, or B1. Which tells you it's hyper extension, osteoligamentous, or pure transosseous injury. If no, if it's a vertebral body fracture, then if it's yes, again, you can divide that into the categories that we had seen earlier. So classification nomenclature works really well to divide these fractures into different forms on which basis you can decide they need surgery or not. There is radiographic assessments. If it's an asymptomatic patient, in the awake asymptomatic patient who is without neck pain or tenderness, who has normal neurology, who is without an injury detracting from an accurate evaluation, then obviously these patients do not need cervical spine radiology. We do not need to continue cervical immobilization in these patients. In the awake symptomatic patient, high quality CT scan should be done. With a routine, if we don't have a CT available, then routine 3-view C-spine radiographs should be done until we have the availability of CT scan. Methylprednisolone, there's a lot of been said and done on it. Still, lots of people worldwide are using it. Brecken came up with these 3 trials back in 80s. And he said that treatment options for acute traumatic non-penetrating spinal cord injury include the administration of high dose of anti-inflammatory agent, methylpred, within 8 hours. However, his 3rd study, they failed to demonstrate an effect in comparison to placebo. Additionally, due to increased risk of infection, he said that its use is no longer recommended. So a group, along with some of our friends in there, had looked at a critical appraisal of the results, and they came up with this report that the reporting of the results of NASCUS studies 2 and 3 have been incomplete, leaving clinicians in the spinal cord community to use or avoid using methylprednisolone in acute spinal cord injury on the basis of faith, rather than publicly developed scientific consensus. So the guidelines now clearly say that administration of methylpred for treatment of acute spinal cord injury is not recommended. It is not approved by FDA. There is no class 1 or class 2 medical evidence. There is class 1, 2, and 3 evidence that high-dose steroids are associated with harmful side effects, including death. Well, what about the timing of surgery? Lots have been said about this. So Stasker's trial showed that at 6 months post-injury, early surgical decompression was associated with 2.8-fold increased odds of a 2-grade ASIA improvements with no difference in acute complications. So there was clear evidence that if you did surgery within 24 hours that of spinal cord injury, there was a good chance you're going to improve their ASIA grading. We also looked at the same thing and found that 23% in the early group and 8% in the late group improved at least 2-grade ASIA improvement. And then again, Feeling came out with the study with talking about ultra early within 6 hours of a partial spinal cord injury, and they showed 70% of these patients improved 1 or more ASIA grade, whereas if the surgery was delayed beyond 6 hours, there was only 12% chance of improvement. What about facet dislocation? So if you had a mild unilateral facet dislocation, more often stable, conservative treatment with close follow-up could be done. If the patient is not fit for surgery, if the patient is neurological intact, if the external orthosis is inadequate for jump dislocated facets. Bilateral facet dislocation are unstable and require surgical reduction techniques, close reduction technique in awake patients, reduction performed with monitoring, not recommended to obtain pre-reduction MRI. It's successful in 60 to 90% of facet dislocation. Incidence of extruded disc is only 0.7 to 42%, but generally it's in the range of less than 1%. So disc retropulsion, post-traction, open or close possible. MRI, it's useful, but not accurate in predicting, and it's a controversial use in the early phase of a patient with a fracture dislocation. So open reduction, posterior approach, dangerous in presence of disc herniation, but that's what we talked about, that probably that's not a big factor. Requires 3 vertebral fixation for 1 motion segment and stability. Necessary to excise facets, also requires 3 vertebral fixation. Anterior approach, single segmental arthrodesis required, lower infection rate, higher fusion rate, better lordog alignment, more frequent voice changes, and dysphagia could be a problem. So there are various reduction techniques. I'm not going to go into detail of that, but these can be used, and they were written by Ed Benzel in his book quite a lot of years ago. What about prognosis in radiology? MRI plays a crucial role in evaluating and detecting spinal trauma. Subtle bone marrow, soft tissue, and spinal cord see them quite easily. Early detection can lead to prompt and accurate diagnosis and management and even prognosis. So this basic score that was described by Jason Talbot, they looked at retrospective records of 131 patients who had principal diagnosis of spinal cord injury, and they divided them into these 5 scores, with 0 with no appreciable intramedullary abnormality, basic 1 intramedullary type 2 hyper intensity, approximately confined to the central gray matter. Basic 2, when it goes all along around onto the gray matter and involves the white matter, whereas when it's completely involving whole of the transverse extent of the spinal cord, and 4 is when you got hemorrhages into it. And the interesting thing was they looked at these patients at the time of discharge, and they found that the basic 0 were majority in E, some in D, and all of them moved to E. Whereas the basic 1 majority were obviously C and D and improved to D and E. Basic 2 majority were A, B, and C. They moved to C and D, 88% of these. Basic 3, at the time of discharge, 67% remained in A and B. And unfortunately, in basic 4, all of these patients did not improve. So we can predict beforehand if you have hemorrhages, if the whole of the transverse line of the cord is involved, then it's unlikely that you will improve. What about DTI? What do we know in DTI? Our proficients with blend spinal cord injury in 11 volunteers, and they showed the DTI parameters reflected the severity of score in patients with non-hemorrhagic spinal cord. Functional MRI, this that occur in metabolically active neural tissue that is responsible for tested neurological function. The signal change is related to both the blood oxygen level dependent, which is bold contrast, and signal enhancement from extracellular water proton caused by an increase in water content in that area. As such, functional MRI is able to map out areas of spinal function related to motor and sensory function. So WFNS Spine Committee did this recommendation, and these are the recommendations for spinal cord injury now. Subaxial injury classification system is safe and effective in guiding treatment of subaxial cervical injury. There's good agreement rate in SLIC score, morphology, neurology, and discal ligamentous complex, and the treatment. It suggests that we should get MRI, which is not essential. The modified AO classification is equally effective, but is little complicated. There is no evidence that closed reduction of cervical closed facets have more benefit to open reduction. If a closed reduction is attempted, awake patients with incomplete injuries are better candidates. If a reduction in patients with reduced consciousness is attempted, pre-reduction MRI and open reduction should be preferred. If a closed reduction attempt fails, immediate anterior decompression and surgical reduction are better options. Best time for closed reduction is not well known, although most papers suggest it may be as soon as possible. All patients after closed reductions should be operated for stabilization and fusion, otherwise they're going to go back and you can have another dislocation and further injury. Recommendations of traumatic locked facet. In the management of locked facet, if a posterior approach is considered, preoperative MRI is essential. Traction helps in immobilizing the unstable segment and may help reduction, should be performed as soon as possible. In majority successful management, in chronic locked facet, lower cervical locked facets with no insignificant disc prolapse in conditions where anterior approach is not feasible, a posterior approach is indicated. So I thank you all, and it's wonderful to be part of this amazing session.
Thank you, Salman. Yeah, it is, you really summarize everything of spinal cord injury in one talk. I congratulate you. But I think we don't have much time for question and answers. I will now invite Dr. Nicolas Theodore to give us a talk on robotics and artificial intelligence in spine surgery. Yes, Nicolas.
Thank you very much. See here. Perfect. Can you hear me and can you see the slides?
Yes.
Okay.
Very well.
So, thank you very much. Beautiful talks this morning. And a very nice review, and it's nice to see everybody virtually. We're going to talk the next few minutes about what I think is where our field is going and how we're evolving, and telling this talk, Engineering the Future of Spinal Surgery, really utilizing advanced engineering principles and techniques and also technology to help us better what we do. You know, when we talk about robotics, people think of the movies and they think about this robot doing this autonomous surgery. We're not quite there yet. I don't think in our careers we're going to see this quite yet, but it's certainly something interesting to talk about. These are my disclosures for this, some of which are relevant regarding robotics. When we talk about the field, you know, our field in neurosurgery is very technologically advanced. When you think about what we were doing, this is Walter Dandy, who here at Johns Hopkins in the 1920s really started the field of endoscopy and used an endoscope, which turned out to be a cystoscope, a urologic endoscope, because there was no endoscopy at the time, and really was pushing the field forward. Harvey Cushing, and then on the left here is William Bovey. Imagine doing surgery without the Bovey electrocautery device, again, utilizing technology to help us push the boundaries of surgery. This is James Greenwood, who's from Texas, who really invented the bipolar and was a ham radio operator, and he was able to electrify the forceps to help us bring in the field of electrocautery with bipolar. So again, we've really been at the forefront of this. This is Jose Delgado, and we talk about deep brain stimulation. You know, he thought, well, can we implant an electrode into the brain of a bull and then push a button so the bull doesn't attack us? Sounds like a great experiment. You notice is that's not Dr. Delgado with the red cape. You don't want to be that guy out there. But the reality is we've been always pushing the envelope. And then comes in the 1970s, unfortunately, Dick Berglund was a neurosurgeon. He wrote this article in the New England Journal. He said, you know what? Neurosurgery stopped evolving. And while we may not go the dinosaurs path, really the field has become lifeless. And I think, you know, it looks like he took up tennis at the time, but the reality is nothing could be further from the truth. We really have had an epiphany when it comes to technology. When you look at this, you realize that there are, you know, now thousands of patents issued in the field of neurosurgery for image guidance and evoked potentials, deep brain stimulation. We really have been at the forefront of, you know, pushing the envelope when it comes to surgery. What has been transformational for us in neurosurgery and in orthopedics as well has been the ability to navigate. And when we talked about frameless stereotaxy, this is Watanabe, and the ability to see where we were in the brain transformed surgery forevermore. We're not doing brain surgery now without image guidance. We know exactly where we are. One of the problems with that is, and I realized early in my training, everybody's head is turned the wrong way. They're looking at the screen, nobody's looking at the patient. And this is a case from about 10 years ago. When I was in Phoenix, we were putting in percutaneous pedicle screws for a trauma with K-wires. And again, the attention's diverted. So the issue is, can we bring us back into the field, and how do we utilize this technology to increase our game? What we're looking for is increased precision and increased accuracy. We want to hit the target every single time. And the problem is in spine surgery, we're all very well trained at what we do, but if we're very critical of our results, we realize that we're not perfect. And, you know, this is a large series from here at Johns Hopkins. 9% of patients had a breach of pedicle screws. So think about that. Most of them insignificant. We have a small cortical breach. We're willing to accept that. You know, about 1%, a little less than 1% required some sort of reoperation. When you look at large meta-analyses, the fact of the matter is that freehand overall, perfect accuracy, about 68%. We start getting fluoroscopy, we get into the 80th percentile, and then with navigation and robotics, we're 95 percentile plus. So there's an incremental improvement. And this was a study that I saw Professor Benzel earlier that came out of Cleveland with one of our residents, Dan Lubelski. You know, we saw that what is the usage of intraoperative O-arm with navigation do? Well, a decrease in malpositioned pedicle screws, significant decrease in hospital stay, decrease in spine-related admissions, and decrease in the risk of reoperation. And ultimately, we want to avoid this. This is what we want. And it just takes one bad screw to ruin somebody's life and change things. But it's interesting because there's been a big chasm here with adoption. So Roger Hartle wrote this article in 2013, and only about 10%, 12% of surgeons were using image guidance. And the reality was that it slowed people down. There are obviously more considerations than that. One of them is an economic consideration. That technology is expensive, but the first and foremost thing is if it's available and it slows us down, we don't want to adopt that. I would argue that at this point we're at a very critical point in surgery. We have excellent advances in imaging, advances in surgery, and advances in robotics. Image-guided surgery now we've had for 30 years plus, surgical robotics with Da Vinci and other platforms we have, but it's the nexus of these image-guided surgical robotics, I think, that will usher in a new era for us in spine surgery and in brain surgery. When we talk about automating surgery, one has to not look in the too distant past. This was in Russia in 1980, and Fyodorov was doing radiokeratotomies, and he said, why do I have to go to different rooms to operate on the patients? Why can't the patient come to me? And this is just a beautiful setup. Imagine this, he would sit down, he would do the eye operation and move, the next patient would come in. Thousands of operations done. And again, your accuracy increases, your outcomes are better because again, you're doing things in a predictable fashion. This is Dr. Russ Taylor here from Johns Hopkins. This is the RoboDoc, one of the first commercially available robots for coring the femoral shaft. This is an endoscopic holder called ASOP, and it was used for thoracoscopic surgery for the chest surgery, but really was the first time that a robot was used in neurosurgery for spine. And what this did was to hold the endoscope when we were doing a lot of thoracoscopic surgery. This is Curtis Dickman, who was one of my mentors in Phoenix. Then came the era, the Da Vinci robot, which is very well known, really was born out of the need for the military to operate on somebody remotely. And this now technology for minimally invasive intracavitary surgery is standard practice throughout the world. Radiation, this is John Adler with the CyberKnife. And then we've got now robots for putting in brain electrodes. And we're not really talking about autonomous robots. What we're talking about are cobots. These are devices that work side by side the surgeon to make us more effective. And I would argue that that's happening. I'll show you some data on that. What we're looking for is to increase our accuracy. If you look in the left-hand corner, you see that with each robotic movement, there's a bullseye. We want to hit that target every time. We want the pedicle screw to be perfect. If we use the analogy of race car driving, this is 1964, this is NASCAR. The car pulls in, the pit crew comes out, they're doing some body work here. They're going to check the air. The fender looks a little bad. The driver's like, can you fix that? Sure, we'll go ahead. Let's go ahead and fix that. And then let's just kick it in here so it doesn't catch anybody. And this took several minutes. And then if we fast forward to 1984, this is the way I learned to put in a pedicle screw. We're going to palpate the anatomy. We're going to know in 3 dimensions where we are. And we're going to do this in an open fashion. And we became very good at what we do. No x-ray needed. When we have everything open like this, we can feel everything. Then you fast forward 20 years to 2016, and this in the same race track, NASCAR, what we see is that in about 13 or 14 seconds, all 4 tires are changed, oil is put in, gas is in, full system check, and the cars are out rolling. So I would argue that we can do better now. And this is just from a few months ago. We're now to the point where in a minimally invasive fashion, we're doing a minimally invasive TLIF, for instance. We've got 4 screws in the first 5 minutes of the procedure put in. And with 99% accuracy in a case series now of almost 400 patients. This is changing things. When we can do this in 5 minutes, the patients go home sooner. When we look back, my mentor Volker Sonntag and I were talking about this 20 years ago, our concept of what a robot would look like. Well, unfortunately, it would be great. Dr. Sonntag said, well, the robot can do everything and I can be at home and watch it from home. And well, that would be wonderful if we could watch from home. But again, the FDA is not going to let that happen. Why would we want to use robots? Well, what we're looking for are less invasive procedures. We want to decrease our radiation exposure. We want consistency, and we want to be able to plan. The radiation issue is real. If we're still shooting significant fluoroscopy at surgery, this is a documented health hazard for us as surgeons. The patient is having one operation, there's a tolerable risk dose. But when you start looking at the data and looking at the sobering numbers of orthopedic and spine surgeons, 5 times risk of cancer, and even with putting lead on and a thyroid shield, only about 66% of that radiation is blocked when we're in field. So I'm done. This is me about a year ago throwing away my lead. I'm not using radiation anymore. This whole project with robotics started about 20 years ago. And the idea was, can we automate targeting of the pedicle? And you can see here the ASOP robot. This is Neil Crawford, a biomedical engineer, my partner. And, you know, how do we do this? How do we design something with the surgeon and patient in mind to be able to bring robotics into the operating room? This is our first iteration of what became the Excelsius robot. And again, now this is the cadaver in 2012. Again, pushing a button, everything off the patient, the robot's not attached, the robot comes in, and we're, you know, putting in K-wires. And this is, you know, led me to believe that we can do this. We can automate this accuracy. This was 2012. And then 2017, commercial launch, and we're now doing this on a daily basis. And why would you use a robot? Well, we want real-time image guidance. We want to be able to navigate. So if it's a tumor, to know where we are. We want to be able to register the patient with intraop fluoroscopy or pre-op CT or whatever we've got available to us. We want to understand what's happening with force and surveillance during the procedure so that we can automate our accuracy and have feedback. The surgeon is still doing the operation and needs to understand what's happening. This is our first case that we did open here in Baltimore in 2017. The nice thing is you can plan. And what I've found is that we're putting in larger screws because, again, normally I would say, give me a 5.5, 45, you know, you'd tap. But now we're planning, we'll be able to look at the tolerance of the pedicle. We're putting in, you know, much larger instrumentation, getting better fixation, bringing the robot in. And then again, not even making the incisions very small because the robot tells us where the screw is going to go. So very small incisions. And again, to the point now where from draping the patient to putting in 4 screws takes about 10 minutes. I want to just show you a couple of cases that to understand the power of this technology. This is a patient with osteomyelitis and a kyphotic deformity. Again, small pedicles, challenging cases. You know, but the nice thing is not just for putting in the hardware, but also for understanding in real time with navigation where we are in the pedicle, where we are in the vertebral body, how close we are to critical structures as we do the vertebrectomy. This is a case of vertebral column shortening. We recently published a series on this, where we're, instead of doing this standard tethering operation, we're basically taking out in most patients T12 and doing a vertebral column shortening to take that tension away from the spinal cord. Seems a little crazy, but the reality is that in long-term follow-up, these patients, this seems to be a very robust way to treat this and avoids having to go down to do standard detethering operation. This is just showing you the artwork here of the T12 vertebrectomy, but look at this patient's pedicles. This is not something in the morning of surgery, my resident says, you know, the pedicles are very small. I said, yes, these patients usually have dysplastic pedicles. And I look at that, so I'm saying, okay. But the reality is with image guidance and a rigid robotic arm, we're able to expand that pedicle and place the hardware. And this is the post-operative picture. And interestingly, as we look here, this is an ultrasound of the spinal cord. You see sort of limited excursion, and then this is after shortening. And you see as a beautiful excursion of the spinal cord. And, you know, these patients, again, in the series that was published in March, tend to be doing very well. That's open access and available. Here's a patient with a high-grade spondy. Again, you know, being able to do a transvertebral screw, very helpful in this case where reduction can be dangerous and getting, you know, good alignment. This is a patient with fracture dislocation, BMI of 50 and a Jehovah's Witness with, you know, a multi-level trauma. These are very challenging cases because you don't have a tolerance to lose much blood. 1 hour case with minimal blood loss. Again, because we're making small incisions and utilizing this technology. We're now doing hybrid operations where we're essentially putting the screws in through the fascia and then doing the decompression, in this case of myeloma with cord compression. This is another case of an upper thoracic problem in a young girl, granulomatous disease, where we were able to fixate nicely. This is a gentleman with a bilateral hangman's fracture and severe spinal stenosis, so he needs a decompression, has a central cord injury, and utilizing the robot to put in direct pars repair, so sparing a motion segment here. So it can be done. Certainly, the pars repair is beautiful if things are aligned and you can get the fragment to align. With the robotic and steadying arm, it really makes this operation much a much easier thing to do. And we're now able to then look at our accuracy. So we're not looking at, are we in the pedicle or not? Now we have where we planned, we see where the screws are placed, and we're able to overlay that. When we published the first series of this, we realized that things weren't accurate. If you look at D, we're off. And that was the part of the issue. Was originally we had a little bit of deflection of the tip of the drill. Our technique has changed now, but we're learning as we go on. And we're now doing volumetric analysis, so I can understand exactly volumetrically. So not are we in the pedicle or not, but what's our accuracy in a volumetric level. And when we look at our numbers with that, they've been very good, basically 100% Gertzbein-Robinson now in several hundred patients with minimal deviation. The technology, like anything else, has a learning curve, and being able to practice makes perfect. We looked at our first series, this was 2 years ago, of our first 28 cases compared with matched controls. While there was less blood loss and less length of stay, the cases took much longer to start off with. And you see this at the very beginning. We were taking 3 hours, 3.5 hours, and now we're reliably down 4.5 minutes a case at the end of the series, and now we're less reliably under, for 1 or 2 level fusion, less than 2 hours, which really has been a game changer. And the literature supports this use now, and I think that when you start looking at review of all the literature out there, you realize that the accuracy is proven across platforms, and I think that there's a real benefit to this technology. Those of us over the age of 40 or 50 may say, you know what, I don't need it. I'm doing well with what I do, and I'm not going to argue with you. What I will say, however, are the millennials are embracing this. And the fact of the matter is that they are going to insist on this type of technology. When we start getting things more complicated, when we start having multiple platforms, we realize that what we're going to see is improvement incrementally in what we do and expansion of this technology. Cranial applications now too, same robot putting electrodes in the brain. And then when we talk about what else is coming down the pike, how about the ability to assess a patient's alignment at the time of surgery? One of the vexing problems for those of us that do scoliosis surgery is assessing how we're doing in surgery. So now we're working on technology that will allow us to measure intraoperative curve in surgery and have an understanding of how our correction is, and which is going to be very exciting. Other things that we're looking at are ultrasound. Can we use ultrasound to help us improve our registration, to help us improve our accuracy? So we use radiation, but can ultrasound help us? And I think there's going to be a significant power in this. How about this? The technology now exists and becoming more commonplace to take an MRI scan and make a CT scan. So imagine doing spine surgery without getting an X-ray or a CT scan, but actually physically changing the MRI scan into a synthetic CT scan. So this is something that's very exciting. These are physics problems, these are math problems that are being solved that will allow us to change the way we do things. This is known component analysis. We have a lot of scatter when we do these operations, but when the computer knows what the screw is, if we tell it what the screw is, it can actually clean the image up. Look at this, the clarity of this image here. You can count the threads. And the reason you can do that is because of some post-processing algorithm, again, making imaging much more accurate. Augmented reality, I think, is going to be not just for training. I think it's going to help us in surgery, help us focus on what we're doing and with less inattention to these details. So this will be coming out. Automatic pedicle screw planning is another advance that we've been working on here at Hopkins. I think we'll be ready for prime time soon, where we can take the scan and have the computer tell us biomechanically, utilizing Dr. Benzel's principles, techniques that and ways that people want, get us to be able to place perfect screws, and then ultimately segment and help us not be at the wrong level and pick out from a biomechanical standpoint the best way to do this. Device localization, another thing that we're working on. Can we look at a mobile tip and understand where things are in 3 dimensions? And then ultimately, I want to just talk about artificial intelligence. I think when you start thinking about the data we're accumulating, this is, I think, the end game for us in spine surgery. So looking at data from Epic and from the medical record, looking at imaging over time of the patient, preoperative imaging, postoperative imaging. We heard a beautiful talk earlier this morning on PJK. Can we predict that? Can we use all the demographics and imaging to say, you know what, this patient's at higher risk? And can we predict it before it happens? Can we say where should we stop these contracts and what should we do? And then ultimately utilizing patient-reported outcomes. So to help us understand who might need surgery, who might benefit from surgery. But this ultimately is where we will be in the future. We've been working on this quite heavily right now. Ultimately, I will say that this is an exciting time in spine surgery. We've got a lot of things happening with robotics and imaging, and these technologies are going to slowly make their way into the operating room. The reality is we don't have as much time with our residents. It's very difficult to train them, and this enabling technology really helps raise the bar for all of us as we continue to care for our patients. So Dr. Sharif and everybody, I'd like to thank you for the opportunity to address you this morning, and thanks for letting me be a part of this.
Good talk, really, Nicolas. Actually, I assume that in the future we will not need a talented surgeon. The robots will do all the things.
So listen to me. I think that once again, the surgeon, this is meant to help us. You're the surgeon. We're making the decisions, and I will tell you that there are shortcomings with all technology, whether it's image guidance or robotics or a pedicle probe. Everything has its limitations. The goal is not to eliminate the surgeon. The goal is to give us tools in our armamentarium to make us better. But I don't want to put myself or you or anybody else out of work. We still have to do it, and we're still going to be advancing the field. So the technical surgeon always has a place. I can't put us out of work, and we're not going to do that.
Nick, just a question. Sorry, I'm sure there are limitations. What is your biggest limitation at the moment with this kind of surgery?
So, as far as limitations go, I think understanding where inaccuracies can be. What I don't want are people to say, oh, the robot says to go here, the spinal canal is here, we're going to go right through, but the robot says, no. There still has to be a ground truth. There still has to be an understanding of anatomy. And I will tell you that teaching this type of surgery is a little bit different because it's different than the way we were taught to do it. But the reality is that I think there's benefit, but you have to understand. So again, to Mehmet's point, I don't want to put us out of work. This is just a little bit different way of thinking things. So now we have to think about, we're making tiny incisions. How do we assess our accuracy? How do we know if something has moved? How do we know if the patient has moved? How do we account for that and continue to provide the highest level of accuracy and care for our patients?
Doctors, Professor Zileli, is it okay if I ask, comment and ask a couple of questions, Dr. Zileli, Professor Zileli?
Yeah, please.
Thanks. Thank you. Thank you very much, Dr. Nicolas Theodore. That was fantastic lecture. Certainly exciting future. I'm mainly a pediatric neurosurgeon today. I change specialties quite often, but in pediatric neurosurgery, we nowadays use axiom-guided VP shunt insertion. I tell you, it's changed the whole game. Now the big game in putting a shunt in a child was getting it in the right place or getting it in wrong, and then go to the parent and try to say that I put it in the wrong place. And you want to put it in the middle of the ventricle, and that we now use pretty much every shunt, even EVD and it really has now that we can concentrate on the other things that causes complications. And touch wood, but my shunt infection rate is now pretty much zero, and my revision rate in the last year is zero, because this small incremental changes really make a big difference in the overall outcome as well. So that's one observation from a different field that you guys might not put shunts, so you might not know that. Thanks.
Well, put in enough ventriculostomies by day, and there were enough misplaced ventriculostomies. I mean, utilizing this type of technology for something that seems as simple as that, and it's something that we did for 50 years freehand, you realize that if we can make that easy to do and cost effective, there's a benefit, right? Because if you're putting a shunt in for the long term and it's not where you want it to be, it's not going to function optimally. So I agree with you.
Thanks. Thank you. And this is I'm going to come back to you, Dr. Theodore, but I just want to go back to Professor Sharif. Professor Sharif, in my practice, I put baclofen pumps for spasticity, and the reason for baclofen pump is because if you give the systemically the baclofen, it's too high dose for the patient, so you give it through the baclofen pump, and the patient's the spasticity or dystonia is like a kind of a miracle. And that's the same question I wanted to know in terms of this. We have had this discussions about steroids and spinal cord injury for so long, and the main detriment was that the steroids had side effects. Whether giving intrathecal steroids, which will cut down by a factor of 1,000 the dose, for example, in baclofen, would that be has that been ever looked at? Actually, I can think of the same thing for the head injury. With CRASH trial, they used huge amounts of steroids, and the problem was systemic problem. So whether you can put a EVD and give steroids, whether you can put a thecal pump and give steroids, just a thought, and what you thought about it. Thanks.
I have not seen any study with intrathecal use of steroids, but one of my colleagues used to talk about it, giving it with the EVD, but he did not see any improvement in his patients at all. If at all anything, if we are doing anything, new thing that we are doing is looking at the intrathecal pressure in some patients with spinal cord injury and seeing that are we making a clear-cut reduction in the pressure by taking away whatever surgery we do or whatever treatment we are giving. So that's what we're seeing, but I haven't seen any study. I'm sure other guys must have seen some study on this.
Has anyone else come across any intrathecal steroids, Professor Zileli?
No.
No, thank you. There's another question that we pretty much have a large number of the greatest spinal surgeons here. It's a real honor for all of us to have you. And my colleague who is another pediatric surgeon with a passion for head injury told me yesterday, Naren, we seem to spend, as a neurosurgery, spend more and more money on less and less things and less money on more and more important things, in the sense that neurotrauma is a specialty that's we're neglected because it's not sexy enough. But the question for me is that with spinal surgery, once again, we are getting more and more sophisticated. But do we have leaflets for general patients or our spinal patients about how to look after the spine? As we say one of my friends said, you have to look after yourself in the winter to have a summer body. And whether in terms of these millennials, they are very keen on being healthy, whether the societies, the WFNS Spinal Committee, the World Spinal Column Society, and we have got Mr. Andreas Dimitriadis, who has recently published papers on ergonomics, whether spinal societies are putting emphasis on education, whether that is a possibility or it's not worth it. Thanks. If I may ask all of you, thank you.
In fact, this year there was a conference on called Spine 2020 about the general health issues related on spine, and it was together with the other societies, European Spine Society, the other societies. We are implementing global spine education and some other recommendations to the governments, especially for low and middle income countries. But these are not having a result yet. We will try to do that. Yes, it's not an easy task.
No. Changing behavior is not easy. Professor Sharif, you are now taken over from you are WFN, the president of the World Spinal Column Society, and now the chairman of the WFNS Spine Committee. What's your thoughts, sir?
I think I totally agree. We already have a lot of brochures that many of us share and use it in our clinics and our institutions. So every institution has some kind of public awareness scenario. And, we keep on doing a lot of CMEs on those. And there's a lot of public awareness programs that we conduct. But yes, I agree, we should have a formal program of that and use a lot of other institutions' help to improve them all over the world. I agree that there are areas that really need a lot of attention, and we need to work on that. And hopefully we'll do. But I wanted to tell you that Nicholas is going to take away your work because your tethering of the cord is gone now, since we're going to shorten every vertebra. So,
I mean, we are happy for him to take the tethering.
Very.
Oscar, want to say something?
Yeah. Very quick question, Nicholas. Excellent lectures. I mean, just a very brief comment on ethical issues. Medical legal things are always going behind technology. We don't have much legislation on the topic. So just a brief comment on responsibility, accountability, liability of these robots.
So, I think that, the reality is that, if there is some sort of mishap, as surgeons, our first posture is always to blame the technology. I think if we're, thoughtful, we realize that there's probably, two sides to every story. The reality is, again, with image guidance, with anything that we use, there are, shortcomings technologically. And I guess the issue is that from a medical legal standpoint, from my standpoint, if you look at the numbers of misplaced pedicle screws that lead to litigation, it's not a small number. And, at this point, with 5 years experience in robotics and more than that with all platforms, the number of, legal suits is not high. It's there. There's going to always be that case. I think, once again, it's really a call for us to continue to push, because as we continue to make the accuracy better, as we continue to make the technique more refined, there'll be more checks and balances for us to understand where things may not be where we want them to be. The medical legal is not going anywhere. And, here in this country, and, since I moved to Baltimore, where it's, unfortunately, it's one of the highest rates in the country, it's something that we deal with every single day. We do the best we can. And again, there's no way out of that except being careful and trying to build the technology that it has enough redundancy so that we have feedback if something is not right, so that we're not in that situation.
Nicholas, probably Ed Benzel we can make some comments.
I have two comments. One, Nick, your comment about the millennials embracing this new technology and the old guys and gals like myself not using it. And I find myself doing less and less complex surgeries as the millennials, or whoever they are, the younger folks, are embracing these technologies. I think it's a natural history of things. The millennials of today, when they're 70 some years old, are probably going to give way to the new waves of technology. And we all just need to accept that, I think, because it's the way it is. And I also like your comment about these technologies do not replace a surgeon. It doesn't make a bad surgeon a good surgeon. And there's an old Southern United States phrase or story that says, a fool with a tool is still a fool. And so the surgeon must be very competent in order to adequately use these new technologies. It doesn't make a bad surgeon a good surgeon.
I agree 100%, Professor. I thank you for those comments. But what it does open up is a different way, a different paradigm to teach our residents and to use this technology. What I don't want is somebody to see, oh, it seems so easy because it works the first 5 times. But having that continual feedback so that they understand where the shortcomings are. But you're absolutely right. I appreciate it. And I just sent you, Professor, a text, Professor Benzel.
You what?
I just sent you a chat message offline for 1 sec.
Okay.
Dr. Professor Zileli, can I just bring Mr. Andreas Dimitriadis, who's the president of the European Association of Neurosurgical Societies, and he's a spinal surgeon, and as you all know, and he's interested in the ergonomics.
Please.
Andreas, do you have any idea, any thoughts on education, whether EANS will be doing it or whether that's too much to change people's habit? Thanks, Andreas.
Thank you, Naren. Very kind of you. I was watching with interest all the talks. So congratulations to all the speakers. Good to see Nick Theodore, fellow Greek, from the other side. We looked at the ergonomics because we had a few members who were complaining of musculoskeletal disorders, and we looked at it in a few different ways, through a systematic review and then through a survey. And even though we found a lot of problems reported amongst colleagues, we haven't really identified those factors which we had presumed to be triggers. For example, we assumed that skull-based surgeons would have had more problems because they operate for longer operations. We assumed that lumbar spine would be, because of the height and looking down, might be more of a risk. We assume that endoscopes might provide a slight advantage, but to be honest, this is way too early to identify robust data, and it's simply a beginning of an effort. So maybe it's time for a study group to look at that more specifically, to be honest.
Thank you very much.
I think we can conclude this session because we are quite out of time.
That's fine.
Thanks all the speakers for their very nice presentation and good discussion. Thank you.
Thank you very much, Professor Zileli. Thank you very much, Professor Salman Sharif, and thank you very much for the distinguished speakers. It really has been fantastic to have this collaborative meeting with the World Spine Column Society and the WFNS Spine Committee, and I really hope that I know you guys are august societies, but certainly the listserv will be always happy to collaborate in anything, in any way that we can collaborate with you. So thank you very much for this absolutely excellent session. Look forward to you joining us again next year. Thank you very much.
Thank you, Naren. Wonderful. Good to see you all.
Thanks.
Thank you, everybody. Thank you, Nick, for turning up.
My pleasure. Thank you very much.
Very grateful.
Thank you. So now we move to the next session. We have got another absolutely fantastic skull-based session with 4 fabulous papers, and we have got 2 very distinguished neurosurgeons who are going to chair it. It's Professor Miguel Arez, who is the professor and chairman of neurosurgery at the Department of Neurosurgery in Malaga, and he's a doyen of skull-based surgery. And we have got Mr. Ramesh Nair, who's the skull-based surgeon at the Charing Cross Hospital in London and active in the WFNS Education and Anatomy Committee. So we have got 2 fantastic chairs for this session. So thank you very much, Professor Arez and Mr. Nair. So shall we move to this session?
Sure.
Thank you.
Thank you, Miguel. Good to see you, Miguel.
Good to see you too, Ramesh. How are you?
Very good. Very good. You want to start off and without wasting more time, so you could start off, Miguel, the lectures.
Okay, so we maybe I can make the introduction of the first 2 speakers, and then you can do that with the last 2. Okay. Hello, everybody. My best regard from Malaga, Spain. We will start the skull-based session with a very interesting topic, that is microvascular decompression for glossopharyngeal neuralgia in a single center. This lecture is going to be addressed by Adriana Fernanda Segura Senon from Mexico. So please, Dr. Senon, go ahead.
Sure, thank you.
Let me know if you can see my
Yep.
screen. Yes, okay.
Thank you.
So, well, greetings from Mexico City. I hope you're having an excellent day from wherever you're following this session. I am really pleased to be here, and I want to thank Dr. Naren for this space. My name is Adriana Segura, and I'm going to talk about microvascular decompression for glossopharyngeal neuralgia in a single center. So I am going to start with a short definition of the glossopharyngeal neuralgia. It is a disorder characterized by unilateral brief stabbing pain, abrupt in onset and in termination in the distribution of the glossopharyngeal nerve. And pain, it will be experienced in the ear, base of the tongue, tonsillar fossa, and or beneath the angle of the jaw. And I think it's really important to talk about a background over the years from this pathology. So I'm going to mention some interesting data. In 1910, Weisenberg first described glossopharyngeal neuralgia as an essential pharyngeal pain. Then in 1920, Sicard and Robineau were the first to describe a surgical intervention for patients with glossopharyngeal neuralgia by dissecting the pharyngeal nerve and the branch of the vagus nerve in the neck. 7 years later, Dandy performed an intracranial rhizotomy of the glossopharyngeal nerve as a treatment. And then in 1977, Janetta observed compression of the glossopharyngeal nerve by the vertebral artery, and that's how the etiology of this disease became known. After that, Laja and Janetta initiated the first non-destructive treatment for glossopharyngeal neuralgia, giving rise to microvascular decompression in the posterior cerebral fossa. So now that we have this summarized background, I am going to present our work. And the purpose of this study is to describe our results of the microvascular decompression to treat glossopharyngeal neuralgia, as well as to inform the surgical findings and the outcome of our patients. So our method was based on a period of time from August 2016 to October 2021, where 94 patients were diagnosed with glossopharyngeal neuralgia, where 37 of them were diagnosed with glossopharyngeal neuralgia in its classic form, and 57 of them in combination with other neuropathies, of which 29 patients was our sample in this studio because they are patients who underwent to microvascular decompression and fulfilled the inclusion criteria, such as a complete clinical record, MRI disc, surgery report with video and drawings, and also histopathological reports. And age, sex, time of evolution of the symptoms, intraoperative finding, and postoperative results were evaluated in this studio. So here you can see a video where Dr. Mauro Segura is realizing the microvascular decompression of the glossopharyngeal nerve. You can see it here. And also you can see that the cisternal segment is identified in its exit prior to the jugular foramen of the glossopharyngeal nerve, and some fibers here of the vagus nerve on the right side. Towards medial deep, contacting posterior inferior cerebellar artery was identified. Then it was dissected, and finally isolating material was placed to avoid this contact. Okay, so now that you see the technique, we are going to talk about our results. And the mean age of patients with glossopharyngeal neuralgia was 56 years old, with ranges from 33 to 76 years. And the average time of evolution of the symptoms was 7.5 years, with ranges from 1 month to 23 years. Also, there are no statistical significant differences in gender and in size of the pathology, different from the trigeminal neuralgia, where female and male ratio is 3:1. So talking about comorbidities, it is important to mention that it is presented in 52 of our patients, where we can highlight systemic arterial hypertension, diabetes mellitus, and dyslipidemia. But it's also important to emphasize that these comorbidities do not affect on the evolution of our patients. And also, as you can see, the incidence is as in the general population. So talking about surgical vascular findings, the leading cause of compression was the superior cerebellar artery, followed by pica, ICA, and vertebral artery. About the histopathological findings, we include arachnoiditis presented in 92% of our patients, where it could be viscous fibrosis or with microcalcifications. But this microscopic information with histopathological findings will be reviewed and analyzed in another study to relate how they affect on the evolution of our patients. Now, talking about the diagnosis, it will be clinically, and MRI will help us to confirm or support our diagnosis. Nevertheless, a vascular contact cannot always be observed until surgery. So look at this 3D Fiesta MRI at the level of the jugular foramen, and note the right side of a patient where we can see how vascular contact looks like here from posterior inferior cerebral artery, better known as pica, that is a direct branch of the vertebral artery. So now talking about to the postoperative evolution of these of the first 48 hours of our patients who underwent to surgery, vomiting, nausea, headache are the most common reports of our patients in 60% of them, and major complications such as cerebrospinal fluid fistula occurred in one patient, and he required a reoperation. Also, just one patient present transitory facial palsy. But as you can see, there is just a minimum number of patients with this postoperative evolution. So we use the following classification to capture the results for having a registration of our outcome. And all our patients present immediate improvement of the glossopharyngeal neuralgia symptoms after surgery. Almost 70% of them reported themselves without pain. 6.9% of our patients report themselves with mild pain, but no medication requirement. And 10.3% of them reported moderate pain adequately controlled with medication. And here I would like to emphasize that these patients have been using drugs that do not relieve pain for years, on average 7.5. And now after microvascular decompressions, they do not need any drug, and it's finally controlled the pain with medication. And finally, we got a 6.9% of our patients that were candidates to radiofrequency thermoablation due to the residual pain. So as a conclusion, we conclude that minimally invasive microvascular decompression as the first selection surgical treatment for glossopharyngeal neuralgia is the most effective and safe surgical procedure, allowing a good resolution in most of the cases, 93% of them. And we do not recommend neurotomy or rhizotomy of the glossopharyngeal nerve due to the transient secondary sequelae, and a more detailed analysis could be done in order to find any possible relation among the surgical and histopathological findings with the long-term outcome. So finally, I want to finish this session with Matilde Petra Montoya Lafraga. She was the first female doctor in Mexico from the National School of Medicine, where in those times the participation of women was not approved, but Matilde fought to achieve her goal of being a doctor, and before 1887, there was not a single female physician in the entire country, so she made history and forever changed the course of medicine. So thanks to her, doors were open for many Mexican women on the path of medicine, science, and knowledge. Thank you very much. Here is our email where you can write us and leave us any question, and we will be very pleased to answer all of your questions as soon as it's possible. Thank you so much.
Dr. Segura, thank you very much. And congratulations. Excellent talk. Very well presented. Very good results. Congratulations. I have one question, but maybe my co-chairman wants to make any comment or
Yeah, thanks, Miguel, and thanks, Adriana. That was a very good talk, and thank you for bringing up this topic because it's not as common as trigeminal neuralgia or hemispatial spasm, but we do still see the cases with significant morbidity related to this problem. And I have to say the number of 94 patients quite impressive. It's almost in about 5 years' time. The only question I have also about the histology, the microcalcification. Where was the histology taken from? Was it around the adjacent structures around the glossopharyngeal nerve? So do you know where the biopsy was taken, Adriana? I think you're muted.
Adriana?
I think she's muted.
She's back.
The biopsy with the calcification and the fibrosis, where was this actual histology taken from? Was it around the tissue of the nerve?
Yes, these biopsies were taken from at the microvascular decompression moment. So they are taken from the arachnoidaries that are found at the surgery.
Okay, thank you. Yeah, I think there's nothing much more for me to add. I can see Andre. Andre, you want to? Andre?
No, thank you, Ramesh. No, I enjoyed all these talks, and the last one was very impressive. I think I agree with your question because sometimes we know you can't take a biopsy where you would like to do because it is difficult, because when it is very adherent, you leave it alone. And probably if you would be able to take that, you will have other histology findings. But nevertheless, this was very interesting, also very good good results, to be honest. For such an amazing number, indeed. I haven't seen that many cases in all of my career. Yeah, very nice.
I think if I may make a comment, I know Professor Segura for now about 25 years. We met at the North American Skull Base Society around the middle 1990s. And it's what I want to mention is that, it's very, very generous of him to get his team to present, and same was with Professor Yekin Angeli, because whenever you come to pediatric neurosurgery meetings, most of the time the consultants are presenting the work. So first of all, thank you to Professor Segura to get his team to. Is Professor Segura, do you want to make any comments, sir?
No, everything is okay.
Okay, great. Thank you. Excellent. So the second, Miguel, I'll leave it to you, Miguel.
Thank you. Thank you very much, Dr. Segura. Very nice presentation. And I think we all have been having the same issue in our mind, the issue of the histological finding. That is something surprising. So now let's move to the next talk, that is also regarding microvascular decompression. And the talk is about the efficacy and safety of microvascular decompression for trigeminal neuralgia in patients with morbid obesity. Dr. Aaron Giovanni Munguia Rodriguez from Mexico as well. Please go ahead.
Thank you. Can you hear me? Can you see me?
Yes.
Okay. Good morning from Mexico. My name is Aaron Munguia. I'm going to present you efficacy and safety of microvascular decompression for trigeminal neuralgia in patients with morbid obesity. We are talking about trigeminal neuralgia. That is a chronic neuropathic pain disorder characterized by paroxysms of electric shock pain involving one or more divisions of the trigeminal nerve. Pain severity can hinder activities of daily living and impairs quality of life. The pharmacological therapy includes anticonvulsant medication that initially reduce the pain. However, the efficacy of the medication generally decreases over time and can cause important side effects. Microvascular decompression is the most effective treatment to achieve long-term pain relief of trigeminal neuralgia. Microvascular decompression is offered to young and healthy patients neurosurgeons tend to be reluctant to offer this surgery to elderly and obese patients due to the comorbidities that could cause complications during general anesthesia and posterior fossa surgery. Trigeminal neuralgia is another life-threatening condition by itself. However, it can cause lifelong episodes of pain, becoming disabling. A quick and accurate diagnosis as well as a proper management can be beneficial for patients and lead to a better prognosis. No single studies of microvascular decompression have been done in patients with morbid obesity due to the small sample size and the refusal of some surgeons to operate on these patients. The aim of the study was to evaluate the safety and efficacy of microvascular decompression to treat trigeminal neuralgia in patients with morbid obesity. From February 2017 to October 2021, we attended 1,634 patients with hyperactive dysfunctional syndrome. We excluded patients with other neuropathies to only have patients with classical trigeminal neuralgia, of which the non-operated and those who received other types of procedures were also excluded. 589 surgeries were performed, of which only patients with normal weight and patients with class 3 obesity were included. Demographic characteristics of pain, comorbidities, pre, peri, intra, and post-operative data, as well as complication rates and outcomes were collected for each patient. We selected morbid obesity patients with the objective that their results were more contrasting. The diagnosis of trigeminal neuralgia is based on a clinical evaluation to identify unilateral facial pain associated with trigger points and characteristic paroxysmal and electric nature of pain. Routine MRI was performed in all patients to confirm the neurovascular conflict and rule out another entity. The surgical treatment should be offered only to patients who were refractory to medication, who refused to percutaneous procedures, or patients who received such treatments with unsatisfactory results, especially those whose quality of life is seriously compromised, regardless age and weight. Obese and morbidly obese patients require more medical care and monitoring before undergoing surgery. Prior to surgery, comorbidities will be controlled. It is recommended to eat healthy, mainly foods with fiber. Medications such as anticoagulants should be suspended. And especially it is recommended to perform exercise with an spirometer from 7 to 14 days before the surgery to improve lung capacity. The routine lab tests for all patients include blood count, blood chemistry, general urinalysis, and coagulation tests. For obese patients, studies of lipid, liver, and thyroid profiles, as well as chest X-ray and electrocardiogram are added. Possible candidates for surgery are previously evaluated by the neurosurgeon, by an anesthesiologist, and by an internist. If any abnormality is detected that interferes with the operation or endangers the life of the patient is referred to the corresponding specialist and undergoes treatment until it is controlled and surgery is rescheduled. If control is not achieved, the patient is no longer a candidate for the surgery. All patients are informed about the risk of the procedure and sign a consent letter. The steps of the surgical technique are listed here, which is very similar between normal and obese patients. The main difference is the difficulty of position and intubate the obese patient. They require the placement of an endotracheal cranial tube with metal core, central and urinary catheter, and anti-embolism stockings. The procedure also needs a skin incision of 5 to 7 centimeters. This is larger than a normal weight due to the adipose tissue. The procedure, at this moment, the surgery is carried out in the same way, always monitoring the stability of the patient. Another important point to highlight is to consider the prevalence of a high intracranial pressure in the obese patient that is reported before by our group. The results, we included 50 patients with normal weight and 26 grade 3 obesity with an average body mass index of 23 and 43 respectively. Female patients were more abundant in both groups. The right side was slightly more affected. And the average age in both groups was similar, around 53 and 51 years. The duration of symptoms before the surgery was 7 and 9 years, with no significant difference between the two groups. The characteristics of pain were similar in both groups, being the combination of branches B2 and B3 the most affected. The type of pain was mainly electrical. Most patients mentioned that pressure and movement were the main triggers of the pain, and patients present severe intensity at the time of the surgery. These results indicate that obesity does not influence the characteristics of pain. In the case of preoperative comorbidities, all obese patients had a higher number of comorbidities than normal weight patients, and they also presented with multiple comorbidities. Metabolic and cardiovascular comorbidities such as diabetes and hypertension were the most common in obese patients. Normal weight patients have a higher number of respiratory comorbidities, mainly by tobacco dependence. It might be thought that obese patients have consumed more medications. However, we found that the number of medication ingested was similar in both groups. Most of patients use carbamazepine. What we must highlight is that the dose of carbamazepine used was significantly higher in obese patients, possibly requiring higher doses due to the greater volume of distribution. Before anesthesia, we found that obese patients had higher degrees of ASA physical status classification and higher intubation difficulty scales. So anesthetic management of obese patients requires more attention and care. Regarding the times, the hospital stay and the duration of microsurgery did not show significant difference between groups, while the stay in the operating room and the anesthetic time, as well as the duration of surgery, were longer in the obese. More times mean the use of more medical supplies. Regarding the intraoperative findings, there were no significant difference between groups of patients. The contact mainly is arterial and single by the superior cerebellary artery. When it is a venous contact, the pontine veins are the main or the most frequent. These findings suggest that there are no obesity-related anatomical change in the neurovascular conflict. Postoperative complications are very diverse. However, the frequencies are very similar between both groups. It was only shown that the obese patients have more nausea in those of normal weight. Obesity does not seem to increase the risk of suffering more postoperative complications. However, the medical center must be prepared for any unexpected event. Microsurgical decompression reduces the pain in both groups in a similar way. So obesity does not appear to affect the efficacy of the surgery. In the most current follow-up, 48 patients present good results, excellent results, sorry. 20 had good results, 5 had persistence, and only 3 had recurrence. So far, our results suggest that obesity is not related to persistence or recurrence. However, more studies are still required. In the extra handling and the extra supplies to guarantee the safety of the obese patients generates an additional cost to the surgery of approximately 15%. Microvascular decompression should be considered in obese patient where is the only effective treatment, to improve the quality of life. Safe and effective microsurgical surgery can be achieved with careful perioperative management. Thank you for your attention.
Thank you very much, Dr. Munguia Rodriguez, for very nice presentation and just perfectly fitting in the program regarding the time of the presentation. Well, I don't know whether my co-chair, Professor Ramesner, wants to make any comment or any question.
Yeah. Thank you, Miguel. I think it's a very good talk, and I agree with your conclusions. The large number of cases is such an important condition that I remember when you were talking about the trigeminal neuralgia. I remember doing my fellowship with Professor Cano almost 20 years ago now, if I think about it. He said for a neurosurgeon, there are two stressful operations to say. One, he said, was the trigeminal neuralgia operation, and the other one he said was the elective unruptured aneurysm operation. I think the reason he said that, the reason for that was essentially they are normal patients, right? You're operating on a normal human being, and you're doing a big operation on these patients. So that makes you give some more stress. So I think that is true. And in terms of the position you mentioned, sometimes I feel lucky to be operating on head, because if you have an obese patient, we were lucky that the head doesn't get obese, so that you don't have to worry about, unlike spinal surgeons or general surgeons who have to deal with such morbid obese patients. So, but I think in terms of the position, my concept, my view would be in terms of a lateral position versus supine position would be the shape of the neck and how thin the neck is rather than the actual size of it. Because positioning laterally in an obese patient is quite difficult, and there are anesthetic issues, as you correctly pointed out. And also, thank you for looking at the other implications of operating on these obese patients, because the cost is higher for them and they stay in hospital for a longer time. There are anesthetic issues and medical complications, including CSF leak, sort of increased incidence of CSF leak, which is a concern for many of these patients. And so I think that's what I have to mention about it. There's nothing else I would say. I can't really think of anything else. Anyone else want to make a comment?
Can I invite, if is it okay, Miguel, can I ask Dr. Aaron Cohen-Gadol, whether do you have any comments? Dr. Gadol?
He might
yeah. Okay, that's okay. What do you call Prof. Grottenhuis? Do you have any comments, sir?
I just agree with Ramesh that well, the position it depends. I have to say that in obese patients, you're fully right that usually the general surgeons and our colleagues, the spine surgeons, have more difficulties in these patients. But nevertheless, the neck could be thick and could be sometimes there is hardly a neck. So in a supine position, turning the head, this is something I actually, even in the outpatient clinic with these patients, I already test that. I test also in elderly patients, I just test how far they can easily, without any complaints, move their neck. And that's because sometimes it is arthrosis, they can't do that. And if it is already a patient that is anesthetized and is in your operating room, you can more or less force anything, especially if you have a head clamp, skull clamp, and then you turn that head any way around. What I teach my residents is that they always have to look to the opposite jugular vein, that is kept free. And why I do it is lifting the mandible. The mandible, you lift it up before you start turning, so that the outflow is always free. That's the reason that I never let a resident operate who was not present during the positioning, because positioning is so essential. And in obese, it is even more. I mean, these patients are there, and if they have trigeminal neuralgia, we have to take care of them. But there it is a little bit more tricky. And I loved your study that you can show that at the end, there is not much more problems with them, higher cost. But I would think about thrombosis. I would think about CSF leak because, they press more. A venous compromise, that you would have more difficulty with cerebellar swelling or anything. It's great to see in the study that more or less we don't care. This may be for us to start with when we finally are inside. Doesn't matter at all. So wonderful study. Congratulations.
Thank you. Okay. Thanks, Miguel. Shall I introduce the next two speakers, Miguel?
Please
Thank
go
you.
ahead.
Thank you. So we have the next speaker from Argentina on endoscopic versus microscopic microvascular decompression for trigeminal neuralgia and diagnosis of hemifacial spasm. Dr. Andres Servio, please.
Thank you very much. Do you see my presentation?
Yeah, you could make it into the slide mode once you maximize it. We can see your slide, but can you maximize it and go into the slide mode?
Okay.
Yeah, that's good. Thank you.
It's a great pleasure for me to be here. Of course, Naren, thank you very much for allowing us to make our presentation. It's a very big pleasure for me to see my very big friend Miguel arrive from Spain. When we received your invitation, I started to think about this word, the cost in neurosurgery. So we have to think in the possibility to make our presentations regarding how the surgeons must be efficient, but also effective in our procedure. You know, in Latin America, in our countries, we do not have so much resources, and medicine is expensive, surgery is expensive. So the neurosurgeons in the future must be very, very careful, not only be involved regarding the outcomes, functional, radiological, and oncological outcomes of our patients, but also in the cost of our surgery. It's necessary to have, we are obliged to be involved in this market because it's completely different maybe in the north than in the south. So in the next minutes, I will present our it's a preliminary results comparison between the endoscopic and microscopic surgery for the microvascular decompression. You know, the endoscopic techniques, it's common to say that there is improvement in the visualizations. Some surgeons said that you can detect better the conflict between the ventral aspect of the nerve. I am not saying that the endoscope is better than the microscope. It's only an opinion. And maybe you have better control to release the neurovascular conflict. About brain retractor, if you are a good surgeon and you have a good visualization with the microscope, you can also do the surgery without brain retractor. And I put the last two sentences with the question mark. Better surgical results and less complications. It depends on the literature or the series you are analyzing on. This is our material and methods. It's a group of patients operated on with microvascular decompression because of trigeminal neuralgia and facial spasm. All of our patients had different medical treatment before with failure of them. All of these patients have the same MRI sequences with Fiesta and Angio MRI, and we have the approval of our scientific committee. Regarding surgical technique, we use retrosigmoidal suboccipital approach in park bench positions. The skin incision is smaller in the endoscopic technique than in the microscopic techniques. Also the craniotomy, now we are doing between 2 and 3 centimeters with the endoscope. We perform neurophysiological monitoring with ring reflex in neuralgia trigeminal and lateral spread in facial spasm. We prefer to do Teflon interposition technique, not a sling technique. We never drill the suprameatal bony ridge when we use endoscope, and we never dissect the cerebellar tissues in this case. In using the endoscopic, I prefer to use the 0 and 30-degree lens for dissection and semiology. We do not use scope holder, I prefer the assistant to use the endoscope because, you know, when we work with the same assistant, it's like two brains thinking in the same situation. So the assistant always is a little 1 second before you and put the endoscope because she can predict which maneuver you will do. In the right side patients, I like to put the endoscope in the union, in the tentorium between the transverse sigmoid union, and in the left side, I put the endoscope over the lower cranial nerve. It's better for young neurosurgeons. It's very important to start the learning curve with the introduction of the instruments and the visualization to avoid sometimes the lesions of the cerebellum or other neurological structures. But when you are more and more involved in endoscopic techniques, it's like your brain is thinking before your hands. But it's very easy to know where is the structure, and you are looking at the thing, and you will put the instrument like doing under the endoscope. And it's very important the intermittent irrigation to avoid. For me, the only critics to the endoscope, which is the fogging of the lab. This is an example, a brief example. You see here the ventral compression of the trigeminal nerve. The visualization with the endoscope for me is completely different than the microscope. I am not saying that the surgery has to do or must do with the endoscope. I prefer this technique, but you will see the difference in the microscope. It's important, but not completely necessary to do with the endoscope. Some surgeons said that when you are operating on with the endoscope, you lost the possibility to work with the three-dimensional vision. I mean, this is an old discussion started with the general surgery, with the cholecystectomy in an open fashion or with laparoscopic techniques. And I mean, when you are training in 2D techniques, it's not different for me. This patient has 2 days of internation, loss of effect, maybe because of the size of the craniotomy and the evolution of the patient. This is a comparison between two patients. This is the vision, excellent vision with microscope. You see here the compression between the vein and the trigeminal nerve, and this is for me better, but also with the endoscope. This is another example of you see here the compression of the facial. In facial hemisphere is completely different because sometimes you have to do more retraction of the cerebellum to go to the entry point of the facial nerve to the brainstem. So endoscopic techniques for me are more useful than in the trigeminal neuralgia. You see here the retraction of the cerebellum is made with the lateral thread with the cotton over the cerebellum and with some instrument. You can deflect the cerebellum and see perfect the compression between the vessel and the facial nerve to put the cathode in between. This is the improvement of the lateral spread and then the interposition of cathode. Of course, I repeat several times because it's not my intention to make a statement that this surgery must be done by the endoscope. I prefer this, but if anybody has a good result with microscopes, it's not necessary to change the technique. This is our result. You see here is a preliminary experience with 20 cases. You see here 10 in the endoscopic group and 10 in the microscope group. It's small sample, but you see here surgery is longer, more time in the endoscopic group. Of course, you need Lerner tube, you have to take some precautions during the movements under the endoscope. But we have some statistical difference in the size of craniotomy. The craniotomy was smaller in the endoscopic group, of course, because we do this on purpose. And the loss of space. This is very important to save resources for the hospital. I mean, you can do the same, doing the same approach, smaller approach with the microscope. But for us, what's very important to see, to make this comparison, to oblige us to start our microvascular decompression with endoscope or with microscope with a smaller approaches, because it's very important to save these days for the economical result. Of course, we have more hypoesthesia, maybe because we do more dissection during the endoscopic surgery, and complete resolution is similar between them, and we do not have very big complications. What does the literature say? In 2013, it was published that maybe pure microscopic technique was the technique of choice. But 6 years later, you see here a meta-analysis confirms that endoscopic microvascular decompression is superior. Of course, our opinion, I repeat, it's not. I am not saying that this is a statement. Which are the limitations of our presentation? It's a retrospective study. The sample we are trying to include more patients. It's not randomized. And all of our endoscopic patients were operated on following the microscopic group, because we are starting doing more and more surgery with the endoscope. And the strength maybe is a monocentric study. Our institution is only a neurological institution and the same surgical team. In conclusion, endoscopic surgery is safe and effective procedure to do this type of surgery. It's necessary sometimes to measure our, not sometimes, every time it's necessary to measure our results, but sometimes to move from our comfort zone. I mean, I performed many years the surgery with microscope. Microscope has an excellent visualization. I was trained with microscope, but someday I started with the endoscope, and it's necessary sometimes to move from our comfort zone. Neuroeconomics, I repeat, it's very necessary to have into account the resources, because cost in neurosurgery, cost in medicine. Always, everybody started to speak about the cost of medicine because of the pandemic of COVID. People ask us as a physician, how many money do you need to start to cure the COVID? And nobody knows how many money do you need for surgery. So it's important for young surgeons to know that it's necessary to be a good surgeon, but also efficient and effective. Thank you very much for allowing me to be here. Pleasure.
Thank you. It was a beautiful talk, Dr. Andrea Savios. Really liked it. I think you really highlighted so many important key concepts in both microscopic and endoscopic surgery for the younger neurosurgeons and the trainees. And also you yourself mentioned about the limitations of the study. What I liked about the technique of endoscopy, which you correctly pointed out, I suppose the general trend everywhere is going to go minimally invasive, but whatever that takes to avoid brain retraction, I think is quite important, especially in the MVD surgery, because as you know, any retraction can lead to some neurological deficit, especially if one is not very careful. Not that it's going to happen with microscopic surgery, but I remember reading about apoptosis of the cochlear nerve with some brain retraction for MVD surgery. So any technique to avoid that sort of problem. And also the other thing is retraction of the cerebellum sometimes can lead to tearing off the tentorial bridging veins, which can be an issue in microscopic or endoscopic surgery. And the one point you mentioned about avoiding competition between the endoscope with the instrument, and that's a big concern, especially in endoscopic skull-base surgery. And it's more even so in the MVD surgery. If you do have like a sword fighting between instruments, the instrument can sharply jerk off and then hit one of these important structures around it. So one has to be really careful. I think that's the key point the youngsters should know about. Otherwise, I think it was a great talk. I would like, Miguel, if you would like to make a comment on it.
Thank you very much, Ramesh. First of all, Andres, great to see you. And congratulations for this wonderful presentation and beautiful videos. I think this is a very good example of how minimally invasive techniques, endoscopic techniques are, just moving forward in our neurosurgical practice. And I think that endoscopy in general has advantages in regarding microsurgical assisted endoscopic assisted techniques or endoscopic intracranial techniques, I always have the concern regarding one issue, because you can see very well from the tip on the of the endoscope onwards, but you cannot control what is behind, and could be something risky. Have you had any problem regarding that, Andres? You know what I mean? Because this is what the saying that Ramesh was saying. You know, sometimes you cannot control what is behind your the tip of your endoscope.
Yes, yeah, I agree completely with you. I don't remember having had any special problems with this situation like you asked me. I can tell you different things, I remember at the beginning of our learning curve to put, for example, a scissor or a bistury, and then to start to looking at the screen and forget where is my skin. Sorry, my hand, and then when I see to the screen again, I make some bleeding to the structure. So sometimes it's necessary to readapt your visual spatial way of thinking. But after many cases, I'm not sure how many cases you need between endoscopic through the nose or through the skull. But after having some number of surgery, it's like you readapt your brain. And the possibility to make this type of mistakes is less and less. The point for me is microscope is not completely 3D. 2 days ago, I read a comment, somebody sent me a paper saying that microscope is not always 3D and endoscope is not always 2D. It's a comparison between them. And it's true that when you have the very best microscope, you have the focus in one point, but all around this focus is not in a very, it's out of the focus, and you have to open or not to open the focus of the microscope to see around this point. With the endoscope, you have more or less the same, but the possibility to see in this big plane. Okay. I repeat, I'm not saying that the endoscope is better than the microscope. No, I perform maybe 80% of my cases in general in surgery with the microscope. But sometimes when we can put the endoscope like assisted surgery, for me it's really an excellent because the visualization with the endoscope is completely different than the microscope.
Thank you very much, Andres. To my mind, a very balanced and very elegant presentation. Thank you very much.
Thank you very much.
Mr. Nayak, can I ask you quite a basic question, if that's okay?
Yeah.
Thank you. Dr. Servio, in terms of, do you get any heat injuries from the endoscope? How far do you keep the endoscope from the surgical field with the light as well as the actual heat coming? Thanks.
Yes. Excellent question. You know, I have this concern many times, also in the endoscopics through the nose, for example, for tuberculous cellular meningioma, with the chiasma and the optic nerves. I am a little bit more worried about the heating because of the breathing, but not because of the scope. I have never had any, I mean, I never recognize any problem because of this possibility. Maybe if I have some case, I never realized about it. Some papers mention this topic, the heating of the scope, but maybe because we use many times saline solution because of the fog of the endoscope. Maybe we do not have this problem because of the irrigation, but I don't have we didn't have any problem, at least recognized.
Yeah.
Thank you.
Thank you. I think I just want to make a comment on that, Naren. In terms of the heat injury, the endoscope is your eye. So you don't really, you want to have an overview of the field you're operating. So you're not going too close to the structures. And as Andres was saying, there will be irrigating solutions around it. But to have a heat injury on the structures you're viewing is very unlikely unless you're going to hit it. Okay, we will go on to the next speaker. Thanks, Andre, again. I will go on to the Thank you. Going to the next speaker, we have a speaker from Mexico, Dr. Mero Alberto Segura Lozano, talking on the epidermoid cyst of the anterolateral cisterns approach through a minimally invasive route. Dr. Mero Segura, thank you.
Thank you very much, Professor. Good evening to everybody. First time I want to congratulate while I'm sharing my screen. I want to congratulate to Naren because this big effort to join a huge amount of giant of the skull-based surgery. I'm very happy to be Professor Arraiz, Goel, Schwerer, Neil, of course, Naren. Thank you very much.
Thank you. You could share your screen if you want. Yeah,
maybe it's ready. For today, I would like to show the experience about the epidermosis located at the posterior fossa. And again, this is the 11th Virtual International Conference. This is a big effort, so congratulate Ned.
Thanks, thank you.
I would like to show this universe because this is our topic. And we are talking about the hyperactive dysfunction syndrome of cranial nerve. My previous professor talked about that, but in our experience in the last decade, we have received as for treatment more than 2,200 patients. As you know, the most important casuistic is over trigeminal neuralgia. As you can see, 83% of all the patients have trigeminal neuralgia. About 50 of them go on their microsurgical treatment. One of them, microsurgery, endoscopic, radiofrequency, even gamma knife. But today we are going to talk about the secondary type of trigeminal neuralgia according to the CRU classification from Italy. And in this case, only 14% of patients have this entity. And among these 14, the epidermosis represent 1.4%. This is very small amount of patients, but in our casuistry, this is the largest register in Latin America with this pathology. In our experience, the first place is occupied by post-herpetic and the second place by epidermoid cyst. This tumor is a slow-growing brain tumor of embryonic origin that manifests in the later in the life. You can see 3 peaks in the 3rd decade, in the 5th to 6th decade, and a small peak after 70 years. It's very strange, but it's very common. Another important point is the anterolateral cister of the brainstem is the most frequent location. We published this a couple of years ago because we are not completely agree with the pontocerebellar angle location. It's not a located tumor, but extended tumor into or under the anterolateral brainstem cister, as you can see in this picture. Also, I want to say that they represent about 2% or less than 2% of the patient presenting at the first symptom as trigeminal neuralgia. Of course, the high definition MRI, Fiesta or other companies would be the best imaging study. I want to point in this three items. As our philosophy is very important for the young neurosurgeon. The first point is preserve the life of the patient. It's not the number, it's not the picture, it's not the amount, it's not the time. The first objective for surgeon should be to preserve the life of the patient. The second point is do not damage or do not cause any more damage to the neurovascular structure adjacent to the surgical site, in this case, the brainstem. And finally, eliminate the cause, talking about the tumor and talking about the epidermoid cister. Of course, to remove the tumor totally or almost totally. This is an example. And the next slide, this is a reference, but we don't call the pontocerebellar angle cister tumor located. We prefer to call anterolateral cister. It's published. In this case, The previous professor, Munguia, talked about the morbidity obesity patient. I'm not going to repeat, but in normal weight patient, we prefer the supine position. It takes about 8 minutes to do the preparating position, much shorter than the sitting position. That's why I prefer to reduce cost, to reduce exposing of the brain, to reduce fatigue of the surgeon, and of course, to limit risk of the surgery. Last year, we talked about this 10 step. I'm not going to repeat because it's the same that everybody do. But especially I'm going to point at we call last year subasternal. It's a mistake. The perfect site, the exact site for the craniectomy should be the infrasternal site, at least about less than 2 centimeters. As you can see in this picture, we don't know more than 18, 20 millimeters is enough to the microsurgical approach. We're talking about a small nerve, less than 5 millimeters. So we don't need more, even when you use endoscopy. Of course, we don't never use brain retractor. And talking about the tumor removal, we do the debulking technique. And finally, in some cases, it's possible to total removal, including the implant area. And the last point is hermetic closing of the dura mater and soft tissue. This is our table. You can see this is our series. We received 33 patients, including infratemporal and supratemporal located. In this table, only we include the infratemporal and also located at the anterolateral system. 2 of them prefer, and the patient themselves decide for the gamma knife. So we exclude this for this information. Average age 43 years, no different about trigeminal neuralgia. And most of them from Mexico, some from Portugal, Spain, Peru, US, etc. Our timing for anesthetic is about 213 minutes. For surgery timing, it's about 3 hours. Talking about the tumor removal, double time of the trigeminal neuralgia. Staying days less than 3 days, and our follow-up is average 36 months. There is no difference about right or left side. All of the patients have a good evolution. That means there is no deficit or neurological deficit. There is no complication that cause disability. Some of them have minor complication like short-time fistula, like short-time facial palsy, or maybe paresthesia. I will show you in the next minute example. This is one of the patients, and as you can see, it's possible to do this by 18 millimeters. This is our approach to the angle. You have to close sound. Okay. First, it's very important to pay attention in this area. The tumor, it's never invading, it's never infiltrating to the arachnoid. It's not an invasive tumor. It's a benign tumor. It's not invasive. Another point is that it could be accepted, the tumor, but in fact, it's a monocompartmental tumor. This is a high velocity record. However, I will show you another angle. We have to remove all the angle at the deeper in the surface and the cranial, caudal, and as you can see, we are able to remove most of the tumor. And in this case, it was possible to remove the implant area. In order to time, I will show the next. This is the preoperative MRI. You can see almost a big tumor, not more than 4 centimeters. And this is postoperative also without tumor. The next case is very important. It came from Portugal, very interesting athletic man. I'm going to reverse because this is very important. We don't do this surgery without all the elements. Technology should be very close to the surgeon and the patient. To open this bone, you can see almost 15 millimeters of spessor of the occipital bone. And finally, our minimal invasive craniectomy, 16 millimeter, and the same. First step, open the arachnoid. Second step, the bulking of the tumor. I'm going to running faster because this is not interesting for this chart. And little by little and piece by piece, we are removing the epidermal cyst. And finally, in this case, the tumor was located and the implant was located at the 5th nerve. So we try, and finally, it was not possible to remove the implant area. In the next peak, we will see. I will show you. This is the 7th nerve. This is close to the implant area. We should be very careful, very obsessive to remove all, as most possible, the tumor. And we are on the 5th nerve. Please, you pay attention. This is the 7th nerve. This is the 5th nerve. This is implant area. It's embedded into the trigeminal nerve fibers. So we decide to leave this small, maybe less than 4 or 5 millimeters, in order to preserve the sensitivity and facial integrity. So after 5 years of follow-up, the patient is very happy and running marathon every month, every time. So that means residual tumor for us. This is preoperative study. This is postoperative. I'm not pretty sure if this is a residual tumor or it was taken 2 days after surgery, maybe HELF1. And if we have time, I would like to show another complete resection. But in this patient, she have the same step: open the arachnoid, removing by the bulking. We only use aspiration, only single aspiration, no CUSA, it's not necessary. Removal of the implant. But in this case, the patient have an extension to the supratemporal region, to the to the mesial area of the lower temporal lobe. So we are very close. You can see implant area. We are removing, taking a picture. And this is right side surgery. So you can imagine at the bottom, there is the temporal lobe. And some area of the residual tumor, we intentionally leave. In our opinion, there is no risk for these cases. Integrity of the neurovascular structure. The most possible, we prefer not coagulate the veins, and integrity of the surgical area. Okay, a little of hemostatic, surgical, and finally, this is the postoperative. Postoperative MRI. I'm going to run the video. This is preoperative. This is postoperative. Please, you pay attention. This is the extension of the tumor. Most of the tumor is located at the anterolateral, left anterolateral sister of the brainstem. And this is postoperative. This is GELF1. And in the last picture, GELF1, this also is GELF1. However, there's here a small amount of tumor in the medial side here, medial side to the temporal lobe. It was not visible by this approach. However, the patient remained asymptomatic. Here we can see the infrasupratemporal limit. Here is the preoperative. I know this is not ideal picture for epidermolysis, but this is the coronal view I have. And maybe, again, maybe this is the residual tumor without any symptom, not epileptic, no confusion, no any symptom. So we decide, as same than other patient, to don't remove and don't do another supratentorial approach. And well, finally, I don't have the surgical view, but this is a largest tumor that you can see, including all the anterolateral cister on the left side involving the trigeminal nerve. This is postoperative. And in this case, here, we left this mesial temporal lobe tumor and some area in the Turca cellar. So the same criteria. So we this patient have asymptomatic. This was finding. So we decide don't remove the remaining tumor, and every year we are doing the pituitary biochemistry test, of course, and MRI. Well, in order to the time, I'm going to show our opinion. This is another case. Some cases like this, we have to do, you know, two-stage approach in supratentorial and posterior fossa approach. They will be topic of the next in another chat. Finally, our conclusion. Our series, the epidermolysis cases, is the Brandstein is one of the largest published in Latin America, and based on the excellent long-term result obtained, we propose this as minimally invasive microsurgical approach as the best treatment. And this response I would like to emphasize. First, comprehensive anterolateral cister anatomy of the brainstem as a 3D space concept. This is the most important, and I'm sure that most of the people, some of the neurosurgeons have different criteria. This is not pontocerebellar angle tumor, definitely. So second point, this is a nocceptate but monocompartmented and not infiltrative tumor. It's only located under the adjacent arachnoids. It never invaded. We analyzed it and there is no invasion. So we don't have to be worried about to total removing included the arachnoid, just inflamed, not infiltrative. And third, complete of total excision without implant zone is the goal of the first surgery. The first surgery, as Mefty says, it's same than meningioma, is the best surgery. And we recommend to do this to the young neurosurgeon. So thank you very much. I would like to stop here in order to hear your opinion. Thank you very much.
Thank you. Thank you, Dr. Seguro. Excellent talk, great experience. And in your beautiful videos, you have demonstrated the excellent microsurgical technique, especially for the trainees and the young neurosurgeons to follow, not disrupting the microcirculation to the nerves when you're trying to remove the epidermoid. The one other thing which also would point out, not to spill these contents into many other systems which are not involved, to avoid contaminating those systems. Otherwise, I would say it's a great talk. And Miguel, if you have any more points to add or anything, any tricks or tips from your side for epidermoid tumors?
Thank you very much. Thank you very much. Another beautiful demonstration of the usefulness of endoscopy. Well, regarding tips and tricks, I like very much the sitting position and for CP angle. And in this particular pathology, I think it's especially useful because you have the patient in the sitting position. If you have to deal with a big tumor, just flushing with the saline, the tumor itself is coming down and is eliminated himself, you know, and this is a very helpful tool. In the other position, lateral position, all the debris and some part of the tumor is going to the bottom, and you have to rescue that. if the patient is at the sitting position, insofar as you are flushing, the tumor is coming down and very easily aspirated and eliminated. This is my personal way of doing things with epidermoid tumors.
Thank you. Thanks very much. And Andre Grotenius, are you still there, Andre?
Yes, I'm still there. I'm still there.
Anything you would want to make a point in terms of epidermoids or the CP angle?
No, I think endoscopy, at least in endoscope assisted, not fully endoscope controlled only, but endoscope. The endoscope really can be of great help, especially in epidermoids, because I saw your cases, but I know several cases where it just moves to the opposite side from the cistern. So it's fully in front of the pons and then moves to the other side, and the endoscope can help. The same as you say, sometimes it goes underneath the temporal lobe. So it is not the solution, but it's the visualization that is of great help. I agree with Miguel that the sitting position is advantageous. In the Netherlands, unfortunately, the Society of Anesthesiologists declared that sitting position is way too dangerous, so they advised their members not to do any surgeries in sitting position. So I had to be comfortable with the supine and the lateral park bench. And the same, but I have to say that to the previous talk also from Andres Servio, that is maybe the same remark to you now, Mauro. If you use an endoscope, it's not that easy. I saw that, I like that little image that Andres was showing, how he used the Holder system with the brain. And I mean, that's another neurosurgeon. That's so important because other Holder systems that we have, or sometimes even computerized, pneumatic, robotic, they are simply not useful for this because you need to have this movement in and out. You have to be in, this is, I'll tell my resident, it's like learning to dance with each other. The beginning, when you start dancing, you step on each other's feet. You have to be, it has to look smooth. It has to look like this is in concert. And I tell them in endoscopy, make sure that your instrument is always in front of the endoscope. So the moment you see an image and the instrument is taken back, it's not the instrument that you have to try to get back into the field. You have to take the endoscope out until you see the instrument again. Because this is absolutely what Miguel and Ramesh were saying. There is no rear mirror. So that's the danger. It's a learning curve. It's not so easy to do that. And if you do microscopic and endoscopic, trying to do that at the same time, looking to one image and another image, looking through the microscope, it's not absolutely natural. And in this first learning period, you can do harm. So be very careful and train this properly in a lab before you apply it in clinical practice.
Thank you.
Epidermoids, it's an amazing part, and yes, they are. Even if you leave remnants, well, you know that if you leave remnants with epidermoid, you leave something for your successor, because usually it takes 30 years to become a problem again, and they will remind your trainees, oh, there was something that he left behind. Because I did quite some epidermoids that were operated in the 70s and 80s. And then I had to do it indeed 30 years later again, when it was steadily growing. It's slowly, but I fully agree, don't damage and take care of it. Make sure that there will the patient don't want to see the surgical video. They want to have the result of your surgery. And that's number one. They want to be cured. They want to wake up without pain. They want to wake up to know that they are in good shape. Miguel was saying this, and Ramesh also. These are more or less otherwise healthy people. They don't have cancer. They don't have any other severe problem. And they want, that's our concern as neurosurgeons. And what I saw in this, I have to say, Naren, amazing talks, amazing lectures. I absolutely enjoyed that. I had to leave for 1 hour this afternoon after my chairing my own session, but happy that I returned to listen to these talks. Thank you very much.
Thanks very much. Any further comments? Dr. Segura, you want to make some comment or no?
No, I completely agree, Professor Rice, Nair, and Andre. Well, this is just our opinion and based in the last 20 years of experience, but learning from most of you. And I would like to see you next time and maybe to share this information and maybe to share the data and make an interesting paper. Thank you very much.
Thank you. Thank you very much. I think unless anyone's got Andres Servios, unless you want to make a point, I think we will be wrapping up. Andres? No.
Thank you very much again for the invitation. I completely agree with Professor Andre Gotten. I agree with all his opinions. It's important to remember that those patients in microvascular decompression are healthy people. I mean, they have a very big problem, facial spasms, neuralgia trigeminal, but it's like the same when you have a lumbar spinal stenosis or lumbar disc. It's a problem for the patient, but it's not, maybe it's a big problem for the patient. But always remember, like like a surgeon, we can make the patient to be worse. So it's necessary to have this in mind always before surgery. Thank you very much.
Thank you. Thank you, Miguel, for co-chairing. And I thank Naren for this invitation. And it's a fantastic meeting today. Naren, you want to finally conclude?
Sure. Thank you very much, Mr. Nair. That was fantastic. And Professor Ares, fantastic chairing and fabulous presentations. I have to say, I was expecting them to be fabulous, and they were. And we really had an amazing day. I mean, this is me not being subjective or biased, but, we really had a fantastic start. Then lecture on subarachnoid hemorrhage, then giants in spine, and then this, feast of skull-base surgery with, eminent chairs. So, I couldn't thank more to all of them, all of you all. Tomorrow we have another fabulous day, if I may say so. The morning session starts at 11 o'clock, and it's a session with skull base, vascular, and spine. It's a mixed one, and that's from 11 o'clock to 12:45. Mr. Daniel Walsh from King's, and I hope Professor Grottenhuis, I'm going to send him an invitation to chair that session. Then we have two world-class symposiums. One is the first one is on on neurotrauma. This is a joint symposium with what used to be the last previous WFNS neurotrauma committee. Before that just changed, and it's like fabulous lectures. I couldn't I can't recommend it more. And then we have a pediatric session from 4 o'clock to 6 o'clock. It's on it will apply to everyone because it's on how to improve outcomes. So it's not on pediatric neurosurgery in terms of pathology, it's on how to improve outcomes. And we have got 8 speakers from around the world who are leaders in the field. So thank you very much, and wishing you all a great late evening, midday, and look forward to meeting you all. In the chat box, I have put the link to the form for certificate. If you put the form, if you put your name and email address, I will then send you a template in this week or next week. Then you can put how many hours that you have. You can put your name and how many hours that you have been in the conference. So that way you can, certainly in my hospital, every hour I spend in any conference, they take it as 1 CME, and I can self-certify. Second one is the recording of all of this is already on YouTube. So you can always look back at it. So thank you very much and see you tomorrow. Bye for now.
Thank you.
Thank you. Thank you.
Naren, I will not be there. I have AC
No,
meeting with the World
no,
Federation.
no problem. Your spirit will be here.
In the morning, it's a board meeting of the ENS and the
No,
afternoon AC meeting of the WFNS.
No problem at all.
Fortunately.
We'll miss you, but thank you very much. Cheers.
Okay,
All the
you're
best
welcome.
tomorrow.
You're
Thank you.
welcome. It was a great day.
Thank you. Bye. Thank you
Great
very
to
much.
meet you all.
See you.